హలో వినొస్తలేదయ్యా
మీరు మాట్లాడండి
సార్.
హలో
సార్ సార్ మీది వీడియో కూడా రావాలి సార్.
వీడియో
అదే అదే వీడియో
అదే చూడండి సార్, మీరు లాగిన్ అయినరు, నేను ఇంకొకసారితో మాట్లాడతాను.
నౌ
వచ్చారు సార్, వచ్చారు సార్.
ఓకే ఓకే థ్యాంక్ యూ
సార్. ప్లీజ్ లాగిన్ సార్.
అది కూడా వస్తలేదు. ఈ సౌండ్ వస్తలేదు, ఆయన మాట్లాడుతున్నారు. సౌండ్ వస్తలేదు,
సౌండ్ వస్తలేదు.
వాళ్ళు మాట్లాడుతున్నారు. హలో
అక్కడ మ్యూట్ చేసినట్టున్నారు సార్.
అంతేనా?
ఒకసారి మాట్లాడండి.
హలో హలో
హలో సార్.
ఎస్
బానే ఉంది సార్, బానే ఉంది సార్.
ఓకే
సార్ అయితే అది బిజినెస్ సార్, అది హాల్ బి లో లాగిన్ అయినారు సార్. ఈస్ కమింగ్ బ్యాక్. ఆయన రాగానే స్టార్ట్ చేసేద్దాం సార్.
ఓకే ఓకే. సో యూ విల్ బి గివింగ్ ఇంట్రొడక్టరీ వర్డ్స్ నో.
I'll just welcome all the delegates, that's all.
Yes, sir.
And then sessions will start on antan sir.
Okay.
Anna tarata Venkatrajay sir will introduce the first session annappudu meer maatladesi ammayini pilvandi sir. She is online, Tejasvi.
Okay okay, yes.
నేను జస్ట్ వెల్కమ్ చెప్పేకి మిమ్మల్ని పిలుస్తాను సార్. దెన్ యు స్టార్ట్.
మొదట ప్రేయర్ అయినాకనే వెల్కమ్ చెప్పండి.
అయితే నేను మీకే చెప్తాను సార్. అదే ఓకే సార్. వెల్కమ్ చెప్పేసి విల్ గో ఫర్ ద ప్రేయర్ సాంగ్ అంటాం సార్. మీకు ఇచ్చేస్తాను, ఓవర్ టు యూ అంటారు సార్.
ఓకే ఓకే. yes.
Good morning to everybody. Dr. Chandrasekhar, am I audible?
Yes madam, you are very much audible madam.
Okay, thank you.
Thank you madam.
Thank you for everything.
Madam Bijin, we are waiting for the Bijin Oliver John to join madam. Sir mistakenly joined in the hall B, so we are requesting again to join in hall A.
ఇది అతని బయట వస్తుందా బయట
ఎక్కడ ఉంది?
దాని కింద
ఒక్క నిమిషం ఇందులో ఉందా? మీ చంద్రశేఖర్ దాంట్లో లేదు సార్. దీంట్లో సేవ్ కాంటాక్ట్
ఓవరాల్ గా చెప్పచ్చు.
ఇవ్వండి సార్, బయట ఇవ్వండి.
ఆఫ్ అలివర్ బిజిన్ ఆలివర్ జాన్ నేను రాసుకుంటే
బిజిన్ ఆలివర్ జాన్
చాలు. ఇదే అనేది ఓవరాల్ చెప్తారు. వెళ్తురు రావచ్చు ఏం కదా.
ఇక్కడ వేలు తీయండి సార్, ఈ వేలు తీయండి, ఈ వేలు తీసేయండి, అట్లా పట్టుకోండి, కొంచెం కింది కనిపెట్టండి.
ఎక్కేనా
ఇది
వస్తుందా ఇప్పుడు?
వస్తుంది.
ఇక్కడ పెట్టి చూడాలి మరి.
చూస్తారా మళ్ళీ
అది 18th కూడా బి చంద్రశేఖర్ 18th మీద బ్లూజ్ ఉంటుంది జెరికాన్, అది ఓపెన్ చేస్తే 18th
8:15
కాదు
PDF ఫైల్ అంటారా? ఇంతకుముందు చూసింది అదే కదా బాబు చెప్పి.
ఇది
18th యాన్యువల్.
హలో హలో
sir, Venkatraj sir, just a minute sir, just waiting to
అదే
log in.
విజన్ ఆలివర్ జాన్
Vision sorry, just waiting for the Vision sir to join.
yes తేజస్వి is రెడీ కదా?
Tejas is ready sir.
yes సో ఫస్ట్ మీరు ప్రేయర్ అనేది చెప్పండి తేజస్వి, అయినాకనే మీరు వెల్కమ్ వర్డ్ చెప్పండి, తర్వాత నేను చెప్తాను. వెల్కమ్ వర్డ్ నేను చెప్పుకోవాలని చెప్తాను.
So this F6756 they will be. So which in the tracks is. So F67564. ఎందుకంటే ఇవన్నీ అక్కడ
అదైందా? మొదలైందా? అది మొదలైందా?
మొదలైతుంది.
మిగతా మ్యూట్ చేసేసి కానీ మళ్ళీ వెంకట్రాజ్ చేస్తారు. సార్ గుడ్ మార్నింగ్ సార్, విజన్ సార్. I think he has gone.
Good morning, sir.
Good morning, sir. Sir, we are waiting to log in you, sir. I am sorry for the initial this thing.
Yes.
Sir,
sorry on my part also.
No, not a problem, sir. We will start with the prayer song, sir, first. So then our chairperson will give the introductory remarks and then we'll go ahead, sir. Sir Venkataraja sir.
Yes, I am
So
ready.
we'll start with prayer. Tejasvi.
Yes.
Yes, sir.
Yes.
Yeah, Tejasvi, please.
गणनायकं भावय गणनायकं भावय हे मानस गणनायकं भावय प्रणवस्वरूपं पापनाशं पशुपतिनिलयं प्रथमपूजितं गणनायकं भावय
Yes.
करुणाशीलं काञ्चनचेलं कमनीयकर विराजितपालं मूषिकवाहं मोदकहस्तं शेषधरं शैवाब्धिचन्द्रं गणनायकं भावय श्रीशारदा सुरसेविता त्वमेव मम शरणं श्रीशारदा
రెడీ
श्रीशृङ्गगिरिवासिनी
ఉన్నాను.
वाणी प्रणवरूपिणी श्री शारदा सामगान विलोलिनी निगमागम विहारिणी प्रेम स्वरूपिणी विद्यादायिनी कोमलांगी वर वीणा पाणी रागमोहिनी रस विनोदिनी हंसवाहिनी ज्ञानदायिनी वाङ्मयरूपिणी भारती चन्दोवासिनी सरस्वती श्री शारदा. Thank you.
That's okay. That's good. We have begun with a prayer. Sir, over to you, Dr. Venkataraja, sir. He is the professor of medicine from Kakatiya Medical College. He is my teacher. And now he is working as a professor of medicine in Chelmeda Anandarao Medical Sciences. Sir, over to you, Venkataraja, sir.
Okay, thank
to
you.
introduce the first speaker and introductory remarks for Bijin John, Oliver John, sir.
Okay. Good morning. On behalf of organizing team of GERICON 2021, under the chairmanship of Dr. Y.S.N. Raju and Dr. V. Chandrasekhar as secretary, without their efforts, this conference would not have taken shape. I heartily welcome all of you, the speakers, chairperson, and delegates, to the wonderful platform of GERICON 2021 from MGM Hospital, Medicine Department. So this is a historical place, and once again I welcome. So without any wastage of time, now let us enter into the scientific session. The scientific session is now declared open. The first session is on the neurology department, the section of the geriatric, what we call as a geriatric neurology. And the first chapter is delirium and its recognition and treatment by speaker Dr. Bijin Oliver John. Really, he has the unique future of getting postgraduate degree in geriatric medicine. This is one of the unique feature of Dr. Bijin Oliver John. He worked as assistant professor of medicine in the same department from 2015 to 19. From 2019 onwards, he is working as assistant professor. He is joint secretary of Indian Academy of Geriatrics and is the state trainer for elderly. He has presented many papers in the national, international conferences, and he is very much involved in the training of undergraduates and postgraduates students. Presented papers in the national, already told. He was the panelist in the national conference held in Kota in 2018, and he was awarded record of achievement in WHO course by health aging for and its impact in the 21st century in December 2020. He received Best Doctor Award with Certificate of Honor for the year 2021 from the Dean of the present institution, that is working in CMC Vellore, Government Medical College Vellore, for the services towards the care of elderly people. Sir, I welcome Bijan John for your expert lecture on this thing. He looks very young and energetic, but his expertise is on the delivering healthcare service to the elderly. That is very, very appreciable. That is a good attitude of the younger doctors. Sir, I really appreciate your services to elderly. Over to you, sir. So, coming to the subject as an introduction, delirium is one of the common problem in the geriatric people. And geriatric people are at the higher risk of developing delirium by their multiple diseases, especially all what we call as a geriatric eyes or geriatric giants, what we call, like instability, iatrogenesis, immobility, incontinence. So they are more proliferate. And the incidence in institutions, especially ICU, varies from 40 to 79%. But most of the time, this is unrecognized or under-recognized. So early recognition, it may be a reversible thing, but if we delay the diagnosis, it may have negative consequences. So to avoid these, let us invite Dr. Bijan John to deliver his next. Over to Dr. Bijan John.
Thank you very much, sir, for your kind words of appreciation. So I thank all the organizers for giving me this opportunity to inviting me as a faculty to deliver this talk on delirium and elderly. Can I share my screen? Am I audible?
Yes, sir. You can share your screen, sir.
Am I audible? Yeah.
Yes, sir. You are very much audible, sir. You can share your screen and start presenting yourself.
Is my screen visible?
Just a minute, sir. No, it is coming. Yes, sir. It is visible, sir.
Okay.
Yes, sir. Visible, sir.
So I like to. Okay, sir.
Yes,
First
sir,
of all, I'd like to
visible.
thank Almighty God for giving me this opportunity to share, and especially my special wishes or thanks to my beloved seniors and teachers, Dr. V.S. Natarajan sir, Professor Krishna Swami sir, Dr. Shanti ma'am, Dr. Shivakumar sir, and Dr. Usha ma'am, for they have been an inspiration to me over the past years. I'm also privileged to see Dr. Raju sir here, who was my external exam during my postgraduate examination. So definitely it's a great audience, and so honor for me to give this lecture. So this is my geriatric unit team from Vellore Medical College. So we had this institution of the decade of healthy aging last year, the WHO initiative. So before we had a small program, and we bring tidings, we bring wishes from government Vellore Medical College geriatric unit. Now, I'm going to touch upon the following: the introduction, the diagnostic criteria, the pathology, the predisposing factors and precipitating factors, the medications associated with delirium, the clinical spectrum, assessment scales, and the treatment options. As Venkatraj sir rightly told about the eyes, the immobility, instability, incontinence, hydrogenation, inanition, and of the intellect. So this intellect issues involves dementia, delirium, and depression, the 3 Ds, the most important factors or diseases affecting the neurological system. So we'll discuss more about delirium and also touch upon a little bit of dementia also. So now come the introduction. the definition is delirium is an acute confusional sorry for spelling confusion state characterized by an alteration of consciousness with its ability to focus, sustain, or shift attention. So delirium affects as many as half of all people over age 65 who are hospitalized. So it was synonymous with the acute confusional state. So now coming to this DSM-5 diagnostic criteria, that is the Diagnostic and Statistical Manual of Mental Disorders, 2013, is the current diagnostic standard. These criteria are based on the following. So A is the disturbance in attention and awareness, then it's acute onset and fluctuating course, then additional deficit in cognition, such as memory, orientation, language, or visual perceptual ability. The impairments not better explained by dementia and do not occur in context of severely impaired level of consciousness or coma. And finally, the evidence of an underlying medical etiology or medical etiology. So this is the diagnostic criteria that has been followed from 2013. So coming to pathophysiology, so it is probably it's a combination of many factors like multiple brain involvement, neurotransmitter systems, etc. So there have been studies or EEGs and neuroimaging. They probably indicate there is some dysfunction in the cortex, thalamus, basal ganglia, etc. And also there have been other PET studies also done. But so associated neurotransmitter abnormalities involve elevated brain dopaminergic function and reduced cholinergic function. So these are the two neurotransmitters most commonly involved, and then bit of serotonergic activity also. Now, I'll just touch upon this newer topic of healthy aging, probably 1 or 2 slides, so that also plays a role in how you manage or how you approach a patient with delirium. Now, what is healthy aging? So this WHO as a started this WHO initiative is a decade of healthy aging from 2021 to 2030. So this following ensuring 10 years probably indicate the decade of healthy aging. So what is healthy aging? It's a process of developing and maintaining the functional ability that enables well-being in older age. So what determines the well-being in an elderly is the functional ability. The patient should be functionally active. So now what is this functional ability? Is the health-related attributes that enable people to be and to do what they have reason to value. So these two things, to be and to do. So being and doing, these two attributes are very, very, very important that characterize this functional ability. And it is made up of intrinsic capacity of the individual and the relevant environmental characteristics and interaction between these individual and characteristics. So functional ability depends on this intrinsic capacity and environment. So what is intrinsic capacity? The composite of all the physical and mental capacities of an individual. So both the physical aspect and the mental aspect. As we all know, the definition of health, it's a complete state of physical, mental, and social well-being, right? So all these dimensions are involved. And what is environments? It comprises of factors in the extrinsic world that form the context of an individual's life. So micro level to macro level, when it is a home, your communities, and the broader society. And range of factors, the environment, people, their attitudes, systems that support them, they all formulate the environments. These all determine the health and well-being of a elderly person. And when, as I told, the definition about well-being, it indicates the happiness, satisfaction, and fulfillment. So one last slide about this functional ability. So what do domains of functional ability? I told health involves functional ability. So the elderly are able to meet their basic needs. Number 2, they're able to learn, grow, and make decisions. Number 3, they be mobile. Number 4, build and maintain relationships. And number 5, contribute. They are also have their contribution to their family and also to the society. So these all are the factors that determine the normal functionality or functioning of a elderly person, and these have to be addressed when you probably see a patient with a cognitive impairment. Now coming to the topic per se, so probably we need to understand 2 important things. One is for delirium, that is the predisposing factors and precipitating factors. So the predisposing factors, they relate to the vulnerability of a individual, of the elderly patient, whereas precipitating factors, they probably that external internal insults that occur newly. So now what are the predisposing factors? What are the triggers or the inbuilt factors that predispose to delirium? So one is the dementia or underlying cognitive impairment. So the underlying patient with the pre-morbid coexisting dementia are more likely to present with delirium. And any severe illness, the long-standing illness, then in comorbidities. As we all know, elderly are characterized by multimorbidity. So they are present multiple presentations and atypical presentations. So comorbidity is one of the important factors. Then depression, then vision impairment or hearing impairment. Then come to functional impairment. So as I touched upon the functional ability, so if the functional ability is affected, the cause of functional impairment can also predispose to delirium. Then there is history of any transient ischemia or stroke, and history of alcohol abuse. Then already pre-existing of delirium and advanced age, more than 70. So this history of delirium, yeah, probably this I can just relate to my own personal experience. My own father, actually, he's 70 now. So the past 3 years, he's having on and off delirium when he gets fever. So probably 2019, he was diagnosed with severe dengue, and he presented with febrile delirium. So just a fever, just amount of temperature crosses 100, immediately he becomes delirious. So febrile delirium due to severe dengue. He had hospitalized for 10 days and he became well. Similarly, this year he had an attack of influenza A. So there also fever predisposed to delirium. Even my mom was affected with influenza, but she never presented with delirium. So this presentation of delirium can manifest a vary according to person and depending upon their body condition or their functional system. So it will vary. So it doesn't mean that all the patients, all elderly patients above 70 can present with delirium with underlying issues, but it can vary. So these are some important predisposing factors. One, history of delirium probably can predispose to delirium the subsequent dates. Next, come to the precipitating factors, which I told about the insults that occur. So, for example, drugs like polypharmacy, psychoactive. Then, so as you all know, polypharmacy is one of the important another geriatric syndrome in an elderly. So they present a lot of medication, 10 to 12 medications. So that's an important thing causing delirium due to this drug interactions and adverse drug reactions, etc. The use of physical restraints. So normally any individual doesn't they don't probably love dependence. They want to be independent. So now causing an elderly, they are forced to be introduced certain restraints, but this actually they precipitate delirium. Then indwelling bladder catheters due to long period. Then any dehydration, severe dehydration can precipitate delirium. Then poor nutrition. Then abnormal serum albumin. Then iatrogenic complications. The major surgical procedures like aortic aneurysm and neurosurgery, even hip surgeries also. Then metabolic derangements like electrolytes, disorder of electrolytemia, hypoglycemia, metabolic acidosis, etc. Then history of trauma and also coma. So these are some of the things that can precipitate delirium. We call acute encephalopathy, some terms like that, acute metabolic encephalopathy, hepatic encephalopathy, etc. So, but we as an elderly term we use acute confusional state. That's the terminology we use. It's the same repetition of predisposing factors versus precipitating factors. So, as I told, predisposing factor relates to the vulnerability which inbuilt older patient has, whereas precipitating factors is the newer insults that affect the elderly. Now, as I already mentioned about the medicines, there are certain medicines that can associate with cognitive impairment and delirium. So, there's something called Bayes criteria, Bayes list. Probably they relate to the usage of inappropriate medications and also due to adverse drug interactions and drug-drug interaction, etc. So, this is something. So, some important drugs causing tricyclic antidepressants, anticholinergics, benzodiazepines, chlorpromazine, corticosteroids, H receptor antagonists, meperidine, sedatives, thyroidazine, zolpidem, antipsychotics. Some of the important. There are a lot of drugs. There are fewer drugs that can cause or associated with cognitive impairment. Now coming to the clinical spectrum. So the clinical presentation of delirium can take two main forms, either hypoactive or hyperactive. So normally we term like delirium or aggressive, delirious behavior, but we need to understand that hypoactive is the most common form of delirium, schedule lethargy and reduced psychomotor functioning. So maybe we may not realize why this patient, why this old man is silent, not responding. He just remains alone. So we need to just interact and also probably evaluate for that also. So it goes unrecognized and carries an overall poorer prognosis. Whereas hyperactive form of delirium, they present with symptoms of agitation, increased vigilance, and concomitant hallucinations. So that is easy. We can diagnose clinically. So some patients can fluctuate between hypoactive and hyperactive forms. That's the mixed type of delirium. Now there are the assessment scales that can be used. The most commonly used the CCAM. CAM nothing but confusion assessment method. So it has been adopted in our normal ward settings in a hospital. We use that. Some variants can be used in ICU, CAM, ICU, the nursing home, then ED, CAM, ED, etc. So, but more this other scales include the DRS, the delirium rating scale 98, the memorial delirium assessment scale MDAS, and the delirium index. So each instrument has strengths and limitations, and the choice among them depends on the goals for use. But still, the CAM, the plain CAM, is used and has good sensitivity and specificity. So these are scales on the left. CAM confusion method. It's a 4-item scale ABCD. A is acute onset and fluctuating course. B is inattention. C is disorganized thinking, and D is altered level of consciousness. So coming to A, the evidence of an acute change in the mental status from the patient's baseline. Does the abnormal behavior come and go, fluctuate during the day, increase or decrease severity? So you get a history. So how long it has started? Is it acute? Then how it is fluctuating? You should have the history. Then inattention. Does the patient have difficulty focusing attention? You can ask some questions, or probably numerical problems with other patient able to follow it. So inattention. Then disorganized thinking. Is the patient thinking disorganized or incoherent? And fourth is altered level of consciousness. Is the patient alert or vigilant or lethargic or stuporous or comatose? Out of this, so the A and B should be there. There is acute on fluctuating course and inattention, plus either C or D. So only then we can say that is CAM positive and patient is delirious. Now coming to this mini mental status examination, MMSC that's meant for this cognitive impairment or dementia. It's a 30-item scale, the Falstein. So 30, if it is 20 till 24, it is normal. Less than 24, there is cognitive impairment. So this was mainly for dementia. Now, what are the investigations? So probably always treat the cause. So as I mentioned, the predisposing precipitating causes. So those causes have to be investigated. So any case of delirium has to be managed with a complete blood count, the blood sugar, renal liver function test, urine analysis, oxygen saturation. So all can precipitate delirium and such occult infection, etc. Then also the thyroid function test, B12 level, then toxicology, syphilis, ammonia, all this can be evaluated. Then electrocardiogram, chest radiography, ABG, then CSF if required, the EEG, they're all controversial, but if required, it can be used. Suppose the patient is suspecting with meningitis or with febrile delirium, then we can go ahead with the CSF after doing a CT or MRI and rule out in ICT. Now this is about differentiating the other DDs for the delirium. So when I told the 3 Ds are very common in elderly, that's a delirium, dementia, and depression. So how probably we just compare these along with acute psychosis. The delirium and psychosis are acute, and dementia is progressive, and depression is acute or insidious. Then delirium is waxing and waning type. Then its attention is impaired as it told, whereas dementia is intact. The level of consciousness is altered in delirium, it's normal in dementia. The memory is impaired in delirium. Then its orientation is disoriented. So we all discussed. So we should have an idea. So proper history and examination will definitely give a clue about how we are going forward. And as I told, definitely this pre-existing dementia or cognitive impairment is one of the important risk factors for the delirium. Under the treatment aspect, so always better we start with non-pharmacological methods and followed by pharmacological. That's always dictum in elderly. Start low and go slow. So probably the realization interventions. For example, always either with delirium or dementia, the proper family support, psychological support, that's more very important. So and any problems, suppose any agitated patient, move them to a private room, and probably you have to do it accordingly. So there's something called orientation protocols in delirium. Just avoid this calendars, clocks, schedule should be properly displayed along with familiar personal objects from the patient's home environment, probably which they can relate to. Their photographs, childhood photographs, family photographs, which they like, or they are spiritually oriented, like the religious things can be along with it, so that they feel familiar, they don't feel left out, they are not alone, they feel they are taken care of. They shouldn't be isolated. Already, elderly patients have this loneliness and isolation invariably. So, but here, so we need to take steps. So, as I told initially about the healthy aging, the functional ability, agency capacity. So, we need to address those issues so that they are able to maintain their healthy well-being. So, they are they kept happy. The personal contact and communication are critical to reinforce patient awareness and encourage patient participation as much as possible. Then, frequent eye contact, clear instructions, repeated reorientation strategies. Maybe we may not able to convince them the first visit or first probably contact. So we need to have repeated orientations are required. Then correction of sensory impairments. I told vision impairment, hearing impairment is one of the important predisposing factors. So they should be addressed to proper ophthalmic checkup and ENT workup. Then mobility and independence should be promoted. As I told, physical restraints is one of the important precipitating factor. So we need to make sure the patient becomes the mobility and the independence is being addressed upon. And also changes may need to hospital-wide changes. We may need to ensure a lower level of noise at night, including minimizing halfway noise, overhead, and staff conversation. So noise is one of the important triggers. So what this slide indicates is, in summary, that whatever triggers the delirium in an elderly patient, or they cause them uncomfortable, then probably cause a dysrhythm, has to be addressed and taken care that they are avoided. That is a great step that can really cut upon these symptoms. And coming to the pharmacological agents, so antipsychotics are the preferred agents of treatment, with haloperidol being the most effective agent start from a low dose. Next, come to the benzodiazepines are not recommended as first-line agents. So in the treatment of delirium, the increased propensity to cause oversedation and exacerbate acute mental status changes. However, they remain the treatment of choice for delirium, cause seizures, and medication-related withdrawal symptoms. So the study was done in 2011, published in Age and Aging, where it's with opioids, benzodiazepines, dihydropyridines, possibly antihistaminics. So we need to make sure that we need to give the right drug at the right time. And some other drugs that can be used are like the delirium evaluation they use as resulted in. We're not sure that will include the neuroatypical antipsychotic agents such as then procholinergic agents, serotonin antagonists, alpha-2 agonists, and sedatives like dexmedetomidine. So the atypical antipsychotic drugs like risperidone, olanzapine, quetiapine have the potential for fewer sedative and extrapyramidal effects. So there is some evidence, however, that treatment with antipsychotic drugs may prolong delirium and result in poor clinical outcomes. Thus, the current recommendation is that their use be restricted to patients with severe agitations that pose threat to their safety. So, yeah, even we do clinical practice before quetiapine and all we do. As far as possible, try to manage with non-methods rather than before starting a drug anything, because each drug has its own side effects. Now, there was a study which we did in MSc in 2009 when I was doing my post graduation under the mentorship of Swami sir. So we did a study of delirium. We selected 100 patients and 50 males and 50 females. So out of the overall was 12% incidence of delirium among this 100 patients, and if males was 6% and females was 18%. We concluded that the factors we looked upon was anemia and elevated total count and also cognitive impairment. We found that the preoperative anemia and elevated leukocyte count were found to be associated with increased incidence of delirium and were statistically significant. And the focus of the study was to evaluate baseline vulnerability characteristics that could be helpful in identifying patients for developing post-operative delirium. And this is another we saw its administration of olanzapine to prevent post-operative delirium joint replacement patients. So randomized the incidence of delirium is lower in the olanzapine group than in the placebo group. So advanced age, a high level of medical comorbidity, and abnormal albumin level and knee replacement surgery were independent risk factors for post-operative delirium. This was inference from this study. Another study regarding the use of aripiprazole, so the psychomotor agitation and hyperactive delirium in COVID-19 patients treated with aripiprazole. So the aripiprazole injection rapidly and significantly reduced signs and symptoms of delirium, psychomotor agitations as mentioned using the ICTS checklist. So this is another initiative in our Tamil Nadu state is to implement this cognitive rehabilitation daycare centers. So probably to address people with cognitive impairment, so make them active, they keep them occupied, bring the patients in the morning and in the room, so they can be involved in activities, recreation, etc. And they are taken back. Funding an initiative by the present government, and it has been really probably it will useful for many of the elderly patients in the coming days. So to summarize, so delirium is commonly encountered in older adults in various clinical settings and associated with significant morbidity and mortality, especially in intensive care units, inpatient settings, nursing homes, and following major medical illness or surgery. The pathophysiology of delirium is currently unclear, but possibly to the end result of multiple pathogenic pathways eventually culminating in the dysfunction of various neurotransmitters. Delirium is commonly due to multiple causes, and most effective treatment strategy is to identify and address as many predisposing and precipitating factors as possible. So acute onset, varying levels of alertness, and inattention are cardinal features of delirium. So lethargy and reduced psychomotor functioning are common presentations of delirium in older patients, in contrast to the hyperactive form more common in younger patients. CAM scale is widely used for assessing delirium. Non-pharmacologic strategies are the preferred treatment of delirium in older patients, and medication are reserved for more severe symptoms. Thank you. So just in this slide, aging is not lost youth, but new stage of opportunity and strength. So I once again thank the organizers for this opportunity.
Thank you much, sir, for your excellent, crystal clear talk on the acute confusional state. Okay. So any questions on the chat box?
No, just one comment, sir. Venkataraja, sir, good morning.
Good morning, sir. Yes,
and Dr. Bijin, you did an excellent job, because one of the most challenging condition in elderly treatment is delirium.
Yes.
Because of the multifactorial causation and difficulty to manage. You did an excellent job. Thank you very much for kickstarting on an excellent topic.
Thank you, sir. Thank you so much.
Any questions? Any questions?
Any questions in the chat box?
So as of now, there are no questions, sir, in the chat box. So
Okay.
from the delegates also, we are requesting to ask any questions. So
yes.
that will come to our chat box, sir. So whenever we are coming, I'll read out, sir.
Okay, that will be.
Yes,
So
sir.
it is
Good
wonderful
morning,
talk,
Chandrasekhar, sir.
Sir. Good morning, sir. Sir.
We'll just go to the next topic.
Okay, definitely.
Yes, sir.
Thank you.
So
once again, thank you.
Okay. I invite Dr. Nalin Chaudhary, sir, to invite the next speaker, Dr. Matthew Varghese, sir. He is the president, IAG. Over to you, Nalin, sir.
Thank you very much. Good morning to everybody. It's a rare opportunity to chair a session in the Indian Geriatric Society, and it is all the organization secretaries' efforts which has come to this conclusion, a well organized the conference virtual form. Dr. Chandrasekhar has been a veteran in presenting the seminars since last 2 years during the COVID days, but we have got the opportunity now to chair a session. It's a pleasant task to introduce Dr. Matthew Varghese, who is a senior professor of psychiatry and retired faculty from NIMHANS, Bangalore, currently adjunct professor, St. John's Medical College, Bangalore. He headed the Department of Psychiatry and Geriatric Psychiatry. He had clinical services, training, teaching in adult geriatric, family and community psychiatry, member of research groups and professional societies, including the WHO. He has over 150 publications, also National Mental Health Survey, and a part of Dementia India Report 2010, Dementia in India 2022. Now, he has many feathers in his cap, but today the topic for him is the behavioral spectrum in dementia. Now, this is a very interesting topic because most of the time as a neurologist, we are asked about only the cognitive decline in dementia. But the fact is that the dementia is not a unifaceted illness. It has multifaceted dimension, and the loss of cognition with behavioral disturbance, they go hand in hand. The initial researchers in dementia, it is known to us since more than 120 years, when Pick was the first person who described the dementia. The focus of the research has been on the cognitive part only and less on the behavioral part. So in today's context, the behavioral and the aspect on dementia is a very, very appropriate subject. Behavioral changes do occur in dementia in early stage, in middle stage, and late stage also. But the common cause of dementia, the Alzheimer's disease, this appears in the first two phases, but as the cognition declines, the behavioral disturbances also decline with that. The major topics in this behavioral aspect will be aggression, and later on it goes down with decline in cognitive function. Dr. Matthew Varghese, I welcome you and for the excellent talk in this conference. Thank you. Dr. Matthew Varghese, please.
Thank you very much to the organizers. Are you able to hear me?
Yes.
Yes, sir, we're able to hear you.
I'm just trying to share my screen.
Yes, sir, your screen is visible.
Is it on slideshow?
Not yet, sir.
No, not yet, sir.
Yes, sir, now.
No, not yet.
Not yet, yeah.
Right, now I think it's
Yes.
Okay, I would like to thank the organizers of GERICON 2021 for having called me to speak at your conference. I was very happy to speak at the earlier conference in 2019 at CMC Vellore, and I must especially thank Dr. Shanti, who called me up and asked me to speak today. And it's good. Good morning to all of you, and it's good to see a lot of familiar faces like Dr. Prasad Matthew and Dr. Vengamma. So, good morning and greetings from Bangalore in India. So, I want to speak today about behavioral and psychological symptoms of dementia, and I'll be covering various aspects of BPSD and also talk about the management. Now, I'm fond of saying that the clinical presentation of dementia, for a clinician, you need to be wary of the ABC symptoms. The A is basically activities of daily living, which is the instrumental and the basic activities of daily living. B is the behavioral symptoms that we are going to discuss today. And C is the cognitive symptoms, which everybody knows, which is basically memory and other mental functions. Now, BPSD, there are many definitions of BPSD, and the various synonyms are neuropsychiatric syndromes of dementia, non-cognitive symptoms of dementia. But now what is accepted is that we all follow the International Psychogeriatric Association definition, which says that BPSD are symptoms of disturbed perception, thought content, mood, or behavior that frequently occurs in patients with dementia. The other definition by Finkel is that it's a heterogeneous range of psychological reactions, psychiatric symptoms and behaviors occurring in people with dementia of any etiology, and or non-cognitive neuropsychiatric symptoms occurring associated with dementia. Now, BPSD can occur up to 2 years preceding the dementing illness. Sometimes it can present as apathy or depression, and where it might be mistaken. And it can present anytime into the illness of dementia. Now, the importance of behavioral symptoms is that it is a very much an integral part of the dementing illness. They contribute to a high cost in terms of management. It's usually when they have BPSD that patients and their relatives present to the hospital, because just with memory problems, they may not actually come. BPSD is something that causes you to get hospitalized or institutionalized. And abroad, you'll find people with BPSD going into old age homes and long-term care facilities. And importantly, they exact a high price from both the patient in terms of disability that it causes and the caregiver in terms of the distress that it causes. But the important thing to remember is that it's very much recognizable, understandable, and treatable. Now, if you look at the pattern of behavioral symptoms and really the frequency, about 2/3 of dementia patients would have BPSD in the terms of these researchers, Riesberg and Leikestos. And the common symptoms are delusions, wandering, agitation. They develop quite early in the course of dementia, and wandering and agitation can increase with the duration of illness. High rates of depression, anxiety, and retardation may be seen more in vascular dementia than in Alzheimer's disease. Now, the causes of dementia are multifactorial. Predominantly, they are biological in the sense that there are brain changes which happen because of dementia, and the amines are implicated. So dopamine or norepinephrine are implicated, and could also be because of other medicines that the person takes, other comorbidities, as I will discuss, and also many times because of pain. It might occur also because of psychological factors, because of the personality of the individual, and also because of various life events that have occurred. And it might also occur because of the environmental factors, as many of us have seen during the last 2 years of the COVID pandemic. When elders, especially people with dementia, have been confined to their houses, this has caused BPSD to surface. So lack of stimulation, isolation is something that has brought on BPSD in many of my patients who have been stuck at home. As the symptoms wax and wane, and recent emergence of BPSD should alert you to various factors which you need to look for when you do the assessment. Which one of them is electrolyte imbalances, especially low sodium. You need to look at metabolic disturbances, for example, low sugar, other interactions with other drugs or drug toxicity. I already mentioned lack of inactivity and lack of stimulation. And very commonly infections, for example, chest infections or the urinary tract infection, urinary retention, constipation. Sometimes even what is blamed is even wax in the ear and subdural hematoma. So when you when you see a person who's got BPSD, you must actually, especially if it's a newly emergent BPSD, you must actually look for these conditions instead of just simply going and treating it with medicines or other treatments. Now, there are various scales to assess BPSD. And the most popular ones are the neuropsychiatric inventory by Cummins, which assesses neuropsychiatric symptoms over the last 1 month. The other one is the one by Barry Reesberg, which is called Behave AD, and which assesses symptoms for the past 2 weeks. There are many other instruments which you might recognize, for example, geriatric depression scale or the Cornell scale for depression and dementia, or the apathy scale, or the Cohen-Manfield's agitation inventory. If you look at the neuropsychiatric inventory, which is the most popular, the information is obtained from the caregiver who must have daily contact with the patient in the preceding 1 month. There are 12 domains, and there are different versions of the instrument. You have a standard version, you have a nursing home version, and so on. And each positive response is further explored with the 7 to 8 sub-questions, and you rate them on severity, rating of 0 to 3, and frequency of symptoms from 1 to 4, and the caregiver distress from 0 to 5. Each domain has a maximum score of 12, so you get a total score of 144. And these scores are really used when you do research. But most of the time when you're doing it in the clinic, you just tick off these 12 symptoms as yes or no. And the time taken for the instrument depends on the psychopathology. But usually, if you already interviewed the patient and the relatives, it shouldn't take more than 5 or 10 minutes. The Behave AD, similar to it, assesses, as I mentioned, over the last 2 weeks, the 25 items in 7 subscales, and the items, these seven subscales are basically paranoid and delusional ideas, hallucinations, activity disturbances, aggressiveness, diurnal and rhythm disturbances, affective, this is repeated, anxiety and phobia. So these symptoms are very similar to what is there on the NPI. In a study that we did at NIMANS a few years ago, when we looked at the type of symptoms that we found that the commonest symptoms were apathy, sleep disturbance, irritability, motor symptoms, delusions, appetite, and depression. You can see that these are present in upwards of 60 to 70% of the cases. Of course, in every patient, you might have multiple symptoms, not just 1 or 2 symptoms. What is the effect on the course and prognosis of dementia? Overall, higher BPSD is associated with lower cognition. So as the cognitive faculties come down, you might get more BPSD. Increasing severity, early admission, it causes institutionalization. It causes increased mortality. And of course, it causes increased caregiver burden. When there is a psychotic cluster, especially delusions and hallucinations, it might be an indication of rapid cognitive decline and possibly early mortality. And the agitation severity is again an indicator that things may not be going very well. Now, what about care arrangements as far as BPSD is concerned? As you know, in our country, family members are the main people who take care of people with dementia, usually formal or informal caregivers. Dementia is wasn't usually recognized as an illness, and BPSD was seen by family members and others as willful behavior. They say, this guy is doing it on purpose. He's stubborn, or he's not having a bath, or he's screaming his head off. And they're seen as mental symptoms. So as a result, these patients are stigmatized, these families are stigmatized, and the elders are subject to a lot of neglect and abuse. Of course, the caregivers have very high depression and anxiety, and of course, other kinds of burdens, and more so in nuclear families where there are less number of people to take care of them rather than extended or larger families. Now, in the management of BPSD, you have an algorithm, which is the DATE algorithm. So you describe the symptoms, which is the behavior, when does it occur, what happens, how does it occur, how severe is there depression, is there emotional regulation, and so on. Analyze the symptoms. Can you explain the BPSD? What have you learned about the patient? What are the etiopathogens or comorbid factors? And what treatments would you plan? Can you work on the modifiable factors, as I mentioned? Can you support the caregiver? Can you provide comfort to the patient? Will you give non-pharmacological or pharmacological treatments? So you can see here that the non-pharmacological treatments come first and the pharmacological treatments actually come last. So you shouldn't really provide pharmacological treatment, though many of us as doctors, our quick fix is to give some drugs, antipsychotics or antidepressants, which is something that you shouldn't be doing. And to evaluate later on, is it feasible? Was it effective? What is the sleep quality? What is the quality of life? What has happened to the caregiver stress? And what are the consequences? Now, there are various guidelines to manage BPSD. And so you have the UBC guidelines, this is the British Columbia guidelines. You have the NHS various guidelines. You have the Australian, New Zealand guidelines. And we have our own guidelines, which is the Indian Psychiatric Society clinical practice guidelines for dementia, which are published in 2018 in the Indian Journal of Psychiatry. There are also various sources of support. You have books and pamphlets. I specifically want to refer you to the caregiver booklet that is there, the Alzheimer Association and the UK Alzheimer's Disease International. And also this very good website, which is designed by a caregiver, is called dementiacarenotes.in. And that is something that you can look at for what to do in terms of BPSD. We also trial this iSupport program. This is a WHO program, which is on an online platform consisting of various lessons. This is generally for dementia now. This is available as on the WHO website as handbook or a manual. The online version is not yet available in Indian languages. So this has got a section which covers challenging behaviors. There are 10 lessons on challenging behaviors, and you can see here there are lessons on how to deal with delusion and hallucination, repetitive behavior, walking and getting lost, depression and anxiety, and so on. Despite all this, it is found in a study by White and others in 2017 that the prevalence of BPSD in the nursing homes and in inpatient facilities were upwards of 75%. Aggression, sleep, and activity disturbance were the common symptoms. And unfortunately, medicines were used quite rampantly, 16%, antidepressants, 12%, antipsychotics, 12%, benzodiazepines, sedatives, 3%, and most of them were likely to die as a result of antipsychotics. Non-drug treatments were used only in about a half of patients, of which psychosocial treatments, which should actually be the mainstay of treatment, was used in only about 36% of cases, and restraint, physical restraint, was used in about 22% of patients. So you can see that even now in many of our hospitals, it is usually physical restraint or chemical restraint that is used and not non-drug treatments. So I want to cover some of the non-drug treatments in the next part of my talk. And you have various kinds. There are these 6 different kinds of non-drug treatment, which have all been investigated. There are Cochrane reviews on all of them. And the ones that all of you will be very familiar with are the behavioral treatments and the structured activities and the cognitive treatments. I'll go over some of them briefly. Music therapy is something that you can tell people to use, especially pre-recorded music which has been there for, which elders have heard for a long time. Live music, getting them to sing. Active listening, playing or singing in groups reduces anxiety and agitation, as found by a couple of researchers. And music therapy was effective in reducing behavioral symptoms. There were 6 RCTs and 5 control trials, over 397 patients. And it especially takes care of depression, 4 RCTs and 5 control trials there, and also anxiety. Aromatherapy, this is something that I've not used much, but a lot of my patients' relatives use this. They apply various oils And some oils have shown to improve agitation. Oils plus acupressure or acupuncture might improve agitation or aggression. Aromatherapy and massage or acupressure can improve, can work as an adjunct with exercise and cognitive retraining for agitation. Now, the review by Fung in 2012 recommended it, but the Cochrane review later on by Forrester showed equivocal results, so you could not use it. Bright light therapy is something that's used for, especially for sleep rhythm disturbances. So you use 100 lux light for 1 to 2 hours in the mornings, not in the afternoons, with or without melatonin in the night to improve the night sleep time. You can reduce agitation and improve cognition. There's no improvement in depression in some studies, and the Cochrane review showed that it was not effective for behavior at all. Touch therapy, this is hand massage or expressive touch or massage therapy. It improved BPSD as per a report by Woods in 2002. Massage therapy was significantly associated with improvement in wandering, verbally agitated behavioral symptoms, and physically agitated behavioral symptoms, and resistance to care. So many times when people are resisting to have a bath or change their clothes, you might just want to just hold them or touch them or stroke them. Then this is something that family members avoid doing. So you might tell family members to just hold the person or to just hug the person. Many times family members, because they're so angry with the patient with dementia, they don't really do much of touch. The Cochrane review showed that the 2 trials showed that there's not enough evidence. And then review by O'Neill in 2011 showed that hand massage with or without calming music and expressive touch might improve agitation. The cognitive therapy is again something that we are familiar with. Cognitive rehabilitation. It's seen to help people with mild and moderate Alzheimer's. It definitely assists in doing IADLs with the caregiver, but it also might reduce delusions, but might increase aberrant motor behavior. Cognitive stimulation therapy, which is something that is being practiced now and a lot of training programs are there in India now. The Cochrane review said that there was really no effect, but the other reviews by Alves and Olzeram said that there might be reduction in behavioral and problem behaviors. Other cognitive therapies, reminiscence therapy is something that you can use. Again, you can ask the family members to pull out old albums, or just like you did with music, and show them and talk about it. 2 small studies showed that there were significant improvements in depression, communication, positive mood, and cognition. Validation therapy, which validates the person's situation, might reduce problem behaviors and depression. And simulated presence therapy might also help in BPSD. Behavior management is something that we commonly do. Cochrane review says there is really no effect on BPSD, but in the meta-analysis done with three trials showed that there was some benefit. Functional analysis of specific behaviors, and you might use, as I mentioned earlier on, the ABC paradigm, the antecedents, the behavior, and the consequences. And you might individualize behavioral reinforcement and communication skills training to help with some of these symptoms. Occupational therapy and activities, you have what is called as tailored activity programs, which might help. They improve quality of life and decrease agitation and depression. They might also reduce shadowing or agitation or argumentative or repetitive questioning. Physical exercise, walking alone did not improve BPSD, but walking together with relaxation, stretching, agility, aerobic endurance training. And in our center, we also looked at, in NIMANS, we looked at use of yoga therapy to improve BPSD. Now, what really helps is psychoeducation. There are long-lasting benefits. This is a paper by Livingston, which shows that psychoeducation of the caregivers or the caretakers, they are definitely helped. Specialized care units helped. There are also some therapies using pet therapy. There are people who have used a robotic cat or a soft toy and to see whether agitation might improve. Now, the last part of my talk to talk about the drug management, and I've deliberately put this last because this is something that we should not be using first. All the cholinesterase inhibitors that you start for dementia would actually help for the BPSD symptoms also. As you can see in these trials, in addition to helping cognitive symptoms, it also helped the psychotic symptoms and other behavioral symptoms. So there is donepezil, which is available, reverse sigmine that is available. Reverse sigmine again helped with various BPSD symptoms, and reverse sigmine is particularly supposed to be helpful in people who have a synucleinopathy like Parkinson's and Parkinson's dementia or diffuse Lewy body disease. Other cholinesterase inhibitor that is used is galantamine. Again, trials to show that it helps for psychotic symptoms. So in summary, cholinesterase inhibitors help in all stages of dementia and in all types of dementia. You really don't use it for the frontotemporal dementia, where there's really not much drug treatment. You must start these cholinesterase inhibitors very early in the disease and continue into the moderate and advanced stage. As I mentioned, helps with all the ABC symptoms, and all the three drugs have same effects. Donepezil is just easier to titrate, better tolerated, and is the cheapest. Memantine is the other drug, NMDA antagonist. Again, used in trials. There's been shown to be improvement in the NPI score in various trials. And memantine is indicated in moderate to severe dementia, and memantine has been combined with donepezil, and combination with donepezil has been shown to improve agitation, aggression, eating behaviors, irritability, and the significance in the NPI and global rating scales there's been improvement with the use of the combination. Similarly, memantine has been combined with rivastigmine, and adding on memantine to rivastigmine improved various aspects of cognition and BPSD in a six-month trials. Now, psychotropic drugs for BPSD, and this is something that has not much evidence, and we should not be using it, though this is something that we tend to use quite frequently. The second generation antipsychotics are the ones that are used. You start low and go slow. Quetiapine in the dosage of anything from 12.5 to 150 milligrams. Risperidone in the dosage going up to about 1 to 3 milligrams per day. Similarly, olanzapine in the dosage of about 5 milligrams per day. Antidepressants for depressive symptoms or sometimes for agitation or apathy. So escitalopram, anything from 5 milligrams to 10 milligrams. Mirtazapine if there's sleep problem. Similarly, trazodone. The evidence for antipsychotics is really only for psychotic symptoms, agitation or aggression. And the majority of trials are with risperidone, though there are some recent trials with aripiprazole and quetiapine. As I mentioned, it should not be first line due to severe adverse effects and increased mortality. And you must actually withdraw them after stabilization within 3 months or so, and keep reviewing the need for it every few months. EPS is more if you use cholinesterase inhibitors with the antipsychotics. With memantine, it's shown to have less EPS. Combination of antidepressants, except for mirtazapine, with the antipsychotics, there seem to be more EPS. Antidepressants, again, various trials have shown that there's really no evidence. Some trials have shown higher remission rates for depression. Agitation for citalopram and certain have been used for agitation.
It's already started, sir.
There's really not much evidence in terms of use for apathy, and some people have used it for delusions and irritability where it might have helped. You need to watch out for extrapiramidal symptoms, hyponatremia, GI side effects, and insomnia. Other drugs that can be used and have been used is carbamazepine, which might improve agitation or aggression or hostility. You need to watch out for the hematological and symptoms of hyponatremia and interactions. Other drugs, valproate, effective, but side effects are high, so not recommended. Benzodiazepines are not an absolute no-no. We do tend to use quite a bit of clonazepam for sleep, for agitation, for REM behavior disorder, but we need to watch out for an acute crisis. So, and we need to watch out for sedation and falls and paradoxical agitation and delirium. So, in summary, the rational use of drugs for BPSD is that you start these medicines low, second generation antipsychotics of SSRIs, and go very slowly, only usually for the psychotic or the affective symptoms. You quickly add a cholinesterase inhibitor right in the beginning itself after you confirm the diagnosis. Add memantine if it's moderate to severe dementia. And very quickly, in a matter of 1 to 3 months, you taper and stop the psychotropics. You might still continue using short-acting benzodiazepines like clonazepam or lorazepam if you need it for agitation or sleep for very brief periods. So in concluding, the present treatment strategies focus on symptomatic behaviors of the APC symptoms. You need to carefully analyze the BPSD symptoms to see whether there are any modifiable or treatable conditions, especially comorbid conditions. Start with psychosocial management earlier on with the training the person with dementia and the caregiver. Cholinesterase inhibitors are cheap in our country and they're useful in all stages, so you must start it early and go on into the illness. And as far as possible, avoid psychotropics, especially antipsychotics. And if you give them, give it only for a brief duration. Thank you very much, and thank you for your patient listening.
So thank you, sir. Nalin, sir, your remarks.
Thank you very much, Professor Varghese, for such a loose talk on the behavior and psychological aspects of dementia, particularly the management part, which should start with the non-pharmacological treatment, and gradually it has to be added later on with small dose and antipsychotics for a very short term. The summary was quite beautiful. The entire talk was quite informative. I hope hundreds will follow these guidelines with your extensive experience, what you have produced. Any questions, please?
Sir, no questions in the audio chat box, sir. But very experts are there. If they want to interact, you can interact. Or else we can move on to next session, sir. So, YSN, sir.
We will move on to the next session, please.
Okay, okay.
Thank you very much.
Dr. Om Prakash is a renowned neurophysician again from Warangal. So we'll chair and invite Dr. Vengamma Madam for her talk. Over to you, Om Prakash.
Yeah. Happy morning to all of you. It's my privilege to introduce today's speaker, Dr. B. Vengana Madam. She's a well-known figure in neurology. She's a professor and head of the Department of Neurology at SWIMS, Tirupati. And apart from her huge academic background, she has a vast administrative experience also. She's a director cum vice chancellor of SWIMS, Tirupati. So please help me to welcome Dr. B. Vengana Madam. And she's going to talk about a very, very important, but a little bit less topic, that is falls in elderly, the evaluation and the prevention. So it's over to you, Madam.
So Madam CV is very big. So yes, we have glimpses only we have presented. Madam is talking on epilepsy in elderly. Over to you, Madam. Dr. Vengamma Madam.
Good morning to everybody. And at the outset, I would like to thank the organizers, Dr. Chandrasekhar and Dr. YSN Raju, for giving me this opportunity to speak on this common topic, epilepsy in elderly. I'll just share it. Is it visible, my screen?
So it is visible, Madam.
Yes, Madam.
So
Okay,
make it a slideshow, Madam.
Is it okay? My voice is audible?
Voice is audible, Madam.
Yes, ma'am. Yes, ma'am.
Okay, good. The topic assigned to me was management of epilepsy in elderly. Okay, I bring greetings from Sri Venkateshwara Institute of Medical Sciences and Sri Padmavati Medical College for Women at Tirupati. I'm going to talk on management of epilepsy in elderly. What is an epilepsy? Is a disorder of brain which is characterized by enduring predisposition to generate seizures and by its neurobiological, cognitive, psychological, and social consequences. A person should be only diagnosed.
Slide show better, madam.
Slide show పెట్టాను సార్, నాకు స్లైడ్ షోనే కనిపిస్తుంది.
ఓకే, ఇక్కడ లేదండి మేడం.
మీకు స్లైడ్స్ మూవ్ అవ్వట్లేదా?
మూవ్ అవ్వటం లేదు మేడం. ఇది ఫుల్ స్క్రీన్ చేయండి మేడం. ఇక్కడ ఉంది మేడం, ఇక్కడ ఫుల్ స్క్రీన్ చేసేస్తే
అదే మేడం.
అది క్లిక్ చేయండి మేడం.
ఇప్పుడు వచ్చిందా?
లేదు మేడం, ఆ పక్కది ఈ థర్డ్ వన్.
ఇప్పుడే చేశాను నేను, నా దగ్గర ఫుల్ స్క్రీనే పెట్టాను.
పర్లేదు మేడం, పర్లేదు.
ఇప్పుడు క్లిక్ చేయండి మేడం. yes, it is coming. మళ్ళీ పోయింది.
వచ్చిందా?
లేదా మేడం.
Okay madam.
Shall I just do it again once more or just a minute?
No need. It's okay madam.
No, it's okay.
You are able to see now? Full screen now?
Not full
Okay.
screen. It's okay madam. You can continue madam.
A person should only be diagnosed having epilepsy if there are recurrent manifestation, that is, there are at least 2 or more unprovoked similar episodes at least 24 hours apart. The first seizure should always be called as a single seizure, not an epilepsy. It can be divided into active and inactive epilepsy. The active one is the one which is being defined as 2 or more epileptic seizures in the last 5 years that are unprovoked by any immediate identifiable cause. The current definition of epilepsy is like earlier it used to be 2 unprovoked seizure 24 hours apart, but currently now 1 epileptic seizure, if there is a probability of further seizures, still you can label it as a epilepsy. The elderly are commonly defined as age 60 to 65 years or older, and the origin of these ages are arbitrary. The new onset of epilepsy in elderly exists as a different entity than in younger adults because of the differences in underlying etiology, seizure characteristics, and as mentioned, multiple comorbidities. Epilepsy has a significant effect in elderly patients, mainly on quality of life, health status, and level of functional independence. The diagnosis and treatment of epilepsy in elderly are challenging because of 5 reasons. 1, there are a lot of atypical seizure presentation. Number 2, there are broad differential diagnosis. The challenges in the management because of frequent use of numerous co-medications, and there are high prevalence of comorbidities and pharmacological changes associated with the aging, especially with anti-epileptic drugs, poses a challenging issue for both diagnosis and management. Clinicians need to expertise in this field to minimize the morbidity and maximize the quality of life. Epilepsy is the 3rd most common neurological disorder in the older people after stroke and dementia, which these conditions which themselves increase the seizure risk. Evidence suggests that the Alzheimer's disease and late onset epilepsy might have a common pathological links mediated by vascular changes or tau pathology or both. Emerging evidence for common widespread network changes in epilepsy and dementia. When you call acute symptomatic seizure is the one which 1 or more seizure due to acute event in the temporal association with brain insult or a metabolic disturbances like
Sorry to interrupt madam, your
Yeah.
slides are also not moving madam. Please check once.
Here it is moving.
I don't know what is happening. Now it is moving. Now it is moving madam.
I think in the slide mode it is not moving. I will put like
Now
this.
it is moving madam. Introduction is over. Yes madam, you come down to the
Yeah.
yes madam, now it is moving.
Okay, most important thing in the seizures is acute symptomatic seizure. The provoked one or more seizures due to acute event in the temporal association with the brain insult or metabolic disturbances, that is stroke, trauma, hypoglycemia, hyponatremia, and other drugs. In these, once you triggers are removed or symptomatic cause, the recurrence is very minimal. As mentioned, epilepsy should be a recurrent unprovoked seizures. Epilepsy in elderly has got lot of impacts, basically because of the anti-epileptic drugs, frequent falls, injuries, and fractures, and it has impact on dependence and psychological stress. The incidence of epilepsy increases with the age after the 50 years, and greatest incidence in the people older than 75 years. The prevalence of 5.4 per 100 people in older population as evident in global burden of disease report on epilepsy. Multiple comorbidities and polypharmacies are the norm in older age group, and this present as a diagnostic challenges. Or the management of epilepsy basically has got 5 steps. Step 1 is first establish the correct diagnosis of epilepsy. Then what is the seizure type and syndrome you should define. Then look for a structural cause. Then the step 4 is the choice of drugs. Step 5 is the dosage and complaints. The first is the establishment of diagnosis of epilepsy, which again has got 5 diagnostic steps. First, you should check, is it a seizure? Always exclude seizure mimics. If it is confirmed seizure, then you have to see whether it is a provoked or unprovoked. Like provoked, it could be acute symptomatic seizures. If it is unprovoked, is it a single seizure or more than 2 to label it as an epilepsy? And if it is an epilepsy, type of epilepsy, and you should check, is it an idiopathic or symptomatic? There are many conditions which can be mistaken for epilepsy in the form of syncope, could be cardiac, postural, or it could be vascular diseases, sleep disorders like parasomnias, and especially in older people, RBD, REM sleep, behavioral disturbances, some of drugs and psychiatric disorders. The seizures have got an initial prodrome followed by 3 distinct phases, that is aura, the first phase, small partial seizure where patient is aware of this one. The next is the ictus, the main part of the seizure, then the post-ictal, the period in which brain recovers from the insult it has been experienced. Drowsiness and confusion are the common. Common types of seizures are partial or focal seizures, generalized seizures, simple and complex partial or secondary generalized. Under generalized, tonic-clonic, tonic seizures, atonic, myoclonic, absent seizures in these age groups are very rare. Then coming to the current classification is focal. There is a awareness present or impaired awareness. Focal seizure, generalized seizures are unknown. Among the focal, awareness present or awareness impaired. It could be motor onset or a non-motor onset. Non-motor onset is quite common here. There's autonomic, behavioral arrest, cognitive and emotional, and generalized seizures again, motor, tonic-clonic, clonic, and myoclonic. Non-motor in the form of typical, atypical, or this is the current classification. Unknown again is classified as motor or non-motor. The clinical presentation in elderly, diagnosis in elderly is difficult. As mentioned, the presentation could be very atypical. Complex partial seizures are common. Among these complex partial seizures, extratemporal, mostly frontal lobe is common. Temporal lobe phenomena like déjà vu, olfactory hallucinations are not common. Most common presentation is an episodic confusion, sleepiness, clumsiness with no tonic-clonic movements or automatism. Another thing, post-ictal phase is most of the time it is prolonged, especially in the presence of a stroke or a dementia. Most important is any paroxysmal confusion or episodes of behavioral arrest in an older patient always lead to suspicion of seizures. Another entity which is very common is non-convulsive status epilepticus, a condition with high morbidity in older people, should be suspected suspect in all individuals who presents with confusion or a delirium, fluctuating awareness, and acute onset of behavioral changes. The persistent headache or disorientation after an episode of impairment of consciousness are suggestive of a seizure as their stereotyped events. Recurrent focal seizures are often misdiagnosed as a transient cerebral ischemia, particularly if the stereotyped nature of the symptom is not recognized. Disorder that predispose to syncope like carotid sinus hypersensitivity, micturition syncope, postural hypotension are common in older people. Focal jerking, also known as limb shaking transient ischemic attacks, might sometimes occur in severe carotid stenosis. Cardiac arrhythmias can present with seizures in this age group, and conversely, seizure also could have a autonomic disturbances and cardiac dysrhythmia causing diagnostic challenge. Epilepsia partialis continua might be confused with involuntary movement disorder. The rare paroxysmal sensory epilepsy could often be labeled as a recurrent transient cerebral ischemia. The postictal paresis, known as Start's paresis, can persist for days and often interpreted as a new stroke. Disorientation, hyperactivity, wandering, incontinence might also continue up to 1 week postictally, occasionally longer, causing further diagnostic difficulty. Dissociative seizures might also present de novo in later life, but non-epileptic attacks are more likely to have a physiological rather than a psychological basis in older people. If you see, most of the time, 43% are focal onset seizures with impaired awareness is very common, followed by 25% of bilateral tonic-clonic seizures and 14% of mixed focal, and 13% is a combination of bilateral tonic. Unlike in adults and adolescents, here the focal onset with impaired seizures are very common. And differences between young adults and elderly, as I mentioned, aura is less reported, automatisms are less observed compared to the younger adults, motor features are less infrequent, but postictal state and can last for a longer in elderly people compared to the younger individuals. And the differences, the seizures could be, they could have a first new onset epilepsy for the first time they can occur, or the chronic epilepsy, which is on elderly, which onset in childhood and middle age. Here also the seizure type commonly is the focal epilepsy or a non-convulsive status epilepticus is common with the new onset. Unlike in chronic epilepsy, you can have a GTCS or focal seizures. Young people can have multiple types. The most common characteristic of a new onset seizure is short duration focal seizures with non-motor manifestations like blank stare, loss of awareness, confusion, memory problems are common for a new onset, and depending upon the type of the epilepsy in childhood, they can continue. And in a new onset, the postictal period confusion can last up to 2 weeks. In other two conditions, it could be short. A word about non-convulsive status epilepticus. It is sometimes can present as a presenting event with a varied presentation, can present with confusion, drowsiness, lethargy, psychosis, and coma. And usually video EEG is helpful to evaluate these patients with confusion or coma. Like mentioned, there are many differential diagnoses we have to exclude before you label a person with an epilepsy: recurrent syncope, transient ischemic attacks, transient global amnesia, drop attacks, REM sleep behavioral disorder, fluctuating cognitive impairment, and episodes of migraine and delirium. If you think syncope, just to mention the neurally mediated, it could be vasovagal syncope, carotid kinase syncope, situational syncope, glossopharyngeal neuralgia. All these things has to be differentiated. Or neurological causes like idiopathic drop attacks, vertebrobasilar insufficiency, hyperventilation syndrome, sometimes CSF dynamic studies required. And postural hypotension secondary to drugs, volume loss, or a small fiber neuropathy, what you see in elderly diabetics also has to be differentiated. And cardiogenic may be because of structural and structural causes like left ventricular outflow obstruction, right ventricular outflow obstruction, and arrhythmias also we have to exclude. And like mentioned, the common presentation is delirium. It could be a part of a seizure, but before that you have to exclude metabolic causes, other things. If there is a history of focal onset, again, like mentioned, you have to rule out TIAs and syncope. Like falls with altered sensorium, rule out syncope, confusion and memory disturbance, always exclude delirium, dementia, transient global amnesia. If there are focal neurological, always you look for or exclude transient ischemic attacks. And there's something called amyloid spells. The positive or negative symptoms, motor sensory, spreading over a contiguous spot slowly over 1 to 15 minutes, duration more than 6 minutes in over 50% of cases. They have an associated cognitive, this one, positive iron susceptibility in MRI can this one. And then sometimes migraine aura also, sometimes visual or sensory aura can also resemble like sensory seizures. Psychiatric symptoms like psychogenic non-epileptic seizures also we have to exclude. After confirming the diagnosis of epilepsy by excluding all the seizure mimics, you have to see what is the cause for epilepsy. The commonest are these 5 causes. One is the stroke, which is the most common cause of epilepsy. It could be intracerebral hemorrhage or infarct. And acute symptomatic seizures can occur in acute stroke or a recurrent stroke. The next common cause is the dementia. Alzheimer's is 9 to 16%, usually high with younger age of onset of dementia and severe disease. Head trauma, trivial trauma, risk increases with intracerebral hemorrhage, fractures and loss of consciousness. Others like intracranial tumors, meningiomas, gliomas, metastasis and AVMs, and 20 to 30% we may not find any cause. Like this study which showed that acute symptomatic seizure, the commonest 40 to 50% are secondary to acute hemorrhagic or ischemic stroke, followed by metabolic illness, then followed by 15% toxic or alcoholic. Other CNS infections are 2 to 3%. In contrast, in a new onset epilepsy, 30 to 65% again due to cerebrovascular disease, followed by dementia 10 to 20%, neoplasm 3 to 11%, traumatic brain injuries 1 to 7%. This is the summarizing, like I mentioned, the stroke or cerebrovascular is common, ischemic is 37%, hemorrhagic is 12%, followed by neoplasms 13%, Alzheimer's disease 7%, other neurocognitive, and still there is a group of unknown percent, about 10 to 15%. Among the strokes, the commonest is the total anterior circulation. Infarct strokes are more common. Hemorrhagic, like intraparenchymal hemorrhages, are more common. Cortical involvement are more common. With the lacunar stroke and posterior circulation stroke, the risk factor for epilepsy after the stroke is less. If there is a stroke severity score is more than 15, they have a risk factor for early and post-stroke. Late post-stroke seizures. Early post-stroke seizure is the one which occurs within 7 to 14 days of the stroke, and late post-stroke is after 14 days. Because the early post-stroke seizures is a part of an acute symptomatic seizure, the chances of relapse or recurrence is less compared to a late post-stroke seizure. How you diagnose epilepsy? Basically entirely from the history obtained from the patient or the onlooker or eyewitness. Video recording of the attack through mobile phone is important. Investigations are not mandatory, only need-based. For most important, helpful is EEG. Is definitely useful in non-convulsive status epilepticus, and main drawback is low sensitivity and specificity, because sometimes EEG may show non-specific changes. However, the normal EEG does not rule out epilepsy. Hyperventilation, photic stimulation may not yield much in elderly compared to the young people. Prolonged EEG and ECG recording in the hope of capturing episodes can be diagnostic, and in addition to clinical acumen, perhaps the most to help the diagnosis. Next important is the imaging is the most important to know the underlying structural cause like CT or MRI brain and other metabolic workup for electrolytes, RFT, LFT, glucose, calcium, magnesium, and CBC. Another important thing compared to the children and adolescents, older people with explosive onset of epilepsy, that is sudden emergence of frequent seizure up to several times daily with no background history of seizure disorder, particularly associated with substantial cognitive and psychological comorbidity, should be screened for autoimmune antibodies, especially LGI1, that is leucine-rich glioma inactivated, or Caspar-2 contactin-associated protein like 2 should be excluded, and paraneoplastic antibodies to be done both in serum and CSF. These are all some of the examples of causes of epilepsy, new onset epilepsy in elderly, like showing the first one showing the meningioma in the left posterior parietal area, and this one showing the left frontal area and the left posterior parietal area, and this is showing the AVM. Another one is a small neurocysticercosis and person with glioblastoma multiforme, multiple tuberculomas are common causes. Coming to the treatment, I would like to re-emphasize the diagnosis of epilepsy uncertain. It should be kept under review and is often clarified with the passage of time. There is no role for a trial of treatment or an empirical treatment in a suspected or confirmed patient, as evaluation of such trial is almost invariably conclusive. Medical treatment starts with when do we start treatment, which AED to be chosen, when and how we should switch over, whether is a polytherapy required, when can AEDs be discontinued. The decision to start treat anti-epileptic should not be taken lightly, because once you start, patient has to take for a regular medication for long period of time, risk of toxic side effects, and may have a lot of social repercussions. That's why in a newly diagnosed patient, we have to always decide the balance between benefits and drawbacks of the therapy, and each decision should be tailored to the individual requirement. Definitive diagnosis is a must. When in doubt, no trial of treatment. Ideal aim is to maximal seizure control with minimal side effects or monotherapy, usually gradual introduction of AEDs. Assessment of AEDs based on after reaching the steady state level. The goal of therapy is to achieve complete seizure control, ideally with single drug taken once or twice, less frequent doses without side effect. There are many drugs which have come into the market for the last 100 years or 200 years, from first generation, second generation, third generation drugs. The older drugs are, efficacy wise, both older and new drugs are same, but the tolerability and side effect profile wise, it is newer drugs are better. But however, the cost factor makes newer drugs are more little expensive compared to the older drugs. But in elderly inadequates, there are not many studies for many of the newer drugs. That is, inadequate studies in this group limits the application of different drug classes. Evidence suggests that improvement in health quality of life following treatment with AEDs, and UAD could be normally until now prescribed as valproate, lamotrigine. But however, the recent guidelines have changed. Levetiracetam and lamotrigine has been given level B evidence as per the SIGN guidelines, ILE guidelines, and NICE guidelines. Among the elderly with epilepsy, lamotrigine was better tolerated than carbamazepine. Levetiracetam demonstrated a higher probability of seizure freedom as compared to the lamotrigine, with no significant difference in measures of tolerability. There were no significant differences between carbamazepine and levetiracetam in terms of efficacy and tolerability. However, more data is required to evaluate the newest generation titration schedules in the elderly with AED doses and titration in the elderly with epilepsy. More data is needed to examine the impact of common determinants such as frailty and neurodegenerative and cerebrovascular diseases. These three are common for this heterogeneous population. But basically, among the newer drugs, lamotrigine, oxcarbazepine, levetiracetam, topiramate, jonesamide have a less drug interaction, linear pharmacokinetics also less, and less ADR. That's why the choice of AED has to be individualized. Ideally, lowest monotherapy drug with the least ADR and smaller doses. And if a patient has got difficulty in swallowing, may use the liquid. And because of the most of the time they have an impaired memory, higher compliance will only be with less frequent doses, either single dose or 2 doses. Now, more than 2 doses, most of the time they're going to miss and causes a problem for the drug complaints. Acute symptomatic seizure doesn't need a long-term anti-epileptic drugs or anti-seizure medication because due to it has to be correctable causes, do not require treatment. Acute intracranial event like stroke and head trauma, they could be treated only for short-term treated for a limited period, 6 months to 1 year. Unlike in adults and children, the controversy of solitary seizure to treat or not, in elderly, because of the risk of high chance of recurrence, must be treated. But before starting of any drug, you should always remember drug interaction with other pharmacy drugs, what person is taking, because for example, warfarin effect may be low if you start on phenytoin. Similarly, tricyclic antidepressants, aminophylins can lower the seizure threshold. That's why we should always think of drug form interaction with the current AEDs. Because pharmacokinetics in AEDs also alter because they show slowing of hepatic metabolism, reduced enzyme inducibility, renal elimination decreased by 10% per decade after 40 years. Plasma proteins and albumin concentration fall with the age, lower protein binding causing toxic symptoms within normal therapeutic range. Decreased gastric mobility, increased gastric pH alters the absorption. Increased fat lean body mass ratio also alters the volume of the drug disturbance. We should always be aware of the pharmacokinetic of individual AEDs before prescribing. Coming to the adverse reactions, the elders are more prone or they're sensitive for this, commonly with phenytoin, and more prone to cognitive effects compared to adults, especially if there is an underlying brain lesion. And the osteoporosis, again, which is very common with enzyme-inducing drugs like phenytoin, carbamazepine, phenobarbital, all these older drugs, you have to keep in mind before we prescribe them. Most of the time, currently, there are many drug seizure medication in the elderly. Carbamazepine can have a cognitive side effects, but it is a potential mood stabilizer. Similarly, clobazam can have an effect on cognitive slowing. Drowsiness is the main reason. And most important, before we start on any drug, we should be always remember about any of these anti-epileptic or anti-seizure medication on what its effect on cognition, effect on mood, other side effects we should always keep in mind. That's why levetiracetam and lamotrigine are relatively safe compared to the other drugs, and especially in relation to cognition, mood. Like oxcarbazepine can cause hyponatremia. Phenytoin can cause effect on cognition with lot of effects on osteoporosis, other metabolism. And topiramate again can have a significant effect on cognition. Before we prescribing, we should always see what the drug is patient, what the other drugs patient is taking, what is the interaction of these drugs, and these anti-seizure medication on cognition and other systemic effects we should always keep in mind. Other important thing is the multiple comorbid these patients can have. That is mostly underlying cause. We have to look for dementia, stroke, head injury, brain tumor. Pharmacological comorbidities, they can have known for hyponatremia, especially carbamazepine or oxcarbazepine, polypharmacy, bone health, and side effects of anti-seizure medication should be kept in mind. Associated and non-associated systemic illness, patient could have a cardiac disease, hypertension, systemic tumors, any of autoimmune disease, and psychiatric comorbidities very common like depression, loneliness, psychosis, and anxiety. And many of them have a psychosocial difficulties for stigma, driving restriction, especially abroad, and effects on osteoporosis. And most important, have a cognitive impairment because they already have a less reserve, and impact of some of the anti-epileptic drugs like topiramate and phenobarbital, some of those drugs, and they have a less self-support. That's why before we prescribe or manage this one, we should always look into what is the comorbidity in these patients can have. Role of surgery is limited in elderly because most patients may not fit into this one. But however, if there is clearly defined focus for epilepsy like medial temporal lobe with ictal or interictal epilepsy, they can be definitely done surgery, and the results are as effective as an adult, but the data is limited. Basically, to say the older person, the epilepsy could be new onset seizures. You should check, is it a non-acute presentation, establish the diagnosis, review the description of the seizure and videos, do the blood test, initiate anti-epileptic. If seizure free, then you can ask him to this one, otherwise attend the OPD. In emergency situation, always establish the diagnosis. Is it a non-convulsive status epilepticus? If it is status epilepticus, treat like a status epilepticus guidelines. If it is not status epilepticus, establish the diagnosis, initiate the anti-seizure medication. If the patient is already diagnosed, the existing diagnosis of epilepsy, review the diagnosis. If still having, we exclude whether the patient is having any seizure mimics. For that, if appropriate case, repeat MRI and other imaging, medical management, and if it's a drug resistant, patient has to go for a surgery unit. To conclude, that the highest incidence of seizures and epilepsy after 65 years, there are a lot of diagnostic difficulties because of variable presentation, susceptibility to AED side effects and toxicity in elderly are common, increased likelihood of drug reaction with other medication for comorbidities, increased feeling of stigma, frequently associated with physical injuries due to frailty and leading to frequent falls, create problems in the management. The most common cause is a cerebrovascular disease. Like mentioned, presentation is varied. They can have present as agitated delirium, altered sensorium, forgetfulness, sometimes transient ischemic attack-like symptoms. Diagnostic evaluation with the video EEG and neuroimaging, CT or MRI. All with the epilepsy need anti-epileptic drugs, but pharmacokinetics should be remembered. However, the prognosis and control same as in young patient if properly managed. Thank you for your kind attention.
Thank you so much, madam, for a very informative talk. As we know that the drug of choice depends upon the comorbid condition, but I want to know your drug of choice if there is no major comorbid condition.
So if there are no comorbid condition, the drug of choice currently with the limited, means with not much of a drug interaction, currently we prefer levetiracetam is the best drug.
Okay, thank you, madam.
Madam, there is one question in the chat box, madam. One elderly patient is on sodium valproate. What all we have to monitor? Age 80 years since 20 years. So patient is on valproate in 20 years, 80 years old patient. So valproate on 20 years. So what things has to be monitored? That is the question from the audience.
No, if normally the sodium valproate known to cause obesity, that is weight gain, loss of weight, alopecia, and sometimes can cause a liver dysfunction. If patient has no or any of these side effects, you can continue. Maybe you can monitor the liver function test. Most important complaint we get is a loss of appetite and obesity, and then liver dysfunction. If patient is comfortable without any other symptoms, you can just continue monitoring the liver functions.
Thank you, madam.
Hyperammonemia, what is described in children but may not be seen with the elderly people.
Madam, want your comments on the newer drugs like brevracetam or perampanel use in elderly patients, ma'am?
Actually, the trials are very limited. We don't use it as of now because we feel that currently the drugs we try is like levetiracetam, sodium valproate, if there is no contraindication, then lamotrigine, oxcarbazepine, those things. But the newer, these drugs have come recently, and at least I have studies are very limited. And most of the time, if it is polypharmacy, it becomes very difficult, especially in elderly. At least maybe up to locasamide and jonissamide has been tried in elderly, but perampanel, all those things have been still not, studies have not completed because most of these things they have taken people less than 60 years, I think, in that group. It is predominantly for adults and children, not for a geriatric population, especially perampanel and brevacetam.
Yes, ma'am.
Maybe after a decade or so, the results may come out, but as of now, they are not recommended.
Yes, ma'am. Any other questions from audience, please?
I can't
Sir,
hear
I think there are no questions, madam.
Thank you so much, madam.
Thank you, Vengamma madam, and other previous speakers also. We have successfully completed first session. Bijin sir, Varghese sir, and Vengamma madam. And also thank chairpersons Venkatraja sir, Nalin Chaudhary sir, Om Prakash sir. So we will move on to the next session, that is presidential oration by Dr. Prasad Matthews, and chairpersons being myself and Dr. Arvind Mathur sir. Sir Arvind Mathur sir, please unmute yourself and introduce about the oration and about the speaker, sir.
Thank you very much. It is my privilege today to invite Professor Prasad Matthews. Professor Prasad has been heading the Indian Academy of Geriatrics for last 3 years and has so much of contribution in the advancement of the academy. And we all are aware that Dr. Prasad was the head of Department of Geriatrics at Christian Medical College, Vellore, where he is right now medical superintendent also. And he would be delivering the presidential oration. Over to you, Professor Prasad Matthews, please.
Thank you, sir, for that kind introduction. I'll be, is my screen seen, sir?
Yes, sir. Yes, sir.
Yeah,
It is visible, sir,
we can
but make it in a slide mode, sir.
Okay.
Slide
I'll
mode,
be
not yet.
giving a talk
Sir,
on the spectrum of vascular cognitive impairment. This is not meant to be a comprehensive lecture, but more of an overview of some aspects of vascular dementia. A lot of the attention is on Alzheimer's nowadays, and so vascular dementia gets missed out. I hope you can see my slides, sir.
Yes, sir. We're able to see your slides clearly.
We can see it.
Okay, the DSM-5 criteria have been around for many years now, but they're still mysterious for many because of their complexity. So when you compare the DSM-4 criteria and the DSM-5 criteria, so the DSM-4, memory impairment has to be there, plus at least one of the following, one of the other domains. While in DSM-5, there has to be, you can diagnose minor neurocognitive disorder or major with even involvement of just one domain. So one or more domains have to be involved. If it's interfering with day-to-day activities, then it's major. If not, it's minor. So as you know, some more domains have been added in DSM-5, and these are complex attention, which can be classified as sustained attention, divided attention, selective attention. For example, difficulty with coping with multiple stimuli, easy distracted. Perceptual motor incorporates apraxia and agnosia, also visual perception, visual construction. And social cognition is basically problems with behavior, social insensitivity, etc. So obviously the complexity of assessment with neuropsychology, DSM-5 is more. But this is more for research, and for practical standards, I think DSM-4 is quite good for us. Now, as medical students, as PGs, we all knew about multi-infarct dementia, and Newcastle upon Tyne has been one of the pioneering institutes for pathological assessment of the brain before imaging came out in a big way. So according to their research in the 60s, vascular dementia was related to multiple brain infarctions exceeding a certain threshold. And it was through occurrence of multiple small or large infarcts. And this led to the widespread use of the term multi-infarct dementia as being synonymous with vascular dementia. And classically, what we learned as medical students was that of an acute event followed by stability and stepwise deterioration with each new infarct. So this is a classic multi-infarct dementia. 2 old infarcts on the left side and 1 new one marked by the arrow on the right side. So that is a classic multi-infarct dementia, multiple wedge-shaped infarcts. So vascular dementia is the second most common type of dementia, and it's a cause or contributor in 25 to 50% of cases of dementia. In clinical pathology, the interesting thing about vascular dementia is in pathological studies, pure vascular dementia is relatively uncommon, accounting for only approximately 10% of dementia cases. And mixed dementia with a vascular component, most often in combination with Alzheimer's, is more common. And this accounts for approximately 30 to 40% of all dementia cases. So mixed dementia is more common than pure vascular, and this is especially so in the elderly. So again, these 2 studies show that vascular comorbidities may be present in 30 to 60% of Alzheimer's patients, and Alzheimer's pathology may be present at autopsy in 40 to 80% of vascular cognitive impairment. This Professor Erkkan Junti from Finland is one of the pioneers of research in vascular dementia, and at one conference, which I happened to attend, he made this statement: dementia in the elderly is always mixed. Of course, he was exaggerating, but basically what he was saying was, with number of comorbidities and problems, as you get older, there may be more than one cause of dementia in an elderly person. Now, I'll just go through some of the common types of vascular abnormalities that can cause cognitive impairment in the elderly and in younger people. An MRI, as I said, is a revolutionized diagnosis of vascular abnormalities causing dementia. So this axial flare MRI shows a chronic cortical infarct in the right parietal lobe. It's white on flare, and you can also see some white matter disease there. So this is a classic infarct. Now this MRI axial flare shows lacunar infarcts which are marked by arrows. So these lacunar infarcts are round or ovoid fluid-filled cavities of between 3 and 15 millimeters in diameter with a white rim on flare. So what is the significance of lacunar infarcts? They are more easily recognizable in MRI and less so in CT scans. So what is the significance of lacunar infarcts for cognitive impairment. So there are certain guidelines in a person with memory impairment. So if the baseline cognition was normal, more than 2 lacunes outside the brainstem would generally be considered as necessary to support a diagnosis of VCD. So you should have 2 or more, with just that. And single lacunes placed strategically in the striatum or thalamus may produce a VCT, vascular cognitive disorder, that is called strategic infarct dementia, but it should be temporarily related to the lacunar infarct. And occasionally, you can have single lacunar infarcts, which can also precipitate vascular dementia, especially when associated with extensive periventricular and deep white matter lesions. Now, this axial flare MRI shows extensive white matter disease, what used to be called as Binswanger's disease, involving almost the entire white matter. So we are familiar with Fezzica scale, which we have seen reported on MRIs of our patients. Grade 1 with just periventricular caps on the top images. Grade 2 with smooth periventricular halo on the second one. And grade 3 is severe with confluent white matter disease extending into the subcortical deep white matter. So can white matter lesions be sufficient for mild vascular cognitive impairment or vascular dementia? According to the guidelines, white matter lesion should be extensive and confluent. And if previous imaging was there, if the white matter lesion is extensive and new, this could also be supportive. But generally, you would need some lacunar infarcts as well, as I said in the previous slides. For mild VCI, white matter lesions may be sufficient without other vascular pathology. For vascular dementia, additional presence of lacunes is necessary, which is not uncommon. Now, the picture on the left is showing a cortical bleed, which is the white lesion in the temporal lobe, and also multiple cortical microbleeds, which on this axial SWI MRI look like little black holes in the cortex. All these black holes here are signs of microbleeds, lobar microbleeds. And the picture on the right side, we are seeing a deep bleed in the basal ganglia here, and we are seeing microbleeds in the opposite basal ganglia. Now, when we see lobar hemorrhages, we are thinking of cerebral amyloid angiopathy, and we are seeing deep hemorrhages, we are thinking of hypertensive hemorrhages, both with respect to the microbleeds and the larger bleeds. So multiple hemorrhages or hemorrhagic infarcts are often associated with vascular cognitive disorder. As I said, the cortical ones are mainly related to amyloid, and the deep ones mainly related to hypertension. So since microbleeds are not uncommon in cognitively normal older individuals, before attributing VCD to these, especially vascular dementia, should carefully exclude other causes of cognitive impairment, only if these lesions are numerous. This is a paper from JAMA Neurology in 2016 showing an association of cerebral microbleeds with cognitive decline and dementia. So model 1, model 2, and model 3 are adjusted for various covariates. So in model 1, you can see that microbleeds were at baseline were significantly associated with development of dementia. Model 2, once you adjusted for a lot of risk factors, it was no longer significant. But model 3, it was significant. So basically, all these lesions, microbleeds, lacunar infarcts, and white matter disease are consistent with small vessel disease, except for the cerebral large bleeds, and can cause dementia. Now, looking at amyloid angiopathy, now the first part which I've marked with an arrow relates to postmortem, which we hardly ever get. But generally, when you're seeing lobar hemorrhages, you are thinking of amyloid angiopathy. Now, the other abnormality that is seen in MRIs with patients with vascular cognitive impairment is enlarged prominent perivascular spaces. They've been marked with arrow. They also look like holes on axial T1 weighted MRI. So evidence is accumulating that these enlarged spaces may be another feature of small vessel dementia. These compartments surround perforating cerebral arteries and are involved in exchange of fluid and solutes. However, a recent review found no independent association of these enlarged spaces with prevalent or incident dementia, but more research is required into this field. So this initiative called STRIVE, Standard Reporting and Neuroimaging, was a structured process by an international working group to develop definitions and imaging standards for markers and consequences of small vessel dementia. So this is the table, the STRIVE table. So you can see from left to right, first one is subcortical infarct seen on acute subcortical infarct seen on diffusion weighting imaging. Then you have the lacunar infarct located in white. This is the lacunar infarct. These are the enlarged perivascular spaces, and these are the cortical microbleeds. Now, this is again a classification of cerebrovascular pathology associated with vascular cognitive impairment, and this is from the group from Newcastle. And this Professor R.N. Kalaria from the Newcastle, who's a cerebrovascular pathologist, is a renowned expert in this field and is part of many of the groups forming guidelines and classifications. And his classification, mainly based on pathology, classified into these 6 groups: large infarcts or cortical infarcts, multiple small infarcts or lacunes, strategic infarcts, which I'll talk about later, hypoperfusion lesions related to fall in BP or including hippocampal sclerosis, which he feels is also caused by vascular problems and not just by Alzheimer's, cerebral hemorrhages, and vascular pathology along with Alzheimer's. So these are the parenchymal lesions of vascular etiology. I've already described most of them. I won't go over them again, except to reiterate that small vessel disease encompasses multiple lacunar infarcts, ischemic white matter change, white matter disease, dilated spaces, and microinfarcts and microhemorrhages in the cortex and deep matter. Now, about the etiology, the common ones I've circled above are atherosclerotic embolism, arteriolosclerosis, lipohyalinosis, so a common cause of obliteration of deep perforating vessels, and amyloid angiopathy. The others are rare, but need to be looked for in appropriate cases. I won't go into them. Now, when we talk about vascular cognitive impairment, especially in the deep small vessel vascular dementia, memory is often not involved early or even for quite significant period of time. And this is what differentiated from Alzheimer's. So rather than memory being involved, first what's involved is executive functioning, manifesting as slower information processing, poor working memory, and reduced judgment, set shifting ability. And also, since these vascular lesions disrupt many thalamocortical, striatocortical, and prefrontal basal ganglia pathways, it may affect cortical and limbic brain structures and is often associated with disturbances in behavior and emotion. Now, for mild and major vascular cognitive impairment, apart from the major affecting day-to-day functioning, mild generally, statistically, on neuropsychology, deficits would fall between 1 and 2 standard deviations below the mean. While in dementia or major, it would fall 2 or more standard deviations below the mean in neuropsychology. So as I said before, in DSM-5 and newer criteria, significant impairment in only one domain can be considered sufficient to diagnose vascular minor or major vascular cognitive disorder, and memory is not compulsory. Now, if you compare these three diagnostic criteria for major vascular cognitive disorder or vascular dementia, you can see the red circles. The first criteria is the red circles, which are the same in all three criteria, which say that onset of cognitive deficits follows one or more strokes. So that's common across all three. And the second, which is the green circles, show that if there's no stroke, then there should be a pattern of subcortical dementia with impaired executive functioning. And the last two criteria also show that neuroimaging should show vascular involvement. There's another group which has proposed their classification of major VCI subtypes. So first is post-stroke dementia. Patients with post-stroke dementia may have also had mild cognitive impairment before the stroke, but the dementia occurs within 6 months after stroke. Mixed dementias I've already spoken about. It may not be just Alzheimer's and vascular, but also Lewy bodies and vascular and so on, some of which can be diagnosed only at autopsy. Small vessel disease, I've been talking about it for some time, is the main vascular cause, and I'll have a couple of more slides about that. And multi-infarct dementia we've also talked about. Post-stroke dementia, in a systematic review of 22 cohort studies, 14% of patients hospitalized with stroke on history had a preceding history of dementia, and 12% of patients without pre-stroke dementia had dementia following a first stroke. But this is including all ages, and in the elderly, it will definitely be much more. Now, small vessel dementia, I've already said a lot about it, just few more points. It's more common with long-standing hypertension and diabetes, which cause lipohyalinosis and arteriolosclerosis of the deep penetrating arteries. It's a subcortical dementia. Progression may be smooth, unlike the stepladder progression of classical vascular dementia. Executive dysfunction, planning, abstract thinking, ability to take action goals is impaired. They may have a slower gait and lower half Parkinson's, emotional lability, depressive symptoms, loss of interest, and urinary incontinence. So some of these features actually look like normal pressure hydrocephalus, especially the gait disturbance, the urinary incontinence, and the dementia. And generally, and there may be cortical atrophy as well, causing dilatation of the ventricles. So in general, when there's suspicion of normal pressure hydrocephalus, if there's extensive evidence of vascular disease, there's a reluctance to operate. Strategic infarct dementia can be due to a relatively small infarct in some parts of the brain, especially in this study, left frontotemporal lobe, left thalamus, and right parietal lobe. Another study, also the medial frontal lobes and language cortices. As far as neuropsychology is concerned, I won't go into details. MMSE is better for Alzheimer's. It's simple. It does not access executive function. So for suspected vascular dementia, you need a better tool such as Montreal Cognitive Assessment, which also assesses executive function and detects mild cognitive impairment, or a frontal assessment battery. These are just some simple tools. I think all of you are familiar with the Montreal Cognitive Assessment, which I've shown here. And the frontal assessment battery has 6 fields: similarity, lexical fluency, motor series, conflicting instructions, go or no-go, and prehension behavior. I won't go into the details. You can probably look it up online, but it's pretty useful. Maximum score of 18, and a score of 12 or less has sensitivity and 77% and sensitivity of 87%, differentiating between frontal type dementia and Alzheimer's type. Now, just by the way, I found this picture in a research paper, December 2017, where 2 patients who presented with MCI, mild cognitive impairment. The first one, patient A, they decided it's vascular because there was no evidence of cerebral amyloid deposition on imaging with floor beta Ben, while patient B below received a final diagnosis of mixed dementia because the PET was positive for floor beta Ben. This is all more in the research setting. This has not come out into our clinical practice yet. Now, I just bring up, as my last 2-3 slides, I'd like to bring up this matter of brain reserve and cognitive reserve. So brain reserve means when there's tissue compromise, some brains have a greater capacity to rely on spared neurons and pathways to compensate, including activation of latent pathways and formation of new synapses. Hence, even with, say, a small stroke, cognition is not impaired. And cognitive reserve means that age and disease-related cognitive declines may be protected against by higher premorbid cognitive ability, higher premorbid functioning with more compensatory strategies, and also because they may have further to decline before being testing in the impaired range. So this is something we often see, that high functioning individuals just keep testing normal again and again on their neuropsychology. Now, this is a very interesting paper looking at 2 different studies, Nunn and Honolulu Asia aging studies, with about 330 and 700 in these 2 studies, one on the left and one on the right. And they looked at 5 different pathologies. Severity of Alzheimer's, 0 is absent, 0.4 is moderate, 1 is severe. Lewy bodies, microinfarcts, hippocampal sclerosis, and low brain weight. So if you look at this, you can see that 41% of patients with moderately severe amyloid deposits in the brain had no cognitive impairment, 0 cognitive impairment. Similarly, with Lewy bodies, moderate, even severe, 20% had no cognitive impairment. Similarly, with microinfarcts, hippocampal sclerosis, and low brain weight. Now, this is combining all those scores together up to a maximum of 4.4. You can see that when they went above, let's say, 2.8, 100% had dementia. But below that, though they had significant burden of some or all of these pathologies, a significant percentage did not have dementia. This is the same data in the form of odds ratios, showing that compared to index of 1, as the disease became pathological burden of all these 5 pathologies kept increasing, you can see the odds ratio increasing. But what is important is that even with significant amount of deficit, many patients remain cognitively normal. So my take-home message, VCI is the second most common type of dementia. Mixed dementia is common, especially in the elderly. Post-stroke dementia is seen in 12%. Small vessel involvement is common, resulting in SSVD. SSVD manifests with executive dysfunction, gait abnormalities, incontinence, and emotional lability. Radiology and pathological findings in VCI have been standardized, and aggressive control of vascular risk factors is important. Thank you.
Thank you very much, Professor Prasad, for elaborating very important clinical issue which we encounter in the older people of vascular cognitive impairment. I think we have some interventions also available to at least delay or prevent this particular type of pathology. In presidential oration, we will not be having any questions, so I'll pass on to the organizers. Thank you very
Dr.
much.
Prasad. That was an excellent lecture.
Yeah.
Thank you.
Sir, thank you, sir. It is very excellent oration, sir. We have learned so many things on it. So as a custom, as Mathur sir said, there is no question, sir. So we will move on to the next oration, sir. That is Venkoba Rao oration. So oration is delivered by Dr. Sureka Madam, and chairperson, sir, Dr. YSN Raju, sir, and Dr. D. Nagender. He is the chairman-elect for API Telangana. Sir, over to you, sir, chairpersons, to invite our orator, Dr. Sureka, ma'am, and also tell me about Venkoba Rao oration, sir.
Thank you very much, Dr. Chandrasekhar. Good morning, Dr. Nagender.
Yeah, good morning, sir. Can you hear me?
Yes, sir.
Yes.
Yeah.
Now we have the prestigious Dr. Venkoba Rao oration. The topic is Lighted to Lighten Educational Incentives in Geriatrics by none other than the young and dynamic Dr. Sureka. I'll first read a small citation regarding Dr. Venkoba Rao. Many of the younger people would have just heard about him, but I had the good fortune of seeing sir at the Madras conference. After that, Dr. Nagender will introduce the speaker or orator, and then we'll hand over the stage to Dr. Sureka. Late Professor Antapur Venkoba Rao was actually born in Andhra Pradesh in a small village, and he was born on 28th August 1927 and reached his heavenly abode on 25th September 2005. His wife and children also are illustrious members of the medical profession. Some of the highlights of Sir, which is a big CV, I'll just give you a few points. He received the Doctor of Science in 1978 from the University of Madras. And Sir was the professor and head Institute of Psychiatry at Madurai Medical College from 1962 to 85. He was the officer in charge ICMR Center for Advanced Research in Health and Disease. He was a visiting scientist to the National Institute of Health, USA, a WHO consultant on psychiatric disorders. And notably, Sir was interested in effective psychiatry in old age, mainly concentrating on depression. He is also the recipient of the B.C. Roy Award in 1981. He has got almost 40 to 50 other awards. With this, I will hand over the mic to Dr. Nagender to introduce the speaker.
Yeah, thank you very much, sir. Let me first thank the organizers for giving me opportunity to chair this prestigious oration. Let me introduce the speaker, Dr. Sureka. She is MD FRCP and currently Professor of Department of Geriatrics, CMC Vellore, a prestigious institute. She is also the editor of the Journal of Indian Academy of Geriatrics. And to her credit, she was instrumental in starting many courses at CMC Vellore. And she used to organize yearly CMEs and other programs for elderly in geriatrics. So she was organizing chairman for year 2019 and currently she's organized secretary for GERICON 2021. So over to Dr. Sureka to continue the oration.
Dr. Sureka, please.
Good morning. At the outset, I would like to thank the Indian Academy of Geriatrics and the organizing committee of GERICON 2021, especially Dr. Raju, for giving me this honor to deliver the prestigious Venkoba Rao oration this year. The topic I have selected, Lighted to Lighten, highlights my passion for geriatrics and medical education. So without much ado, I would like to showcase the educational initiatives in geriatrics thus far. In my talk today, I would be covering undergraduate and postgraduate training, distance education, training at various levels in geriatrics, and research. According to the WHO survey on geriatrics in the medical curriculum, which was brought out in 2002, they have said the basic principles of special care needs of older persons should not be of exclusive concern to specialists. We specialists live in our ivory towers and actually do not touch the common man at the periphery. So, and the next statement is even much more important. All students, medical, everybody must understand and must be able to practice the basic principles of assessment and management of older people. Regarding geriatrics in developing countries, there has been an exponential rise in the geriatric population all over the world. In the developing countries, access to medical care is difficult for this vulnerable age group. There's lack of infrastructure at the governmental and social level to look at the medical, social, and financial needs of this segment of population. In many of the medical schools, geriatrics does not exist as a separate specialty, and it is fragmented into specialist disease-focused care. According to a study which was done in the UAE on students 3 to 5 years, professional years, this was actually a questionnaire which students answered and covered the health of older adults and determinants in the development of attitudes towards them and their career preference. They have noticed significant improvement in medical student knowledge on physical health by the 5th year, but not on mental and social health. Changes in attitudes of students were influenced by parental attitude, childhood experience with older adults, and religious education. They also were told in this particular study that geriatric health and aging topics were scattered in the curriculum. And believe it or not, neither the faculty nor the graduates perceived that geriatric medicine was actually included in the curriculum. 40% of the final years reported increase in knowledge was due to medical education. But of all of them, only 2% opted for a career among older adults. So they came to a conclusion that there is a need to enhance geriatric training and experience in undergraduate medical program. Geriatrics and medical education. As already alluded to, there is no specialized training in geriatrics in most medical schools in India. And of course, this is the lowest low-profile specialty that lacks visibility in academia and finds least favor among medical students. So their options to take geriatric medicine at a PG level is very, very low. Why was geriatric medicine not taught? This is from a study done in 2021. Geriatrics is not in the national curriculum according to this particular study. Older people are not a priority issue. Believe it or not, we are all growing old, remember? And there's lack of interest from the medical school itself. Now, when we want to introduce a curriculum with geriatric medicine, there are a lot of constraints that we face. First and foremost, lack of appropriate training sites, scarcity of qualified teachers with a passion to teach geriatrics, limited financial resources, lack of time in the already overcrowded curriculum, which has been revised recently, negative attitudes, not only of teachers, but of the students and of the public in general They are old, forget about them. Poor recognition of the importance of such training. Now, we have to see that we have to influence the stakeholders who are responsible for making the change. Who are these wonderful stakeholders? It starts at the top, the Ministries of Health and Family Welfare and Justice and Empowerment at both center and state levels, the national and state medical councils, geriatric associations both at national and state level, non-governmental organizations, all the fraternity, medical, surgery, obstetrics, everything at all medical colleges, the students, medical, nursing, allied health, the communities, and the older persons. These are the major stakeholders. And what do we have to actually tell them? The pros of having a geriatrician on board. We can easily treat non-communicable diseases and assess the unmet physical, psychological, and social needs of older individuals, manage multi-morbidity, assess and reduce unnecessary, invasive, and often expensive investigations, and decrease the harmful effects of a high bill burden. We can do a good acute assessment and intervention for older people with frailty, dementia, delirium, and other mental health problems. We can help liaise with other services like orthogeriatrics, surgical specialties, oncology, and palliative care. And we can coordinate the care across all levels, primary, secondary, and tertiary. What more do they want? We can do all this for the older person and more. So we need a national curriculum. It is actually in the process of being developed for the postgraduate course according to the local requirements and healthcare systems. The competencies which are in the curriculum will strengthen the position of geriatric medicine in the context of multi-professional care of older people. And as assessment drives learning, which is the mantra of medical education, the format of assessment should change. But you look at the truth. Every specialty within medicine believes that its fundamental principles should be included in the core undergraduate curriculum and should be accompanied by a compulsory placement. Look at this fort. This fort is very close to Dr. Arvind Mathur. This is in Jodhpur. And basically what were forts built? They are built on a hillock. They are very strong. They keep people safe inside from intruders from outside. So is our curriculum. It is built on a hillock of tradition, which cannot be changed, and they do not allow any intruders in. So how do we access this fort? Look at the story. I'm sure you would have heard the story of the camel and the Arab. I'm not telling you to be as mean as camel, but basically that's this camel who tells this Arab, can I put just my neck inside? It's too cold outside. The Arab says, you may put your neck inside. And the next thing we know, the camel is inside, and guess who's outside the tent? I'm not saying please do this and chuck out the rest of the specialties. No, look at the thing given by Medina Walpole et al. There are 10 steps. Actually, this person in the JAGS has said that all this is like a baseball game they have put it. So I put them down and I've highlighted the things which are important. Cooperate, that is the main thing, rather than compete with other specialties. Develop specific learning objectives and a curriculum map. Develop a working relationship with your medical school, your team, your curriculum committee, the medical fraternity at your school. They need to actually realize what work you're doing. So you must showcase your work. Mentor and encourage your medical students. They are your geriatricians of tomorrow. Look at the evaluation process, the effect of curricular initiatives, and look at what barriers are there to success. And incremental growth is okay. You can't make a sudden paradigm shift. A small growth in the right direction is worth the while. Believe it. So as we were trying to make inroads into this particular bastion of the traditional curriculum, I sent out a letter actually to the pre and para clinicians saying that we would like the students to get a flavor at geriatrics at the undergraduate level. And I actually made a list for the perusal, and I said we would be happy to input any of your departments at any point of time. And it would be appropriate if at the end of each system, each lecturer could highlight the aging changes in that system and how they influence the functioning of the older individual. So to build up what exactly are aging changes in the elderly and what we can do at final year level. So this is just a snapshot of exactly what I have done, how the vertical integration can be done between, and this IM and all is actually from the competency-based undergraduate curriculum from the Indian medical graduate, which is found on the net. There are 3 volumes of it. I've just taken one snapshot. There are about 36 topics which we can actually input it. The other important thing is not just teaching them knowledge, because our people have feelings too. So attitudes, ethics, and communication is a big thing in the MCI and now NMC. So we can actually input. There are many modules in the ATCOM that the medical student has to go through, and we can actually input into communication, the way we interact with relatives and team members, the way we care for the patient and carer, especially those who are undergoing terminal care, and we can showcase the working of a healthcare team. What better place they can learn this than looking at us, because we do this day in and day out. I'm going to speak about 3 other things that we can input into electives. This has become one thing in the competency-based education system that we are following from 2019. Electives for a month in geriatrics, they can perform geriatric assessments, which are so exciting. Dr. Prasad had alluded to some of them. Begin to institute a management plan for common geriatric issues. Understand the role of various members of the interdisciplinary care team, and understand the importance of various services that can be given, either non-governmental or otherwise. And appreciate the non-medical issues in caring for the older patients. Believe me, most of the patients have this as a major criteria, and develop greater comfort in discussing goals of care and advanced directives of patients. I had great problems actually doing this because nobody taught me that. How do you tell a patient that her relative is dead or dying? It was very difficult for me. In clerkship, we usually take bedside clinics, which is just a snapshot of that patient. But in clerkship, where the person, the medical student is with us 24/7 through a month-long clerkship, we can learn to approach care across the continuum of inpatient and outpatient settings. So they actually travel with the patient from the outpatient, the admission, the discharge, and the follow-up in OPD. It is such a fulfilling thing for the medical student, apart from all those that I have alluded to in the electives. And of course, internship is the culmination of all this, and internships have been long valued for providing students with opportunities for practical experience, career preparation, and personal growth. There are many teaching and learning methods, and it's online and offline, and COVID-19 has taught us so many things that we can innovate. So for teaching students, we have lectures, videos, question answer sessions, very interesting ones on, euthanasia, or things like that, panel discussions, seminars, and role plays. You make it interesting. That will strike that spark in your student, believe me. Simulations, case vignettes, quizzes. I remember organizing a quiz for the medical students, and it was such a hit. And the feedback was, I never knew geriatrics had so much to give to the patient. So strike that spark in your student. It is worth it. We should have appropriate handbooks with algorithms, checklists, and assignments, which we have to work on specifically, which makes it culturally relevant to the person. Hands-on, showing them exactly what to do. Shadowing is very important, and community visits, especially to old people care home or to their own homes, the old people's home, to see how exactly they live. And then there is continuing medical education. This has to be followed up. It's not just a one-time exposure. You have to continuously keep reiterating and networking. I think the youth wing of the IAD is actually trying out this networking and successfully managing it. According to the General Medical Council UK's policy document on tomorrow's doctors, they have said there are special problems definitely associated with older people's health. We do agree. Young doctors must learn to respect age and the vulnerability of older people. Graduates must understand human development. Of course, we have a lovely progress growth chart for children, milestones crossed, but this should include growing old. And students must have unique learning of experiences. I mean, I had gone to a old people's home, and that experience really changed me. Opportunities to visit older persons, to hear their stories. It's a beautiful experience of growing with them. But there's an unanswered question that is there, that's actually not even asked. Should there be compulsory attachment to a geriatric medicine unit? The pin drops here. In the US, geriatric medicine training placements are optional. And the CDC agrees that geriatric medical education is the largest education gap in any field in terms of numbers of educators available. And the American Geriatric Society has suggested core competencies that should be included in the training at undergraduate level. This is the position paper of the Indian Academy of Geriatrics, which came out in GIAG in 2020. It was written by Dr. A.R. Rao and Dr. Arvind Namathur and Dr. A.B. Day. Just a small snapshot of it, there's a need to increase geriatric content of undergraduate and postgraduate medical programs, improve attitudes towards geriatrics by medical students, staff, and academic administrative leaders, offer more excellent opportunities in clinical research training, and develop public policy initiatives which will increase geriatric training. They've also suggested to give monetary incentives, but I think incentives should come from within, motivation should come from within, that spark should be ignited. And they also suggested that certification of geriatricians could be intended to provide a means by which family physicians and internists can obtain recognition of their expertise in geriatric medicine. So going on to postgraduate training, we all assume, or we want our postgraduates to have the ability to establish a diagnostic formulation for older patients with appropriate use of history, clinical examination, and investigation. The knowledge, skills, and experience to develop management plans for each patient, individualized, no one quote fits all. It is different for each patient, different in each setting. The appropriate attitudes and communication skills to effectively manage patients and to work effectively within a multidisciplinary team to promote optimal recovery of patients. So assessments here in geriatric medicine are formative and summative. And we at CMC have appraisals for our postgraduates once in 3 months. It's a 360-degree assessment where we actually assess comments on the seminars presented, journal club presentations, the procedures done, and the soft skills. Their presentation on rounds is also looked at, and the last three are the requirement by the university, their progress on the e-journal or their publication, poster and platform presentations, and an update on their thesis. This appraisal is given in writing and sent to the vice principal postgraduate education in CMC Vellore every 3 months for every postgraduate. This is just a snapshot of what we sent to the vice principal. There's also a logbook, and we look at the logbook every time. It would be nice if we could have mini clinical examinations, which is a 20-minute snapshot of either an examination, a communication skill, or history taking. The other one is a direct observation of procedural skills, which should be done to see how well they are performing. This is from the RCP, Royal College of Physicians, and for the geriatrics. And I think all of us should go through this with the students so that the student grows to love geriatrics and the patient grows to love the doctor. So in summative assessments, there's a thesis everybody has to submit. Then there are theory papers in all universities which cover a gamut of geriatrics. In our university, that is the Tamil Nadu MGR University, there's an OSCE, one long case, 2 short cases, ward rounds which are management based, and finally a Viva VOC. But please remember, you have to climb the ladder of formative assessment and then you reach your summative assessment. It is difficult at that point of time to say, you are not worthy to actually get an MD Geriatrics degree. You should have actually done a lot of formative assessments and corrected what is wrong before you send them for their final summative assessment. Because in the end, with that MD degree, they're going to treat you and me. So we have to be very, very careful. Regarding distance education, this has become very the norm now because of COVID. This is not only for doctors, it's also for nurses and allied health people. And we should also think of community level workers. And the language you speak to them, even like regional language, and also the language of medicine that you speak to them is very different. So there have been a lot of inroads by the NPHCE, National Program of Healthcare of the Elderly, the National Health System Resource Center, the National Institute of Social NIST, and the WHO. I think it will be better if all these people get together and do it, present a united front and teach them, because I think that would be a better thing than each one teaching piecemeal what they want to teach. In the DNB, we have to push boundaries. The DNB medicine has the goal of he should be able to provide preventive, promotive, curative, and rehabilitative medical care. So we can use the same platform and give geriatric medicine DNB. I think this is in the pipeline somewhere, but because there are limited ND seats, this should be explored at the earliest. Remember, for all this, you need to train the trainer. That is very important. Doctors in other specialties should realize what is the flavor of geriatrics, what can we do for their patient as a matter of inputs from geriatrics. Well, how can we help them? How can we help quality of life in their patients? They should understand that. How will they understand it? Only when they see the difference in their patients. So you should make a difference in patients' lives for the others to actually understand. For doctors at the periphery, we have to teach them from theory onwards to practice. For an application should be based relevant to their context. Allied health workers and nurses should be able to multitask, should be able to do a lot more than actually they were taught in med school. Community workers should be able to recognize red flags, should be able to do use the basic principles of geriatrics to look after the elderly in their communities. And the most important is student sensitization. I just put up this because most of the time, geriatrics is realized as a stopgap between the grave and the particular specialty. No, it should not be taught like that. Geriatrics is something that we actually input a lot before they reach the grave and improve not only the patient's condition, but also the relative's frame of mind. That's what we aim to do. Teaching and learning methods, we have to talk, not only talk, we have to walk the talk, we have to teach, we have to show other specialties what great things geriatrics can do. We don't need to say state-of-the-art things, just something which makes a small difference in people's lives. Like even doing a PR to get rid of chronic constipation goes a big, long way. Believe me. You go out and teach. Don't teach from a tertiary care center. Go out, teach them. There are so many people willing to learn. There's web-based learning, continuing medical education. It has to be done because it's not a one-stop job. Short-term certification courses will help. I've already alluded to handbooks, which are application-based, and students, you know, the world is theirs, and there's so many things that you can do for students. And at the community level, arrange mailers, upgrade workers, empower that community. Then you will notice the change. Research has always taken a back burner because we're looking at acute care all the time. But research should go side by side. I'm not a research person, but I guess there are some who are very research minded. So there's so many things you can do research on. Etiological mechanisms of aging, socioeconomic support mechanisms for aging, mechanisms to promote healthy and active aging process, and models of geriatric healthcare delivery acceptable. That is most important. and based on our cultural practices and traditions, and they should be scientific and models for medical care in different settings and study of age-related disorders. Many more, I'm sure the research people will bring out a huge list, but these are some of the things that we can focus our research on. I can tell you the ones who lit the spark of geriatrics in my life were not teachers. They were my parents who actually took us to the older people's homes. Till today, I remember getting postcards from my aunts and my grandpa every week to tell me about their life. And I used to send postcards to them to tell them about my life in medical college. So parents have a major role to play towards fostering respect for older adults, but the government has a different focus, raising the capacity of health professionals in geriatric care and developing socioeconomic support mechanisms for older people in the community. So signing off, we have to sensitize the stakeholders. The list I've already produced. Faculty development is very important because they need to know. Learn to teach at all levels, to MD geriatrics, somebody at the community, to a person to look after his foot at the grassroots level. Follow-up is important because people don't remember. I myself forget. So what about blaming others? Begin in your own home and illuminate your corner, illuminate your road, illuminate your community, illuminate everyone who comes in contact with you. It is worth the while. I'm just signing off with a blessing. Please remember, there's God to help you out in this, and you have a mission. You have been lighted. Enlighten your world. God bless you all. Thank you.
Thank you very much, Dr. Surekha. That was an excellent lecture. And as tradition, we don't have any questions. So thank you very much again.
Sir, in the chat box, there is a one compliment for the Surekha madam from the Meenakshi Sharda. It's a wonderful oration, Dr. Surekha madam. Congratulations. Yeah.
Yeah.
Thank
you, Dr. Surekha.
Thank you.
Thank you,
Surekha, I
Dr.
would like to
Surekha, for
thank
your...
you. Surekha, I'd
Yes,
like to thank
Daksha.
you for your excellent talk, your vision for the future roadmap. You have drawn a roadmap to the future geriatric care and also the geriatric teaching. Thank you so much.
Thank you. God bless you all.
Yeah.
Okay.
Thank you, Dr. Surekha.
Thank you.
Can you hear me?
Yes, sir, I can.
Yes, you're audible.
Thank you.
Yeah, okay. Yeah. Because present day, the declining relationship in the family relations, I think your topic has got a real relevance from the professional point of view. All the young medical graduates, as you have already mentioned, the geriatric has got a big role in current NMC curriculum, and students will be benefited from that one. Thank you very much.
Will go. Thank you, sir.
Okay,
Over to
Nagendra sir.
organizer.
Thank you.
Yeah.
We will quickly, already delayed by half an hour, we will quickly move on to next part, that is inaugural session.
Very careful.
So I'll invite all the dignitaries first to join us, sir, and then followed by a little prayer and then welcome address by YSN Raju sir, and order follows. So first I invite our chief guest, sir. He is Dr. B. Karnakar Reddy, sir. He is the Vice Chancellor for Kaloji Narayan Rao University of Health Sciences of Telangana State, situated at Warangal. Sir, Karnakar Reddy, sir. Are you in, sir?
Yeah.
Sir, please unmute.
Are you able to hear me?
Yes, sir. We are able to hear you, sir.
Yeah. So good morning.
And, good morning, sir. Good morning, sir. Sir, then I'll invite the patrons for this Indian Academy of Geriatrics, Dr. V.S. Natarajan, sir. Sir, are you in, sir?
Yes.
Thank you, sir. Thank you, sir. And I invite Dr. A.B. Day, sir. Sir, A.B. Day, sir. I think he has joined, but I don't know.
Namaste. No, sir is there.
Namaste, sir. Namaste, sir. So next I call upon Dr. I.S. Gambhir, sir. Gambhir, sir?
Yeah,
Are you in, please?
Namaste, sir.
Namaste, sir. And then I invite Dr. Arvind Mathur, sir, editor for Journal of IAG. And then I invite the present President IAG, Dr. Prasad Matthews, sir. Sir, are you in, sir? Prasad Matthews, sir.
Yes, he's here, sir. I'm here, sir. I'm here, sir.
Thank you, sir. And then President-elect Dr. Ashish Goyal, sir.
Yeah, good morning.
Ashish
I'm
Goyal.
here.
Yes, sir. Yes, sir. And then Scientific Committee Chairman, Dr. Shanti, ma'am.
Yeah, good morning. Good morning. I'm here.
Good morning, ma'am.
And Secretary for IAG, Dr. Rajendran Magesh. Magesh, sir.
Namaste. Thank you.
Then Organizing Secretary, Dr. YSN Raju.
Chairman, organizing chairman.
So, Organizing Chairman, YSN Raju. Sorry. Raju, sir.
Yes, sir.
So,
Yes,
myself, Organizing Secretary. Thank you for joining the inaugural party, virtually conducting GERICON 2021 with the help of IAG and this Kakatiya Medical College, Department of Medicine, Kakatiya Medical College, Warangal. So I invite you all for this program, and then a lightning lamp session. Virtually it will come, and followed by a prayer song from a medical student from Kakatiya Medical College. Tejasvi, are you there?
Yes, sir. I'm here.
After lightning lamp, please give a prayer song of Saraswati. No, you start the lightning lamp. Yeah.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya deepajyotir namostute. Deepajyotir namostute. Shubham kurutvam kalyanam आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते.
Thank you, technical team. Now, prayer song by Tejasvi, student from Kakatiya Medical College, Warangal. Tejasvi?
Yes, sir.
Please go ahead with the Saraswati song prayer.
Sri Sharada Suraseevita Tvameva Mama Sharanam. Sri Sharada Sri Shrungagirivasini Vani Pranavarupini Sri Sharada Surasevita Tvameva Mama Sharanam. Sri Sharada Samagana Vilolini Nigamagama Viharini Samagana Vilolini Nigamagama Viharini Prema Swarupini Vidyadayini Komalangivara Veena Pani Ragamohini Rasavinodini Hamsavahini Jnanadayini Vangmaya Rupini शारदा
Thank you, Tejasvi. Now move on to welcome address by organizing chairman, Dr. YSN Raju. Sir Raju, sir.
Namaste, everybody. I would like to welcome, firstly, the chief guest, the Vice Chancellor, Dr. B. Karnakar Reddy of KNR University. Then next, I would like to welcome all the doyens of geriatrics in India, starting with Dr. V.S. Natarajan, sir, Dr. A.B. Day, sir, Dr. Gambhir, Dr. Arvind Mathur. And I would like to also invite the President of IAG, Dr. Prasad Matthews, President-elect, Dr. Ashish Goyal, and one special mention, Dr. Vengama Madam, who is the SWIMS Director. Actually, she's so interested in geriatrics, she made her daughter do geriatrics, and she recently passed her Amrita. I would like to even thank Dr. Shanti Madam, Dr. Magesh sir, and other dignitaries of the dais. I welcome all the faculty members, chairpersons, delegates, and the most important, the students. The 18th annual conference of IAG actually was supposed to be held last year, but because of the COVID situation, we postponed it to 2021. And this has been a total virtual conference. This has materialized and seen the light of day thanks to some of the people, especially the encouragement from all my seniors and doyens who said that we should do it. Then it kick-started with a scientific committee with Dr. Shanti, Dr. Tangam, Dr. Usha, Dr. Deepa, who actually made us gain confidence by actually any conference is the scientific program that's most important. And thanks to these people. Then I should thank the organizing committee at the local level, especially special mention for Dr. Chandrasekhar and Dr. Krishna Prabhakar. And last but not least, Dr. Magesh, who is a thorough gentleman and efficiency personified. This conference, there were 400 delegates registered, out of which 150 were students. And we had 30 presentations. Because of the paucity of time, this, I think, is a good number. And what is interesting about this conference is we have a very new set of speakers, topics, chairpersons. And this is going to be an academic feast. And we did not compromise on anything or cut corners. Therefore, we have the thesis awards and presentations, best paper awards in poster and platform. And with this, we are making it as good as a physical conference. I know there are a lot of glitches whenever computers and internets are involved. So kindly forgive us for that. And please sit back and enjoy this academic feast in the comforts of your home. So welcome you all. Namaste.
That's very good summarization, sir. Now moving on to Sir Dr. Rajendran Mangesh, sir. He will give his secretary's report of IAG. Sir, Dr. Mangesh, sir.
Sir, you have to unmute yourself. Unmute.
Sir, unmute yourself, sir.
Thank you. Warm greetings to all seniors in this room. I welcome the chief guest, Dr. Karnakar Reddy. My greetings to chief patron, Dr. V.S. Natarajan, sir. All senior patrons, Dr. Day, sir, Dr. Arvind Mathur, Dr. Gambhir, who are here today with us. And I would like to greet fellow members in my executive committee and thank Dr. Raju and Dr. Chandrasekhar for organizing this excellent virtual conference. I'll go on to read the secretary report. The Indian Academy of Geriatrics was founded at Chennai in 2003. Goals of the organization are to spread knowledge of geriatrics among medical, nursing, and allied medical professionals across our country. We now have a total of more than 1,100 members. The main annual activity since 2003 has been our annual conference, GERICON. Today, we are proud to have the 18th edition hosted from Warangal. virtually. One of the other main branches activities of our organization has been the journal. This is now indexed and the ISI in the International Scientific Indexing, and the journal was granted an impact factor of 1.45. This year, our ICV, which is Index Copernicus value, has improved to 85.11. The journal has been publishing high quality research work. This has been possible due to the eminent members of our editorial board and reviewers. The journal's impact factor has shown significant improvement. This year, we had ICOPE, WHO training program for comprehensive care of older people. Our academy has led the trainers program, which was for Southeast Asian region, with geriatricians from across 6 countries. Similarly, our research wing has conducted workshops and training modules on research methodology. State and local city chapters have been active, conduct regular academic meetings, CME programs aim to educate the family physicians. Today, I would like to thank all the speakers who have given their valuable time to deliver an excellent academic session. On behalf of the IAG, I would like to thank Division of Geriatrics, Department of Medicine, KMC, MGM Hospital, Warangal, Dr. Chandrasekhar and his team for taking this task of organizing an excellent academic feast despite the challenges of short notice and the pandemic. Thank you.
Thank you, sir, for that. And now next I invite Dr. Shanti Madam to report of scientific committee, report from the scientific committee. Shanti Madam.
Yeah, good morning. Respected Chief Guest, Vice Chancellor of KNR University of Health Sciences, Warangal, the Registrar of KNR University, Dr. Praveen, the Dean, Kakatiya Medical College, Warangal, Dr. Mohandas, the Organizing Chairman of GERICON 2021, Dr. YSN Raju, the Organizing Secretary and Joint Secretaries, Dr. Chandrasekhar, Dr. Krishna Prabhakar, the President of IAG, Dr. Prasad Matthews, the Secretary, Dr. Magesh, Dr. Tangam, and our patrons of IAG, Dr. V.S. Natarajan, who is with us now in this conference, and also our founder members, Dr. Arvind Mathur, Dr. Gambhir, Dr. Professor A.B. Day, and all the senior members of IAG, the executive committee members, and all the faculty and delegates who have joined in this e-conference, and specifically the postgraduates from various institutions, and whoever is participating in this e-conference. And dear friends, a warm welcome to all of you. It's my pleasure to be with you all in this scientific conference organized at Warangal on behalf of IAG. And this scientific program is framed in such a way to address the important clinical aspects of geriatric care and the ways to be managed by efficiently by the geriatricians, physicians, and other practicing doctors. So this is in fact a good mix-up of the topics of well-known geriatric syndromes up to the latest advancement in the medical fields. And the speakers also include various international speakers who are indebted to their specialty of geriatrics, and also from speakers from all over India. We felt that newer advances in the field of medicine, and which are applicable to the geriatrics, of like the apomorphine therapy for Parkinson's disease, the role of proton therapy in oncogeriatrics, application of technology in geriatric healthcare will throw light on these areas. And not only that, any practicing physician will face day-to-day problems in the managing the elderly, and the practical day-to-day issues of managing the behavioral problems, psychological problems in demented elderly, managing a chronic and critically ill patients. And this will help us to improve evidence-based knowledge and practice of geriatric care. And also to provide a good scientific buffet to the topics for the 2 days will fulfill the knowledge hunger of the various participants and the postgraduates. And I hope all the delegates will be benefited by these informative lectures and orations. Already we have seen few orations and topics which are delivered in a very nice manner, updated versions, and definitely this is going to improve our knowledge. And this is all because of the efficient and knowledgeable speakers who are with us. And I request you all to extend your support and participation and make this conference a big success. And definitely, I thank the organizing secretary, Dr. Chandrasekhar, for taking this initiative in a short notice. And I hope this should be a big success by all your support. Thank you, one and all.
Madam, I invite Dr. Ram Kumar Reddy, Vice Dean, Kakatiya Medical College, Warangal, because the Dean is in some urgent work, is unable to join the inauguration party. I welcome Dr. Ram Kumar Reddy. And moving on to address by our patrons of Indian Academy of Geriatrics. First, none other than Dr. V.S. Natarajan, sir. Sir Natarajan, sir, please, we want to hear from you, your blessings and all for this conference. Natarajan, sir.
Morning, sir.
Natarajan, sir. Unmute yourself. Sir.
Hello.
Sir. Yes, sir. We could able to hear, sir.
Okay. So, I am Dr. V.S. Natarajan. You know about me, and I'm very happy to join in this GERICON. And now we are in a very critical period, particularly in the COVID situation. After all the group of people, elderly people are the main target of this period. Now the quarantine still continues, not yet gone completely. And still they are threatening about the third wave and Omicron. And what I say in this 1 year corona period, many elderly people still they have not taken the vaccine. Probably they have taken first dose, but not taken the second dose. But I request all the delegates of the conference to convince your group of elderly people and organize meetings, seminars, and request them to have the injection and let them have a healthy aging. Thank you very much for giving this opportunity. Wish you all the best for the success of the conference. Thank you very much.
Thank you, sir. We'll definitely take your message to all the groups, sir, to take the completion of their vaccination. Sir, moving on to, I invite Dr. A.B. Day, sir, to give his address. A.B. Day, sir. Sir, I think sir is joined.
Namaskar and good morning. Respected Vice Chancellor, sir, and my Guru, Dr. Natarajan, and my colleagues and friends on and off the dais. It's kind of a very unusual situation of doing an inauguration on virtual mode, but this is also an experience that one has to have in a 100-year-old, once in a century pandemic. So these are the new experiences of life. I'm extremely pleased to see that despite all these logistics problem, the team has been able to put in place a conference with a huge number of participation, and it's really a very positive development in the field of geriatric medicine in India. The previous 2 years have been very difficult, but our backroom team in the form of the President IAG and Secretary IAG and all their support staff, as well as editor JIAG, have been able to maintain the flow of events and activities in the society, in the academy, so that we are, though the pandemic has put our spirits down, but the activities have been on. I congratulate the team for this very successful conference on a distant mode. It's a new experience, and the two orations I have already heard, and I felt very good that things are moving in the right direction. And thank you for inviting me, and all my good wishes to the conference. Thank you.
Thank you very much.
Thank you, sir. Now I invite Dr. Gambhir, sir, for your message for this conference, sir, and your blessings also. Dr. I.S. Gambhir, sir. Sir?
Yeah. Am I audible?
Yeah, sir. Yes. Audible, sir.
Thank you. I feel greetings. I bring greetings from the abode of Lord Shiva, Kashi, to all of the participants and the organizers. My greetings to respected Vice Chancellor, sir, and organizing chairman, Dr. Raju, Dr. Chandrasekhar, and G. Shanti, scientific committee chairman. I think in this difficult time, this is one of the best things to happen to IAG, because there has been a long hiatus, and last year also we insisted on a virtual conference which could not materialize. But I congratulate. Very grand success. Thank you very much.
Thank you, sir.
Sir,
Thank you very much.
thank you. Thank you, sir. Now I invite Dr. Arvind Mathur, sir, editor of Journal of IAG. Sir, a few words from you, sir.
Thank you very much. Our guest of honor, Dr. Reddy, the Honorable Vice Chancellor, Professor V.S. Natarajan, sir, Professor Day, Professor Gambhir, Dr. Raju, Dr. Prasad Matthews, Dr. Magesh, Dr. Shanti, and all our colleagues. It's our privilege to have this conference due to relentless effort of Dr. Raju and Dr. Chandrasekhar and their team, which has made this GERICON happen. And this is very important event in the Indian Academy of Geriatrics, for which we always look for this annual event. And the interest which the GERICON 2021 has generated amongst our members and others also. I'll say that our students, our practicing doctors, they have all been looking for this particular event. So I wish all the best for the conference, and I thank them and congratulate them also for organizing such important event. I assure everyone that the journal will always be supporting the activities. So I'll request all the speakers, if they could submit their review articles for publication, that will be a welcome thing for us. I wish all the best for the conference. Thank you. Thank you very much.
Thank you very much, sir.
Thank you, sir. So now I call upon a few words from President-elect for IAG, Dr. Ashish Goyal, sir. Sir, Ashish Goyal, sir.
Yeah, a very good morning and my greetings and gratitude to the Vice Chancellor for his august presence and all my seniors for having entrusted me with the responsibility to take up the mantle in the future. It's a delight to participate in the IAG conference once again, although on a virtual mode. But the patience and the effort that has gone in to build this program together and put this event together is extremely visible and most welcome. Thank you, congratulations, and wish you all the best.
Thank you, sir, for your message. And now call upon President IAG, Dr. Prasad Matthews, for his address.
Respected Chief Guest, Vice Chancellor Dr. Karnakar Reddy, Deputy Dean KMC Dr. Ramkumar Reddy, Organizing Chairman and Secretary Dr. YSN Raju and Dr. Chandrasekhar, esteemed ex-presidents of IAG, President-elect Dr. Ashish Goyal, Dr. Magesh, other office holders and EC members and delegates. I'm delighted to speak on the occasion of the 18th annual conference of the IAG. I would like to thank the organizing chairperson and the secretary and the scientific committee, Dr. Shanti and Dr. Isha, putting together a vibrant program at short notice. I'd like to thank Dr. Magesh for all the hard work that he's put in. I'd also like to thank the editorial team, Dr. Mathur, for decades, and Dr. Sureka and team, and Dr. Gopinath for all the work they've been putting into upgrading the journal. With the steadily increasing proportion of elderly in the country, the discipline of geriatrics is becoming more and more important. I'm happy to report that at present there are 8 academic geriatric programs in the country, and I hope that many more may start soon. The IAG has been in the forefront of development of geriatrics in the country, organizing workshops and training programs for healthcare workers and doctors, organizing an annual conference. Our senior members and past presidents have been busy with advocacy with the government to start healthcare programs for the elderly in the country and also increase the number of training programs in the country. At this moment, I'd wish Dr. Ashish Goel, President-elect, and the other officers bearers well as they take the IAG and the discipline of geriatrics forward in the country. Thank you again to the organizers for organizing this program.
Thank you, sir.
Sir, thank you, sir. Now I invite Dr. Ram Kumar Reddy, Vice Dean. Please put a few words. Actually, we want to make this conference as hybrid mode, but because of this Omicron news and all, we couldn't able to. So, but the support from the college principal is enormous. So I invite Dr. Ram Kumar Reddy to say a few words about this conference. So unmute yourself, Ram Kumar.
Oh, good morning, sir. Thank you, sir. And I'm very much delighted to see this program, sir. And we have started geriatric department here with the help of Dr. Chandrasekhar. And geriatrics is the one subject we very much needed for us. And we, the orthopedic surgeons, always strive for the geriatric problems to look after. And nowadays, the geriatrics nowadays is a upgoing subject where you physicians, orthopedicians, and psychologists, social activists, they all should come together and plan the geriatric healthcare in the India of the future. So this is a very good initiative. I very much thankful to Dr. Chandrasekhar and other delegates who participated in this. I wish very much success in this. Thank you very much, sir.
Thank you, sir.
Thank you, Ram Kumar Reddy. Now I invite our chief guest of the day, respected Vice Chancellor, Dr. B. Karnakar Reddy, sir. He is my teacher at my undergraduate days, and he is heading first Vice Chancellor for the youngest health university in our country. And happy thing is that university is located not in the capital of Telangana, but in the Warangal. It is considered the second capital. So in our own campus, Kakatiya Medical College campus. And Sir is a very renowned academician. And with his help, we have started so many new departments: emergency medicine, transfusion medicine. The moment we say, he say yes, and affiliation he will give, and he will strongly fight with the government and NMC. So getting the permitted. This year, we have started geriatric OP at Kakatiya Medical College. But upon the MCA inspection, we have applied for geriatric department. So in this regard, Dr. Karnakar Reddy sir help is immense. So he's as a very good visionary. So sir, Karnakar Reddy sir, please give your message for this conference, sir. Thank you, sir. Karnakar Reddy sir.
Am I audible, Dr. Chandrasekhar?
Yes, sir, audible, sir.
So, right. So, good afternoon, everybody.
Sir, resound is coming, sir. Sir, Karnakar Reddy sir.
How is it, Chandrasekhar, now?
Now it is better, sir.
Better,
okay. So, I'm really happy to be part of today's inaugural function because this is one subject.
Sir, sorry for the interruption, sir. There is resounding is coming. Sir, I think you have
all other participants should unmute it. All other participants to mute it. So only sir will speak.
Yeah.
So now is
why it is coming like that?
Hello.
So rendu device login ayi unnaru sir meeru. Oka device off cheste it will be very clear.
Phone gaani laptop gaani.
So it is showing
now,
two devices.
How is the sound now?
Now it is good, sir.
Right, fine. So happy to be participating in today's function because this is one subject which has been, very close to my heart. And I congratulate the organizing team, Dr. Chandrasekhar and others for organizing this. These are our difficult times due to COVID, and slowly conferences have been, started getting organized in hybrid mode. We had recently few conferences in totally physical mode also. But once again, there's a little bit of, fear of COVID due to Omicron. And see, virtual mode is as good as physical mode, and the participation seems to be more. So impact of so much of COVID, particularly in the medical field, we had lots of challenges. And as geriatric specialists, you must have had the maximum, complications, problems, because COVID has affected the elderly in a very, bad way, and maximum complications because of the high risk and all. And a few, things that have come out of COVID are healthcare infrastructure improvement from government side, and extensive use of IT. Now, because of that only, now we are having this in virtual mode, and the entire medical in the country, even entire education in the country, was on online mode for more than a year or so. And now telemedicine has become quite popular. So it had its advantages and some of the improvements. It has led to improvements in the medical field. Now the importance of geriatrics is going to be on the rise, because we are a very large population, and because of the increased longevity, we are going to be, subsequent to China and Japan, we might become the largest, geriatric population country. And unfortunately, it is the most neglected population in the country. It really saddens one, because our society was previously with joint families and all, where the elderly people used to get the maximum respect, maximum focus in the families. Now with this globalization and then urbanization, nuclear families and all, they have become the most neglected sect. And unfortunately, if you observe, even in educated families, middle class families, what we find is the symptoms of geriatric people are neglected. They think that somebody is complaining of constipation or some other problem. This is because of old age. Somebody complains of weakness. Somebody complains of breathlessness. It is because of weakness. It is because of old age. And that will lead to a lot of delay in the diagnosis of malignancies, cardiac problems and all. So I personally feel that, geriatrics should be treated on par with pediatrics. And when I was an actively practicing surgeon, now probably for the past 5-6 years, I'm not able to practice. Every day there used to be a class for the patient's attendants. Any elderly patient used to come, because for me, mostly the patients used to become their neglected state, diabetic foot and all those things are neglected conditions. I used to ask the entire family to come, and 15 minutes class for them, why they have neglected. And I used to quote them. We had a movie, Tata Manvadu. If Telugu speaking people will know, where the grandson will tell his father that, oh, you are doing this to your father, so I have to do the same thing to you. So those are some of the things. That was the culture. From that we have somehow degenerated, and I feel your organization should again take a lead in getting back the importance of geriatric population. And it's a special status, because as a surgeon also I have seen lot of difference in anatomy, lot of difference in the physiology, lot of difference in the wound healing and surgery. The tissues are so friable, in particularly in geriatric age group. If the amount of force we use, the same amount of force which you use in a normal adult, if you use straight away, you'll enter into the peritoneal cavity when you make an incision. So there is a difference, and there is a need for somebody. The previous speaker was rightly talking about the importance of geriatrics to be taught to undergraduates. And slowly the NMC has recognized the importance. Geriatrics has been included as a subject, specialty subject in post-graduation also. So I hope more and more people will take up that. Apart from that, there is a lot of need for teaching the geriatric subject in all elite healthcare subjects also, like nursing, physiotherapy, and other paramedical workers, so that it evolves as a specialty totally like Western countries. Still, we are in our country, still geriatrics is not identified, not percolated to the society level that geriatrics is a specialty and people have to go to a geriatric person, the doctor, to take treatment. And our government also is taking a lot of care with the introduction of some of the schemes like old age pension and with 104 services providing drugs to non-communicable diseases. Definitely the nutritional status has improved because rural areas, elderly people were neglected. There were lots of nutritional deficiencies, and now government is providing 2,000 rupees per month. It has made a significant difference in their improvement, and the medicines are supplied for hypertension, diabetes and all. So definitely it has led to some improvement in geriatric health. At the same time, now we are planning for about 4 or 5 super specialty hospitals in the Hyderabad, and every hospital is having a geriatric unit included in that, because I am part of the committee. So we have seen to it that the geriatric unit also is, included in that. So what I feel is, from the geriatric society or geriatric association and geriatric physicians, there's a need to educate the population, educate the society about the importance of, nutrition, to prevent all the deficiency disorders like iron deficiency, vitamin nutrition deficiencies, which might lead to all other problems like cardiac problems, neurological problems, musculoskeletal problems. The importance of some moderate exercise, regular control of diabetes, hypertension and all. And from government side, definitely there should be, say, the Telangana state government is planning to have health profile created for all the state population. That will definitely help in a long way, because once health profile is there, we'll know how we are aging. See, if your health profile, we start from childhood, we know what are the problems we are going to face and what are the difficulties. Plus, there should be regular health checkups and health camps for diagnosis of, diabetes, hypertension, malignancies, and neurological conditions, ophthalmic, ear conditions, which are all the problems of geriatric age group. Apart from that, society mindset also has to change. So from the most neglected population of elderly, they should be once again brought into the regular fold, regular family setup, and they should get their nutritional, emotional, and other supports, so that a healthy elderly population, healthy grandparents will definitely lead to a healthy family, and they will, bring up the ethics and morals of the younger generation also. So this is where I feel that geriatric physicians have a very important role, not only in treating the geriatric conditions, in diagnosing the geriatric conditions, but educating the population, educating the family members, and educating the general population. Probably you should have some, we have to take the help of social media in having lots of lectures and all in a simple language, which are useful to everyone. How we can prevent problems, how we can, age in a healthy manner and minimize the problems and all. So this is one aspect where I want all of you to, focus, because not only doing some research into geriatric conditions, diagnosing, treating, but prevention is most important, and changing the mindset of the society, changing the mindset of the governments in providing proper geriatric healthcare is very, very important. And, I'm really thankful to the organizers for giving me this opportunity to share my thoughts, because geriatric medical care was something which is always in the back of my mind. And I thank Dr. Chandrasekhar and organizers for giving me this opportunity to be with you today. Thank you.
Thank you very much, sir. It is a wonderful message. Definitely, we will be thinking, adopting your thoughts, and we will take this geriatric forward into the society also, sir, not only for the classrooms and colleges, into the society also, sir. Thank you very much. And this is the end of our program. I'll say the vote of thanks. I thank Dr. Karunakar Reddy, sir, our chief guest, Vice Chancellor, KNR University of Health Sciences at Warangal, sparing his valuable time Particularly, sir is very busy with his government activities and his Senate meetings and all, but he has spared a valuable time with us and shared his thoughts. Thank you very much, Karnakar Reddy sir. And I thank our patrons of Indian Academy of Geriatrics, the senior most Dr. V.S. Natarajan sir, Dr. A.B. Day sir, Dr. I.S. Gambhir sir, and Arvind Mathur sir for their blessings and their valuable address given to this August gathering here. And at the same time, I thank Dr. Ramkumar Reddy, Vice Dean of Kakatiya Medical College, for present in this inaugural meeting and giving his address. And I thank Dr. Y.S.N. Raju sir for his welcome address and for actively involving and every step in this conference. He is guiding me how to take it forward. Thank you very much, Y.S.N. Raju sir. And I thank Dr. Rajendra Magesh sir, Secretary IAG, for his constant help from the day one it is announcing. Sir was each step how to organize, in which way, how to call upon and all. So for his help is immense, sir. Thank you very much for that and for today's sparing and participating in the inauguration function, sir. I also should thank Dr. Shanti Madam, the Chairman Scientific Committee, for her strength, because all the scientific persons are personal invitation from the Shanti Madam, and they are never refused. And there may be some mistakes from my side because of some miscommunication in getting the phone numbers and delivering the emails. Sorry for that, madam. For without your support, without your guidance, without your intervention, this scientific program wouldn't have been possible, madam. For sincere thanks for that. And also thank you, Shanti madam, for participating in the inaugural session today. And I thank President-elect Dr. Ashish Goyal sir for his valuable advice and presence today. And I thank President Dr. Prasad Matthews sir for his constant help for time to time advices and today's address, today's President oration, so which was very beautiful. So many messages has been taken for all the delegates today. Thank you very much, Dr. Prasad Matthews sir. So I think I
just
haven't
one,
left any.
Dr. Chandrasekhar.
Sir.
We'd like to announce the Best Thesis Award.
Yeah, sir.
Which was
sir,
awarded by
in this,
Dr.
yes, sir. So there are a few awards to be announced. One of such is the Best Thesis Award, which is given by IAG. This year, this goes to Dr. Yamini Ajmera. So it is 10,000 cash prize with a certificate of appreciation. So it is congratulating Dr. Yamini for selected as a best thesis for year 2021 and 22. And because there are 30 oral presentations and poster presentations are there, sir. So judges are there. They will announce the results. In the valedictory function, we will announce the winners on the last day, sir. And anything, sir? Y.S.N. Raju, sir? So shall we conclude this inaugural meeting?
And
So I thank all the delegates also, all the dignitaries who are presenting, because as of now in Hall A, 236 are watching our programs are in live. In Hall B, 93 are watching, sir. Total out of 400 delegates are registered for this conference. 329 are on board, sir. And 28 talks are there, sir. 5 orations and 38 chairpersons, 10 judges, and oral poster presentations are 30, sir. So that is the statistics of this GERICON 2021. Thank you very much for your August presence for this conference, sir. Thank you very much.
Thank you very much.
So with this, we are concluding the inaugural session, sir. And there is a short break of lunch, and we will back to both Hall A and Hall B as per the scheduled program. Thank you again, sir. కాదు, విల్ కంటిన్యూ ఇట్. అప్పుడు లంచ్ లో కల్పిస్తాం. Welcome back for the next session in the hall A. Because first initially it was supposed to be the Neelakshi Mahanti madam's talk now. So, but madam has, because of some untoward, unwanted situation, unavoidable situation, madam is not going to present now. And we were moving on to the next topic, that is by Dr. Babu Narayan sir. Is there life beyond the Parkinson's disease? Sir, Babu Narayan sir, are you there, sir?
Yes, sir.
Krishna Prabhakar.
Good morning, sir. Good morning, sir.
Krishna, you chair the session. Yes, sir. Dr. Babu Narayan sir has come into this, because it is your name is there.
Sir, end of life care.
No, that is late. Now Babu Narayan sir is coming.
Sir,
He's already on that.
మీ సెషన్ కొంచెం పోస్ట్పోన్ అవుతుంది సార్. నేను మీకు ఒక హాఫ్ అవర్ కాల్ చేసి చెప్తాను సార్. అప్రాక్సిమేట్ టైం
ఉందా సార్? సివి వచ్చిందా?
ఒక్క నిమిషం
కాదు సార్, సార్ సివి అయ్యింది.
నీలాక్షి మేడం చెప్తుంది లేదు కదా సార్. మీకు నేను చెప్తాను సార్, ఇప్పుడైతే లేదు సార్. మీకు నేను చెప్తాను సార్. 1 hour లేదు. రైట్ సార్, రైట్ సార్.
So sir CV is not there. You have a CV? Babu Narayan sir CV.
Today morning also I have sent it across, sir, to Dr. Krishnan.
No, just play it, sir. Dr. Krishna Prabhakar is Joint Secretary for API Telangana. Will read out the CV of Dr. Babu Narayan sir. And over to you, Krishna Prabhakar.
Good afternoon all. It is my immense pleasure to read about Dr. Babu Narayan garu.
Dr. Krishna, I have sent a single slide also in your WhatsApp.
Sir, you are not audible, sir. Babu Narayan sir.
Sir, am I audible, sir?
Yes.
Sir, am I audible?
Yes.
Sir, am I audible?
Yes, sir. You are audible, sir.
Can I start the session, sir, with your permission?
Yes, sir.
Okay. Let me share my screen, sir.
Yes, sir. Please share your screen, sir.
Is it visible, sir?
Yes, sir. Visible, sir.
Good afternoon, everyone. First of all, I take this opportunity to thank the organizers and the president of Indian Association of Geriatrics for giving this opportunity in this esteemed platform to talk about my topic. And I take this opportunity also register my heartfelt thanks to Professor and HOD, Dr. Shanti Madam from Madras Medical College, who is also my teacher. And thank you very much, Madam, for your guidance and support and providing this platform to create awareness about the new therapies which are available for Parkinson's disease. I'm basically a physician and I practice general medicine, and I have an association with the geriatrics in terms of working under Professor Natarajan, the legend, attending to some home calls. And he was an inspirational figure to me. With this latest short introduction, I would like to go to the topic, is there life beyond Parkinson's disease? The intention of this talk is to create awareness about the most commonest, second to our Alzheimer's disease, which causes a heavy morbidity among the aging population. That is the Parkinson's disease. We will start with the tale of two patients. One is a 42-year-old right-handed school teacher who is also a shuttlecock player and an athletic, diagnosed as akinetic Parkinson's disease, probably an early onset Parkinson's disease. He was on oral therapy for 3 years, but in spite of his oral therapies, there were unpredictable offs and ons. And as because there was a stigma, because his movements were more restricted, students was calling him as a robo, and he couldn't tolerate that stigma or these comments, unsympathetic comments from the students, and he voluntarily retired from his services. And he was on therapy, on oral therapy, but however, over a period of time, there wasn't much improvement, and he came to us, and we started on apomorphine therapy, and he rejoined. He resumed his passion for shuttlecock, and he is leading a normal life. Another is an 80-year-old right-handed banker, retired banker, diagnosed as PD 4 years back on oral therapy, was highly dependent on attenders for his daily activities, for his mobility, very restricted mobility. He came to us and he responded to apomorphine therapy, and now he is able to lead a self-sustained or a self-supportive care without not much dependence about his attenders. So as we all know, that this Parkinson's disease, which was described by the physician James Parkinson's way back in 1817, is one of the most common neurodegenerative disease, and it affects usual mean age of diagnosis is anywhere between 65 to 70 years, below 60 and after below 40, and it is very uncommon below 40, and the incidence increases after 60 years. Though we restrict ourselves to the classical presentation of Parkinson's disease of bradykinesia, rigidity, tremor, plus or minus postural instability, a lot of research has gone through into Parkinson's syndrome or Parkinson's disease, and we have come to know that in addition to the known factors, there are a lot of non-motor neuropsychiatric symptomatology which occurs pre to our motor symptoms, and they play a havoc on the patient activities of daily living, like constipation, speech, swallowing difficulties, panic attacks, hyposmias, facial expressions, hypotension, impulse control disorders, sleeping difficulties, bladder dysfunctions, then REM sleep disorders. These are a lot of say iceberg phenomenons which is submerged below the motor manifestation of our Parkinson's disease. When we look into the progression or manifestation of the disease, as you could see that right from almost 10 to 20 years before our diagnosis of Parkinson's syndrome or Parkinson's disease, based on its cardinal features, the non-motor symptom starts. Constipation, REM behavior disorder, then hyposmia, then depression, then acting out on dreams. These are the things which happens when he comes to us for a diagnosis of a Parkinson's disease, where we make our diagnosis based on our motor criteria. And from there, it progresses relentlessly, leading on to other complications, motor, non-motor, and neuropsychiatric. All these things are already known to us. When anybody comes to Parkinson's a specialist or our geriatric care or our physician care, usually we put them into any one of the subtypes, right? Either it's a tremor dominant, akinetic rigid, or with postural instability and gait difficulty only. However, this tremor dominant subtype was associated with slower progression and less neuropsychiatric impairment than other two group of disorders. We know that there is a nigrostriatal pathway dopamine receptors degeneration and there is a deficiency of dopamine. So what we usually resort to, we resort to drugs which increases the dopamine level in the brain in terms of levodopa. And we also use drugs which will prevent the degradation of dopa in the brain. So there are two groups of drugs. One is which is a dopamine or dopamine agonist, and another group of drugs which prevents the degradation of dopa in the brain. So this is our usual approach to Parkinson's disease treatment, like levodopa, carbidopa, salicylic, rasagiline, bromocriptine, pramipexole, ropinirole, entacapone and tolcapone, and these are the usual, say, armamentarium which happens. Okay, over a period of time, when we diagnose the Parkinson's disease and start him on treatment, what happens? What happens? What happens is that the disease progression, it is not amenable to our routine oral drugs. Second, there will be, of course, most of the cases, as you are in your clinical practice, you would have seen predictable and unpredictable oftentimes. Then this erratic absorption of drugs from the GI tract leading on to unreliable drug levels in the blood. Constipation and other GI symptoms causing challenges in drug ingestion, absorption, pharmacokinetics, and pharmacodynamics. Challenges with compliance with drug intake with the progression of the disease. This is which we call it as either the patient-related or attender-related fatigue of living with Parkinsonism. Right. If that being the case, why can't we optimize and continue with the oral drug? These are the points. Though levodopa is considered the gold standard for all stages, long-term usage induces motor fluctuations and dyskinesias. And this manipulation of oral therapies in advanced PD is usually non-effective and causes more dyskinesias and wearing of symptoms. And poor levodopa absorption is responsible for different variants of levodopa-induced motor fluctuation, as we would have been witnessed in our routine practice: early manning off, delayed on, dose failure, no on. These are the things which usually happens during our interventions. Dopamine agonists are associated with impulse control disorders and should be avoided in the elderly with cognitive impairment. So these are some of the restrictions we have when we are putting the patient on, say, oral therapies or continuing with the oral therapies. Right. Now the question comes, when a patient is diagnosed with the Parkinson's disease, when he is on oral therapies, and if he is not amenable or it is controllable by the oral therapies, and in addition to it, there are oral therapy induced dyskinesias, do we have a solution? Yes, there are advanced non-oral therapies available. What are the things? There are three interventions which are normally available. One is deep brain stimulation, as we know that it is available in India and it is widely practiced. Apomorphine therapy, this is a new entrant into the market. And third is levodopa carbidopa intestinal gel, which is not available as of now in India. Of course, US, UK, and Europe, it is available. Let us look into the apomorphine. Apomorphine, it was, say, synthesized way back in 1868. Then it went on through different processes, and almost in 1993, apomorphine injection was launched in UK, and it was widely distributed or prescribed, and it is supported by NHS. And now at 2019, it is launched in India. Right. What is this apomorphine? We know that this apomorphine is a derivative of morphine. It is a non-ergot dopamine agonist, right? We know ergot, non-ergot, right? So this is a non-ergot dopamine agonist, and it is highly selective for D2, D3, D4, and D5, and to a lesser extent D1. It activates the serotogenic 5-HT1 receptors as well, but has an antagonistic property in other 5-HT2 receptors and alpha receptors. Why these are important? Because they play a major role in causing the side effects. Okay, then can this apomorphine can be given in an oral form or in an IV form? Although apomorphine has a poor oral availability, which is only less than 4%, subcutaneous administration has a 100% absorption. It is almost equivalent to your IV apomorphine, because IV apomorphine cannot be given. Usually it crystallizes, and the peak plasma concentration is anywhere between 10 to 60 minutes, and around 30 minutes after that, the brain concentration increases. Apomorphine improves the motor function and also the non-motor function. The duration of the action usually depend on dose and method of administration. How it is this apomorphine given? It is given either as an intermittent subcutaneous apomorphine injection or continuous subcutaneous apomorphine infusion. Intermittent subcutaneous apomorphine injection is used as and when needed during the off times, where continuous is used throughout the day using pre-filled syringes. This is the comparison between deep brain stimulation, continuous subcutaneous apomorphine infusion, and levodopa carbidopa gel. As it has been described here, documented here, it has its own indication and contraindication. There were a lot of studies to prove and support that apomorphine therapy is either equivalent or sometimes superior in certain conditions in comparison with DBS, and also in comparison with your levodopa carbidopa intestinal gel in reducing the dyskinesias associated with your oral drug therapies. What are the benefits or what are the USPs of your apomorphine injection? It bypasses the dysfunctional gastrointestinal tract, as because you know that Parkinson's disease is a complex phenomenon. Autonomic failure will be there. Gastrointestinal absorption will be affected. And it has a rapid, reliable on time, can be used as a rescue therapy. Whenever a patient goes in for a freeze, it can be used. And it has a short life and no interference with the basal drug regimen. And it has a well-established tolerability. It not only addresses to the motor symptomatology improvement, but also non-motor disorders as well. So it has a pan benefit. Okay, let us consider, if that being the case, why not we consider DBS, which is also equivalent? Yes, DBS has also its own indication, and it is a very good, say, intervention for certain, say, indications of advanced Parkinson's disease. But however, it is invasive and has its own adverse effects. It reduces the phonetic verbal fluency and word naming speed in medium and long term, versus the cognitive function and neuropsychiatric status. But continuous subcutaneous apomorphine infusion does not affect the cognitive function and neuropsychological function. Sometimes it improves. And ease of usage. This is a pump or pen, like your insulin pen or pump, which can be used, which is external, which is non-invasive, and the learning curve is very, very, very easy, either for the patient or for the care provider. UK NICE recommends considering this continuous subcutaneous apomorphine infection before using more invasive therapies like either a DBS and like your levodopa carbidopa intestinal gel, that is nothing but through a PEG tube. It is a percutaneous endoscopic jejunal tube placement, and through that jejunal tube we will be giving that gel. So it is also an invasive like your DBS. But however, this apomorphine is not invasive. As like every drug, apomorphine has its own side effects, plethora of side effects, and which can be said as local, systemic, hematological, psychiatric, subcutaneous nodules, local allergy, paniculitis, injection site bruising, abscess formation, systemic like fatigue, nausea, vomiting, dizziness, orthostatic hypotension, one of the commonest, mental confusion, yawning, daytime sleepiness. Hematological, it can cause hemolytic anemia. So frequent monitoring once in 3 months, once in 6 months after induction of therapy is needed. And psychosis can be one of the complication if there is a cognitive decline of the patient due to the disease process. And there can be some impulse control disorder as well, but however, less than your dopamine agonist. What is the recommendation? If it is less than 70 years with motor fluctuation or dyskinesia, either DBS or continuous subcutaneous apomorphine infusion. More than 70 years, CSH should be the first choice to be considered. For patients more than 70 years with mild or moderate cognitive dysfunction or other DBS contraindications, CSAs should be considered with reduction or cessation of oral therapy. What do you do? Usually, when the patient comes in, we will do an apomorphine response test. If the patient shows a response to apomorphine, then they will be prescribed either a pen or pump. Current and future apomorphine-based treatment strategies. What are the things which are in the pipeline available for this Parkinson's disease? One is subcutaneous, like I already told you, which is in clinical use, apomorphine infusion and apomorphine injection, subcutaneous injection, already available in India. Then transdermal patch, buccal or sublingual, inhaled or pulmonary, which is in the process of clinical trials. Clinical recommendations. What are the clinical recommendations for apomorphine? On every visit, clinician should ask the patient about the motor and non-motor fluctuation. Insufficient control motor fluctuation and cognitive decline related to non-motor fluctuations or indications for device-aided therapies. The risk and benefit should be analyzed. And if the patient is needing levodopa more than 5 times per day or otherwise troublesome off period, this is one of the main indication for starting or considering apomorphine. What they will cause this apomorphine to provide rapid and reliable relief. For sudden off, we can rescue therapy. Whenever the oral levodopa absorption is impaired, we can use this. For delayed on, we can use the injection. To avoid increasing oral medication and the risk of unpleasant side effects, this can be used overnight off periods alphas or otherwise used with an infusions. When this is not controlled with injections, intermittent injection, we can go in for infusions. The primary benefit is that of people who are not willing for surgical interventions due to their beliefs or contraindication. This apomorphine therapy is a welcome, say this thing. The challenges, of course, there are plenty. One is that awareness about the therapy, acceptance and understanding. Then there are non-communicable disease which will compromise your skin and skin-related this thing. This is a subcutaneous infusion, so we should be careful about it. And the limitation of health insurance coverage. So the take-home message would be provides rapid and effective relief from predictable and unpredictable off. Apomorphine infusion significantly decreases the time spent on off without concurrent increase in dyskinesia. Non-motor, motor symptoms, everything is being addressed by it. It shows promising results in Indian subpopulation, but however, health insurance support is needed to take it forward. Apomorphine pen and pumps are available. This is your pump. This is your vial. This vial goes into this reservoir and it is a continuous infusion. This is a cartridge. This goes into the pen. Where it is being given, we run a unit at Imperial Institute of Movement Disorder, Parkinson's Disease Research and Rehabilitation Center at Chennai, Westminster Hospital, wherein we have a multidisciplinary team of the neurologists with visiting international KOL guidance, physicians, physiotherapy, speech therapist. And this is a process what we undergo whenever a patient comes for our looks into the thing, confirming the diagnosis, ruling out contraindication, doing assessment. And once they are the candidates for apomorphine therapy, we will be starting on apomorphine drugs or apomorphine related device aided therapies. thank you very much for your patient listening. And I once again thank the organizers for providing this platform. Thank you. Thank you very much. Sir, sorry, sir, I couldn't hear you. I think.
Am I audible, sir?
Yes, sir. Yes, sir. Now it is audible. Sorry, I couldn't hear you. Sorry.
Sir, thank you, Dr. Babanarayan, sir. That was a spectacular speech regarding one of the commonest neurodegenerative disorders in the elderly people. And that was a very wonderful center which you have shown. I'm sure quite a good amount of work and research is happening in your center. I appreciate all the good efforts by you, sir. And thank you very much, sir. Thank you for the presentation.
Thank you, sir. Thank you very much, sir. Thank you, the organizers.
Thank you, sir. We have a few minutes to take any questions, if any.
Yes, yes, sir. Yes, sir. Sure, sir. Sure, sir. Sure.
Any questions, audience, please, Dr. Babanarayan sir is ready to answer them. No questions, sir. Sir, as there are no questions, we are, thank you, Dr. Babanarayan sir.
Thank you, sir. Thank you. Pleasure, sir. Pleasure.
And coming back to the session, the other speakers of the session are unfortunately with another preoccupied event, and they're unable to join us today. So this would be the end of session 2. We are going for a lunch break, and we will join you back at 2 p.m. with our session 3 topics. That will be chronic illness, oncogeriatrics, and other topics to follow. So we will see you at 2 p.m. sharp at Hall A for session 3 to begin with. Thank you.
ఈ ఆడియో వినబడటం లేదన్నారు సార్. రాకేష్ రామన్ సార్. Hello?
I can hear you now.
Yeah, sir.
Perfect.
So I'll call you when your session is there.
Yes, that's fine.
I think Uma Kalyani madam?
She's here, sir.
Yes, sir. I'm
Okay.
here.
Okay. Kamala Manohar. Okay. So we are just checking.
Sir, Dashratham sir,
Dashratham sir cheppestam. Just a few minutes, madam. I'll call you. Okay. So good afternoon all. Welcome back for the post-lunch sessions. We are moving on to the session. So the session starts with the talk. Session 3. So by Dr. Uma Kalyani, ma'am, she will be talking about the chronic critical illness. Dr. Kamala Manohar sir is chairing the session. Sir, Dr. Kamala Manohar sir.
Yes, good afternoon, sir.
Good afternoon. Madam, credentials are here, sir. You can start the session, sir. Kamala Manohar sir.
Good afternoon. Thank you for the organizers to giving me opportunity to chair this session as a moderator. As the topic is concerned, it's a difficult topic. It's a frustrating to family and to the doctors also. So Dr. Uma Kalyani is presenting on this critical subject. She studied undergraduate in Tanjavur Medical College in 1989 to 1995. Then diploma in diabetology, Madras Medical College, 1999 to 2001. And completed her MD General Medicine in Madras Medical College, 2001 to 2004. Presently, she is working as Assistant Professor of Department of General Medicine in Madras Medical College. She is also co-author for 2 chapters in clinical evaluation of older patients and quality planning care of elderly in textbook of geriatric medicine, IAG. And she also presented many topics in Indian Academy of Geriatrics in Chennai chapter. I am introducing, as introduced, I'll let the speaker to continue the session.
Thank you, sir. I don't know how to share the video, which file to.
Hello, Dr. Chandrasekhar.
Any problem?
Yeah,
I think you are unable to share
Yeah, share.
There's a green color button there.
So press the green color button, madam.
Okay.
It's not coming.
Share. Yeah, it's
Share
coming
the
here.
screen.
But how to go into my computer, I don't know. Microsoft.
No, just press the green button.
Okay.
Then have you pressed that?
Yeah, it comes at Dropbox, Microsoft OneDrive, Google Drive.
Presentation open cheyali madam. You have to open the presentation. Okay. The technical support team is there.
Okay.
So you can talk. You can talk from there.
Ma'am,
yeah,
actually, like after you opening, there will be a buttons like at the top. It will be basic and right, ma'am. After you clicking on sharing screen,
okay.
like what is the top bar you are looking at, ma'am? Basic, advanced.
Dropbox, yeah, basic, advanced, and files.
So go to basics, ma'am.
Okay, basic.
Click on basics.
Okay.
And there will already be a column called screen, whiteboard,
Yeah,
and iPad,
yeah,
right, ma'am?
yeah, it's there.
Click on share. Click on screen.
Screen. Okay. Oh, now it goes to my screen, is it?
Yeah. No, your
Okay.
screen is visible.
Okay.
Select your PPT, madam. Yeah,
Okay.
it is on. Yeah.
That's visible.
So yes, it is visible, madam.
Okay.
And you go to the slide mode, madam.
Slide.
Slide mode. I think how?
Down.
So this is also okay, madam. You can continue by going down.
Okay. I'll present like this. I don't know where is the slide mode.
The play button, ma'am, down.
Okay, that's okay.
Yes.
Now it's
Yes.
okay.
Okay, it's okay. Just go down. Next slide will come. Okay, madam.
Okay. Thank you. Good afternoon, everybody. At the outset, I thank the organizers for giving me this opportunity. So, just an overview of the case, how critical illness progresses to chronic critical illness. An 80-year-old male with known hypertension, diabetes for 10 years comes to our geriatric ICU with an altered behavior with urinary incontinence past 2 days. He was admitted in geriatric intensive care unit. On evaluations, random blood sugars 340 milligram, and he has right middle lobe bronchopneumonia. So started on broad spectrum antibiotic and insulin. So patient sensorium improved by day 5. We planned the discharge, but on day 7, the caregiver noticed the patient was more dull and sleeping all the time. So now the investigation revealed a serum sodium of 120 milliequivalent. So patient was planned to be retained in ICU for some more days. And after correction of serum sodium, patient slowly improved. But on day 12, the patient became dyspneic and tachypneic. So chest X-ray showed increased opacity in right lower zone. Aspiration pneumonia was diagnosed and the patient was treated accordingly. Since patient dyspnea worsened and oxygen saturation dropped, endotracheal intubation was done on day 15. And by day 20, he still couldn't be weaned from ventilator and a tracheostomy was planned. How to proceed? So this is how a critical illness, a patient has come for a critical illness and now it has progressed to a chronic critical state where we had to retain the patient for more than 2 weeks. So when was this coined, this terminology, chronically critical ill? Our advances in intensive care, medical science have enabled more patients to survive critical illness. But paradoxically, we have created a growing population of patients who depended on who had prolonged dependence on mechanical ventilation and other critical care needs. For this group of patients, Girard and Riffin, they coined this term chronically critical ill in the respiratory care article way back in 1985, where they titled it as whether to save or let them die. So by definition, chronic critical illness is just not an elongation of acute critical illness, but it's a syndrome of significant and characteristic derangement of metabolism, neuroendocrine, neuropsychiatric, and immunological function. So now it not only represents the patient with prolonged mechanical ventilation, but also the patient who needs prolonged critical care for more than, actually, so far a consensus hasn't been arrived as to how long the patient should be in a critical care to call them as a chronic critical ill. Some studies say it's 14 days, some studies say it's 21 days. But roughly, when a ventilation, prolonged mechanical ventilation needs a tracheostomy for continuing ventilation, and the patient ICU stays more than 14 days, we call it as chronically critically ill. So why we should know about this chronic critical illness patient? this patient group of patients need high resource consumption. So studies have shown from in USA at any one point of time, around 1 lakh people suffer from CCA, and the cost of treating them is around goes around $20 billion each year. So that is the resource need of these patients. And these CCA patients, they progress, they have a slow fluctuation, either progression or deterioration. Both occurs very slowly, and it's interrupted by acute events. So physicians, the different mindset are needed to treat this group of patients. They should have an expertise in both rehabilitation and acute care expertise. So the physicians should have a different mindset. And organ failure in these patients, because they are chronic, often requires somewhat different approach than the organ failure in the acute care environment. The outcome of these patients are very poor. The inpatient mortality is around 40 to 50%, and the 6 months mortality is also high. And even if they recover, they have a poor functional recovery. They are chronically dependent. So the outcome is very poor. So culture of care with heavy palliative care influence is critical. And CCA imposes a heavy burden on the families, both emotionally and financially. So it's very important to know about this critical care illness. We don't have any data for critical care illness, but database from United States with a patient discharged under the DRG, diagnostic related to 483. 483 is tracheostomy done for conditions other than head, neck, or facial injuries. Roughly, it translates to patients with prolonged mechanical ventilation. So this is the database. Here we can see the chunk of the patients formed by age group from 65 to 74 years. And you can see the cost that is needed to treat such patients. Median cost in $1,000, around $1,35,000 per year. That is the resource consumption of these group of patients. So what is the pathophysiology of this? Acute critical illness is characterized by the Darwinian principle of fight or flight. So the patient becomes acutely ill, all your stress hormones is poured into the system. The patient either recovers or succumbs to illness. That is the end of the story. But evolution hasn't prepared us for the chronic persistent inflammation. So when in the setting of old age and chronic comorbidity, and if an acute illness occurs, this acute illness can be medical, surgical, neurological, cardiological. Then the patient and we physicians, we propagate this chronic critical illness. So we'll see what are the features of chronic critical illness. So prolonged ventilator dependence, profound weakness attributed to myopathy and neuropathy, alteration in body composition, including loss of muscle mass, increased adiposity, anasarca, neuroendocrine changes like alteration pulsatile secretion of anterior pituitary hormones, impaired anabolism, increased vulnerability to infection, often with multi-resistant microbial organism, brain dysfunction, that is your delirium or coma, skin breakdown associated with nutritional deficiency, edema, incontinence, and prolonged immobility. So this critical illness, it's propagated as by we physicians. How we propagate this? By inadequate antibiotics, either by inadequate dosage or by inadequate timing. By inappropriate ventilator setting, producing ventilator-induced lung injury, fluid overload, electrolyte mismanagement, malnutrition, excessive sedation, and exposure of patient to nosocomial infection risk. So what are the venues where you care for these CCA patients? It either can be an intensive care unit, it can be in a long-term acute care unit, it can be in skilled nursing facility, in inpatient rehabilitation facilities, or in home. So what studies have found is in 1 year, these patients undergo 5 transitions among these 5 venues of care. So that is the erratic clinical trajectory of this group of patients. So now coming to each problem of this. First, ventilator dependence. Why these patients undergo prolonged ventilator dependence? See, we don't give adequate attention to nutrition in ICU setup, especially when the patient becomes critically ill. So this is a highly catabolic state. When you are not going to give adequate attention to nutrition, all your muscles get paralyzed, atrophied, especially your respiratory muscles. So the patient becomes ventilator dependent. And the drugs you use, your sedative, your neuromuscular blocking drugs, those are deleterious. And critical care neuromyopathy, you will see subsequently what is this. So how to prevent this ventilator dependence? Ventilator setting should be lung protective. If you see in Harrison textbook of medicine, there is some list of protocols. What are the lung protective ventilator settings? Your tidal volume should be 6 to 8 ml per kg. Your FiO2 should be kept minimal. Your plateau pressure shouldn't exceed 30 centimeter of water. Those are the lung protective ventilator settings. We should be aware of this. And especially you should give attention to nutrition. And the spontaneous breathing trials, whether that should be used in a chronic critical illness, that's still questionable. Because the spontaneous weaning protocols are devised for acute care illness, but that we cannot translate to a chronic critical illness. These patients should be weaned over a prolonged period slowly. And so far, a consensus hasn't been reached about what is the best method to wean this patient. And studies have found around 25% of patients become chronically ventilator dependent. Whether to abandon weaning in this patient or not, that's also is not known.
No.
So nutritional deficiency. So why nutritional deficiency occurs in this patient? Of course, as I told you before, CCA is a persistent catabolic state, and malnutrition propagated by us physicians, and your neuroendocrine imbalance, more of stress hormones, which contributes to your protein catabolism. So how to prevent nutritional deficiency? You should give special attention to nutrition. You should prevent over or under feeding and your refeeding syndrome. So you monitor for hypoadrenalism, especially when you withdraw them from glucocorticoids. So far, hormone supplements is not advised for this group of patients, controversial. Infection. Why infection occurs? Because of the various invasive devices you use. Because it's a chronic catabolic state, patient undergo immune exhaustion or paralysis. And there's because again malnutrition, hyperglycemia, and inappropriate antibiotics. So these group of patients, they get infected with bad bugs like vancomycin resistant enterococcus, methicillin resistant staphylococcus, etc. It's very difficult to treat. So how to prevent infection? Give chlorhexidine baths for the patient. Environmental cleaning should be done periodically. Immune surveillance program should be followed very strictly. And you should isolate patient, those who are infected, and very simple protocol like hand hygiene goes a long way in preventing infection in these patients. So prevention of ventilator associated pneumonia, you should height of the bed should be elevated. You should minimize sedation, give attention to oral care, subglottis suctioning, and peptic ulcer disease prophylaxis should be done. How will you prevent bloodstream infection? Again, hand hygiene, complete barrier for central line insertion, chlorhexidine usage, proper site selection. Don't put IV lines on the lower limb where there's more probability to get infected. Daily assessment for continuous need for IV line or venous catheter. How will you prevent urinary tract infection? Again, hand hygiene and daily assessment for the need of catheter. So coming to critical illness neuromyopathy. So many studies done regarding this. And these are all the risk factors for critical illness neuromyopathy. Female sex, sepsis, catabolic state, multi-organ system failure, and your systemic inflammatory response syndrome, long duration of mechanical ventilation, immobility, hyperglycemia, glucocorticoids, and neuromuscular blocking agents. What is the pathophysiology of this critical illness neuromyopathy? So patient undergoes axonal degeneration, mainly due to dysfunctional microcirculation. This dysfunctional microcirculation is propagated by hyperglycemia, and there is also sodium channel inactivation. And this muscle necrosis, atrophy occurs due to immobility and thereby protease activation, muscle breakdown. So I don't think this slide is visible for you. Anyway, I'll just tell the approach, how to approach for a critical illness neuromyopathy. Suppose you see a patient not moving his limbs in a critical care setup. First, you see the patient whether it's alert enough to follow your instructions. If the patient is not alert enough, then reduce your sedation dose. If still the patient is not alert enough, then you can go for a CT, MRI studies like that. But if the patient is alert enough to follow your instruction, then do a muscle strength grading with your medical research council scale. If the score is less than 48 and if it's symmetrical weakness, then you periodically examine the patient. Side by side, you advise physical and occupational therapy, and the patient improves, it's okay. If the patient doesn't improve, and also if the patient has a focal deficit with an element type of paralysis, then go for a nerve conduction study and electromyography. You have specific pattern in a nerve conduction study in EMG to diagnose a neuropathy or myopathy. Usually it coexists. Myopathy occurs. It's not either neuropathy or myopathy. It coexists in a critical illness. So how to prevent? Even though I say tight glycemic control, it's walking a tightrope in this patient, because in an ICU setup, patient cannot tell the symptoms of hypoglycemia. So if you're going to give a tight glycemic control, the patient goes for hypoglycemia, is even more deleterious. So this tight glycemic control should be very careful, and reduce exposure to toxins, just neuromuscular blocking agents, and electrolytes should be optimized. Of course, early mobilization. Technology has enabled us to mobilize the patient even when the patient is on ventilator and on ECMO. So you should mobilize the patient as early as possible. Now, studies have found that if even the patient is in ventilator, we mobilize the patient, his hospital stay is reduced. So neurocognitive impairment, delirium. So why it occurs? Because of systemic inflammation, hypotension, electrolyte shifts, sleep deprivation, hypovolemia, and drugs. So how to treat delirium? So non-pharmacological protocol of delirium should be followed first. You shouldn't be enthusiastic in treating the delirium with drugs first. First, you should address all the causative factor for delirium. Sedation should be minimized. You should restore the sleep cycle as much as possible. You should monitor metabolic parameters, and there should be contact with caregivers for cognitive orientation, and of course, early mobility again. So why palliation? We all talk palliation in terms only of a terminal illness. We don't think in terms of a critical illness for palliation. But why we talk about palliation in these cases? This chronic critical illness has a high morbidity and mortality, as we seen before. So this traditional paradigm of palliation, where palliation is on one arm and your life-prolonging care on other arm, that doesn't work for a chronic critical illness. This should go side by side in a CCI patient, because they have high symptom burden. This study is done by Judith E. Nelson. He has done many studies in CCI. He did this in a Mount Sinai Medicine School in a medical ICU setup. What is unique about this study is, even though the number of patients study is very low, only 36 patients, but it's a prospective cohort study. While the patient was undergoing treatment in critical care setup, they were interviewed, chronically critical ill patient who are ventilated or patient who are in ICU for more than 14 days. Those patients were interviewed, and they found this high symptom burden. You should address these symptoms, otherwise patient may not cooperate for your treatment or rehabilitation. So how to treat each symptoms? Dyspnea. So patient perception of dyspnea may not correlate with your objective parameters. So this may delay your breathing. So you should address dyspnea. So we are reluctant to use morphine for dyspnea for other causes other than lung cancer. So we should start using addressing this with morphine. So what is the dose of morphine? It's 5 milligram only in opioid naive patient, and the patient is not opioid naive. You can give 2.5 times dose higher. Pain. So in a critical illness, there are many causes of pain, like arthritis, neuropathy, pressure sores. So and even your endotracheal suction is the most distressing painful procedure in ICU setup, and even a simple procedure like turning in bed and moving the patient from bed to chair is most distressing for the patient. So you should address this pain. Opiates is commonly used. Fentanyl can be used before a procedure, painful procedure like pressure sore cleaning, etc., debridement, etc. Pethidine should be avoided. So non-opioids usually is not found useful, and they have a ceiling effect for their analgesia. Also, they may mask fever because of their antipyretic effect. So this is not advisable in a critical illness patient. So depression, we all think because this patient is chronically critically ill, he is bound to be depressed. But this depression is not universal or normal in a CCI patient. And this depression may worsen other symptoms like your fatigue, sleep disturbance, anorexia, etc. So we should address depression. A simple screening question, are you depressed, provides a very sensitive and specific screening question for depression. So this should be screened, early screened, and it should be treated. So what are the barriers to diagnosis of depression? Of course, social stigma, and the clinicians himself may lack skill, knowledge, and experience to do so. And psychiatrists, even though psychiatrists are available, those with an experience with CCI patients, those psychiatrists are the need of the hour. And even recognizing the need for such consultations lacking among physicians. So treatment of depression, if the patient is in vegetative state, then you can give psychostimulants like dextroamphetamine, methylphenidate, etc. And for other patients, you can give rapid acting drugs like fluoxetine, paroxetine, sertraline. Of course, non-pharmacological treatment like cognitive behavioral interpersonal psychotherapy are effective, But even in normal patient, it's difficult, and all the more difficult in a critically ill patient, very emotionally draining. You should have a committed psychologist or psychiatrist for that. So communication. Why communication is very important? Support study to understand prognosis and preference of treatment was done. What this study has found is majority of patients, they didn't receive any communication regarding their mode of treatment. What most of the patient felt was their treatment was not in accordance to their preference. They preferred a comfort care, but what the treatment they got was not in accordance with their preference. And 25% of patients felt that what approach of care their medical team is taking for them, that itself they don't know. So communication is very important in a CCA patient. So this again is done by Judith E. Nelson in published in Archives of Internal Medicine 2007. He identified 5 domains that are very important for a communication in a CCI patient. So these are the 5 domains: nature of patient illness and treatment, prognosis for outcomes including ventilator independence, function and quality of life, impact of treatment on patient experience including symptom burden, potential complications and treatment, expected care after hospitalization, and alternative continuation of treatment. So what this study has found is for short-term outcomes, they are able to get the information from the physicians. Like for short-term outcomes, for tracheostomy, physicians tell them that they will lose their speech, they cannot swallow for some time. But what about long-term morbidity? They didn't get any information from their physicians as such. And especially one important area which the respondents, they considered is important, like alternative to continuation of treatment. Suppose we offer them ventilator, but the patient is not willing or caregiver is not willing. What are alternative to that? They are not getting such information from the treating physicians. So what are the challenges for the communication? So patient, caregivers, and even physicians, they have unrealistic expectations. And when we wean them on from sedation, patient become conscious, but this gives a false hope that they are recovering, but it's not so. Their critical illness is continuing. And the prospect of life prolongation may be seductive and may distract them from the likelihood of extreme functional impairment, even indefinite dependence on multiple life-sustaining treatment. And impossible to predict. Of course, geriatric patients themselves are a heterogeneous group of patients, and it's impossible to predict the individual prognosis. And consensus about appropriate care goals difficult to achieve among multiple stakeholders. And many clinicians themselves, they lack training and communication skills. And unfortunately, patient preference are only poorly predicted by their surrogates. So, so what is the way, how can you address this? So you should have a patient-centered decision making. To the extent possible, care goals should be established with preference to the patient view of acceptable function of life. So we physician, treating physicians or their caregivers should project their preferences to the patient. We may feel the patient dialysis may improve the patient's condition. We may feel ventilator may be useful for the patient, but if the patient doesn't prefer that, then you shouldn't offer that. So this HELP project, Hospitalized Elderly Longitudinal Project, what it found is elderly patient may value time spent in their usual health, even if they see it as suboptimal, more than they value excellent health if it means shorter half-life. So communication is not a one-time process, it's an ongoing process. Every time their clinical course changes, you should revisit your communication, and you should have a honest and compassionate communication with the patient and the family as and when it's needed. It's not a one-time process. So what's the way forward? So training of physician, the concept of chronic critical illness, more analytical studies to guide clinicians in the care of CCA patient, choosing a venue of care for CCA patient that's resource efficient, and integration of palliation treatment of CCA patient should start early on. Thank you.
Yes. So Dashratham sir, unmute yourself and Sir, Kamalamanur sir.
Yes. Any further questions on this subject can be taken up.
Any questions are there? Audience, please check. No questions. Sir, there are no questions from the audience, sir.
Yeah, okay.
So it's a very good topic, madam. I personally learned so many things, particularly in caring the chronic critical illnesses. So because it is a highly neglected, even for the physicians also. So it is a need of our, particularly in the geriatrics. Thank you, madam, for enlightening us.
Thank you, sir. Thank you, sir.
We'll move on to the next topic. Dr. Dashratham, sir, are you there? Sir, unmute yourself, sir. Next talk is by Dr. Rakesh Raman from UK. Sir will be talking about the oncogeriatrics. Sir, Rakesh Raman, are you ready, sir?
Yes, I'm ready. Thank you very much.
Yeah.
I just need to.
So just waiting for the chairperson, sir, Dr. Dashratham. Dashratham, sir, unmute yourself. Yeah. Hare Krishna. Yeah.
Yes, sir. Yeah. Sir. Where? No, sir. He's there.
But I don't know why he is not coming up. Dashratham, sir.
Sir, మీరు మాట్లాడండి సార్. అన్మ్యూట్ అవి మాట్లాడండి, వీడియో ఆన్ చేయండి.
ఉన్నారా? ఇచ్చారా?
ఇచ్చారు సార్.
ఓకేనా సార్ డాక్టర్ గారు?
దశరథం సార్, ఓకే సార్, మీ వీడియో రావటం లేదు, బట్ వాట్ ఎవర్ ఇట్ మే బి, మీరు యు కెన్
నాట్ ఏబుల్ టు హియర్, స్లో, వెరీ స్లో వాయిస్.
సో వి ఆర్ ఏబుల్ టు హియర్ యు. We are able to hear you, sir, not a problem. So read out the biodata of Dr. Rakesh Raman, which has been showed on the screen, sir.
Hello.
Hello.
Hello, I am not able to hear.
మీరు చూడండి సార్, ఒకసారి మాట్లాడండి.
Hello.
Sir, increase your volume in the
వినపడుతుందా సార్?
Are you able to hear?
Yes, we can hear you, sir.
Hello, sir. Sir.
Chandrasekhar, shall we proceed?
Yeah.
Can I?
Yes, yes, sir. Sir, just read out the biodata.
Do you want me to introduce him?
No, sir. I am Krishna.
Good afternoon. There is some technical issue, Dr. Dashratham. So I'm Dr. Krishna. I would like take this opportunity to introduce Dr. Rakesh Raman Garu. He cleared his MBBS from Madras Medical College and did his MD Geriatrics from Madras Medical College again, and his MRCP in 2003 with FRCR in UK. And he's currently in Kent Oncology Center, working as an oncologist with urological and lower GI tract specialist in oncology. Dr. Rakesh Raman, sir, the stage is yours. You can start your topic.
Thank you very much for that introduction. I'm just going to get the share slide. I hope you can see the slides and
yes, sir. Yes, sir. We could able to see.
Just make that the slide view. Yeah. So thank you very much for the introduction, and thanks to the organizing committee and my friend Dr. Magesh and Dr. Usha and Dr. Shanti for extending the invitation to talk at this conference. I have no disclosures or conflict of interest. I have had to use some of the slides from a recent European Medical Oncology Association meeting, and Dr. Etienne and Dr. Kelsey were the slide providers. So this is the topic of geriatric oncology, where there is a need for a partnership. It is an emerging concept of, everyone knows that there is a need, but there is very little happening around, and there are reasons for that. I'm aiming to hopefully cover the few points in this talk, starting with statistics. You cannot get away from a talk without having statistics bombarded. Then some background on cancer management principles, the unique challenges of cancer and aging. Are there any tools for practice that will help geriatricians and oncologists to work together? The question of what does geriatric assessment add to oncology, and some information on the Indian context of geriatric oncology. So this is a map of the world. The upper part of the map shows the 2015 population distribution. And as you can see, India is in white, which means less than 7% of the population was above 65. Whereas if you look at 2050, the projection is up to 20% of the population is likely to be in the geriatric age group. A similar graph on a change in population, you can see the population of India continues to go up. If you look at the bar graphs, the proportion of patients in the 60 plus category show the maximum increase. Currently, India is a very young country with the majority of the adult population being the younger age group. That is likely to change in the next 10 to 20 years, where the geriatric population will show proportionately greater increase in numbers. In 1965 was when the first combination chemotherapy protocols were developed. And at that point, the life expectancy was approximately 55 years. Over the last 50 years, the life expectancy has gone to 71 years. GloboCan, which is a global organization on cancer data, shown that about 14 million new cancer cases in 2012 and about 8 million cancer deaths. And if you look at that, about 1 million of those new cases were in India, and nearly 700 deaths were approximately in India, which, India is about 17% of the global population. So if you look at the change that is going to happen from an 8.6% population who are geriatric in 2011, it's going to go up to 19% by 2050. And in terms of absolute numbers, that's about just over 100 million geriatric people in India. What about the cancer in the older adults? You can see from 2012, when there were 6.7 million cancer patients in the geriatric, which for the international data, it is about 65 and over. In the Indian context, it is 60 plus, which is the nationally agreed age for definition of the geriatric person. You can see it goes to about 14 million, and 60% of all cancers by that time would be in the older patients. The largest increase is going to be in the Middle East, China, India. And the tumor types that are going to show an increase are the most common tumor types that are seen in India: lung cancer, prostate cancer, breast cancer, oral cancer, and the head and neck cancers. And all this means is it's going to add a substantial economic and social impact, especially in health systems which are of limited resources and limited infrastructure. So this is another statistical graph, a table which shows the change in cancer incidence from 2020 to 2030. That's about a 38% increase in cancer in individuals over 60. And by 2040, in another 10 years, it goes up to about 80%. So there is a significant increase in the next 10 to 20 years in patients over the age of 60 that you are likely to encounter with cancer. And you can see the life expectancy has gone from 54 years in 1981 to 67 years in 2011. So that's the statistics, which basically in a nutshell is that there is going to be a population explosion of geriatric people in India, and associated with that is the increased risk of cancer. So going on to the cancer management principles, as with anything else, you make a diagnosis. Biopsy is required for establishing diagnosis. There are some situations where a biopsy may not be considered. In the tumor that I treat, prostate cancer, a very high PSA and investigations to show that there is spread, like a CT or a bone scan. If that shows there is spread if there are metastases or secondaries, that is a reasonable grounds to treat somebody. But otherwise, Histology is essential to make a diagnosis. Staging involves the usual range of investigations, CT, MRI, if required, a PET scan. And the crux comes down to what is the aim of treatment? And this is the big news for the patient. Is it cure? Is it palliation? Or is it somewhere in between? And then the bigger question to the oncologist is, what is the best evidence-based way to achieve the above aim of either cure or palliation? And what has changed in a big way are establishing guidelines, and there are national, international guidelines on how each stage of cancer has to be managed. And what is even more impressive is the organization, which is called the CEOG, which is the International Society for Oncogeriatrics, has itself established about 35 protocols and guidelines for managing cancer in the older patients. So, it is a lot guideline driven, and there's a lot of interest in developing geriatric oncology guidelines. What are the treatment modalities available to the MDT? In the UK, all of the management is made, decisions are made in a multidisciplinary team. There is the choice of surgery, which is usually reserved for patients who are on a curative pathway. There are exceptional reasons where patients may be operated even if they are palliative, as in an emergency presentation, or if they are likely to die from their acute presentation than from their cancer. Radiotherapy, similarly, in a curative and palliative setting, extensively used. More than half of the cancer patients have radiotherapy at some point, if not at diagnosis, maybe later on. Systemic therapies, and this is where there's been an explosion of options. Chemotherapy has been the conventional backbone. Everyone is aware of that. Hormonal therapies have caught up. There are now, for the hormone-sensitive tumors, breast and prostate, there's a whole range of hormone treatment options. From what was done, used 50 years ago, like the LHRH analogs. Add to that, there are several new generations, second generation, third generation hormonal treatment options. The newer treatments are these biologicals, which are called the targeted treatments. And the even more recent findings are the treatments are these immunotherapy drugs. And that is going to simply transform the way cancer management is going to happen in the next 10 to 20 years. I mean, I wasn't surprised when the two physicians who discovered immunotherapy were given the Nobel Prize last year, because immunotherapy is a hot topic in oncology. Let's not forget there are groups of patients for whom what we call palliative care may be the most appropriate option, where dying with dignity, dying with limited symptoms, as we call it, the best supportive care may be the most appropriate option. So over the last 10, 15 years, what has happened is that almost all of the treatment modalities have improved. And what does that mean? Just means that there is an improved benefit risk ratio. The patients are likely to gain more than suffer from the risks of treatment. And in some of those instances, or in most of those instances, there's also an improvement in survival. For example, in surgery, laparoscopic surgery has more or less replaced open surgery. You have robotic surgery, which is coming through, which is going to help change the way surgeons operate, which means there is shorter recovery time, quicker discharge. The anesthetic care has improved significantly. There's better triage systems. The patients are selected properly. They're offered better pre-anesthetic fitness treatments, or treatments that would improve outcomes, and the way the patients are managed in intensive care. The systemic therapy options that have changed in cancer has improved the tolerability of the treatments. Most of the newer treatments that are coming through have a focus on improved quality of life, reducing side effects. Yes, they come at a cost, but hopefully in the next 5-10 years, when some of these drugs lose their patent, the cost may be less of a factor. For example, the hormonal therapy for prostate cancer, there are 4 or 5 drugs that have come out in the last 5 years, which are all oral tablets, very well tolerated, even in the octogenarians. So, similarly with breast cancer. Targeted therapy, there are some oral targeted therapy drugs, and there are some intravenous Tyrosine kinase inhibitors are a group of drugs, oral drugs, which are used for a range of cancers, kidney cancer, gastric cancer, there's a whole range. Immunotherapy, as I mentioned, is given intravenously, and that is going to change the landscape of therapy. How about radiation therapy? Radiation therapy techniques have changed. Radiation is becoming more and more focused, as we understand that the wider the area of radiation, higher the risk of side effects. So this technique called IMRT, which is highly focused radiotherapy, kind of choosing areas where you want to treat, minimizing areas where you don't want to treat, is an advanced technique. Then even more advanced technique is stereotactic radiotherapy, where it is pinpoint radiotherapy. And even more advanced is CyberKnife. And I can see there's somebody coming up to talk about proton therapy tomorrow in your one of your speakers. So you will see how radiotherapy has gone a long way. And what all this means is patients are tolerating treatment better, which is good news for the older patients where there's always a concern whether there is risk of side effects. So improved techniques of treatment has reduced the risk of side effects. Just a quick slide on targeted therapy and immunotherapy. Targeted therapy works on specific proteins on the cancer cells that are involved in cell growth. The cancer eventually develops resistance. Immunotherapy works by triggering the patient's own immune system to fight the cancer. And this is over the last 20 years. There's the circle on the left, the cartoon shows the various pathways involved in how a cancer grows and spreads. And this was all theory when I was doing my training. It is unbelievable how each of these paths have a target now, and there is a drug. So there is a drug almost to attack any of these pathways, and they're all in the pipelines. A lot of them have come through. Similarly, immunotherapy, the cancer blocks the immune system from attacking it. The immunotherapy drugs unblock it and unleash the immune system to fight the cancer. So this is cutting edge, next generation, what's going to happen, the immunotherapy. So what does an oncologist have to think through when they decide on how to treat? In my mind, the most important is how to optimize the patient's care. It may be cure. How do I increase cure rates? It may be palliation, controlling cancer. How do I help them live longer with the cancer in them? And it starts with what drugs to use, what schedule, how am I going to sequence these treatments? Are there newer treatments? Are there any genomic personalized therapies? So, and how best am I going to manage the side effects? So there is a lot to take on when it comes to a new patient with cancer diagnosis. And that then combined with the current dilemma in geriatric oncology is you can have one end of the spectrum is a treatment nihilism, which is older patients do not receive any treatment for the fear of risk of side effects and making their life miserable. Or the other end is treatment enthusiasm, where older patients are offered non-beneficial treatment in the hope that they would do well. What we are aiming to achieve is the middle ground, where patients are offered treatment that may benefit them. And this is where there is a need for a geriatrician plus oncologist partnership. Because quite frankly, with an oncologist having to think through all those things that I mentioned before making up a decision, there are lots of things a geriatrician can add, can never take away from the contributions. So the oncologist questions are, is my patient going to die from the cancer or from any other cause? What is the risk of treatment? Am I dealing with a patient with impaired cognition? Do I know how well their organs are working? What does frailty mean? Okay, if I have a geriatrician, what does a geriatric assessment do and add to the consultation? Can the geriatric assessment be short? How can I work with a geriatrician? So, cancer and aging, there are some challenges. There are some competing causes of morbidity and mortality. Not everyone ages the same way. There is a lot of heterogeneity. In oncology, there is a lack of data on how best to treat older patients, because a lot of older patients were excluded from oncology trials. There used to be an age criteria of age over 81 was considered an exclusion. And there isn't enough geriatric oncology services. I mean, it is catching up in Europe, it is catching up in America, but still there isn't enough considering the extent of the population that we are going to be dealing with. You're all familiar with this, the aging process and changes. You know, the key changes from oncology point of view is how the body organs handle the drugs. So liver and kidney, there is decreased liver blood flow, there is decreased way in which the drugs are cleared, thereby increasing the circulatory concentration of drug in circulation. The same with the kidney. The GFR starts to decrease as one gets older. So muscle mass goes down. So serum creatinine is not necessarily the best way to assess kidney function. And what it means is all the age-related changes in the body organs result in increased risk of acute illness and complications during cancer treatment. As I mentioned, morbidity and comorbid conditions increase with age. As the age goes up, you will find there is higher incidence of diabetes, high blood pressure, heart failure, and cancer incidence goes up at the same time. So you've got all these competing medical problems that are going to pose a issue for the oncologist making decisions on a patient's treatment. And as I mentioned, competing causes of deaths, not just the comorbidities. In severe ways, the comorbidities can contribute to death. Age itself can contribute to death. So this is a slide which shows the three common cancers. I mean, two of them are relevant to Indian population. Prostate and breast are the commonest cancers. You can see there is always the risk of a comorbidity related deaths, almost matching in some cases the death from the cancer itself. And as I mentioned, aging is a heterogeneous process. Not everyone ages at the same way, in the same way, and not all young people are healthy, and not necessarily not all elderly people are sick and dependent. And the concept of this age cutoff is just to improve awareness. And it is not the chronological age that we look at, it's the biological age, or else we call it the functional age that matters. And you can see from the slide, which unfortunately doesn't project very well, that the first top end is self-reported health status. How many of them consider their age, their health as excellent or very good? There are still about 1 in 3 85 plus who think their health is excellent. What about not receiving any supervision with daily activities? There is still about 56% who don't need any activity help at 85. So let's not forget, not elderly people, not all elderly people are sick and dependent. There are a group of people who are fit and well. That brings the concept of frailty, which I must admit is not something that oncologists are necessarily familiar with. They're aware with the organ changes. They're aware that biological age and chronological age are different. Frailty is a very particularly specific geriatric concept. And it increases with advancing age for the reasons that I have put down there. And what it means is there is a decreased physiological reserve as a result of accumulative decline in the changes in the organ system. And basically what it means is an elderly person can be at risk of reduced resistance to stressors. So a surgery can be a stress, radiotherapy is a stress, chemotherapy is a stress. So the $1 million question is about a fit patient or a frail patient. I mean, these are three pictures that I've taken. The first person with the stick, Shantabai Pawar, she's 85 and is known for her stick fighting. The woman on the right running with Milind Soman is another octogenarian who is known for her running skills and exercise skills. So, you know, it is a choice between the whole range that I have put down here as to who we feel would be ideal for treatments. And there are people whom we don't make any changes at all. So this is the graph which shows what is successful aging, which is the green line. So with aging, the performance remains steady, but we know that is not how everyone ages. There is a normal aging process. So from being fit, they become a bit clinically silent, pre-frail stage. And the last stage is the disabled stage. You can see those red lines are the stressors that may be to do with any acute medical illness or specific to oncology treatment, cancer chemotherapy, immunotherapy, radiotherapy, stress from surgery. All that can reduce and steeply cause a decline in the performance of an individual. So what tools do we have in practice to choose between a fit and a frail patient? You're all very familiar with this. I don't even have to mention it in this forum. The comprehensive geriatric assessment, which is multidimensional, interdisciplinary. It's not just medical needs, psychological and functional abilities is being assessed. And what it helps, the key is the last line. It identifies problems that are not identified by routine physical history and physical examination. So a comprehensive geriatric assessment, CGA, identifies things that are normally missed. So this is just the same in a cartoon way. So you have a screening process, you have an assessment process, and then you create an intervention and then you follow through. So this is the comprehensive. Now this is time consuming. This is exclusive for use of geriatricians. What is often used in oncology is what is called just the geriatric assessment, where there is the screening and the assessment, and where interventions and follow through are not planned. So we stop at the screening and assessment bit. And these are the domains that are normally assessed. You have a whole range from functional status to comorbidities, cognition, polypharmacy, psychological. I don't have to mention any of this because you're all familiar with the various domains that are assessed in a comprehensive geriatric assessment. We stick to geriatric assessment where there is no intervention or follow through. We just stick to screening and assessment. So the first bit was the difficult bit. It is time consuming. It can take up to an hour, if not longer. So there is this screening tool called the G8 screening, which is basically 8 questions. Could take no more than 10 minutes to perform. And it covers similar domains. What do they think of their health? What is their nutritional status, polypharmacy, cognition, mobility, and an abnormal score. So there is, each of those domains are rated, and an abnormal score is less than or equal to 14. So a G8 screening questionnaire has about a 90% sensitivity and about a 60% specificity in picking out an elderly person who could be at risk. There is a similar tool, which is, the G8 is a validated tool. Absolutely no doubts about that. Also emerging is this vulnerable elder survey, which is 13 questions covering 4 categories: physical, activities of daily living, age, and an individual's perception of their own health. And here you can see a score of more than 3 is considered vulnerable. And what it means is anyone with a score of 4 or more is at about a 55% risk of functional decline. And you can see compared to the G8, the vulnerable elder survey score has a higher specificity, whereas the G8 is better on sensitivity. So sometimes these two are run together to make up the sensitivity and specificity. So the next question I put was, is this person going to live long enough to benefit from the cancer treatment, or are they going to die shortly? There are various tools that are available, which are of a good quality prognostic index. Some give you 6 months survival, some give you a 1-year survival data likelihood, but the most often used are the Lee score and the Schoenberg score, which has a long list of questions that you put. It's an online tool, so you put all the information about the patient details. It offers you a choice to offer your impression of the likelihood of this person being alive at 4 years. and then it gives you the answer. So we use this, the Lee score, which, as I put to you, there are several questions. It all comes up on the online drop down, and you fill all of this, and it gives you a final score. And it says, what do you think is the likelihood that the person in front of you is going to be alive at 4 years? And Lee score is often used in the context of oncology decision making. So the next thing comes up with treatment. There are a couple of tools. The most often used is the Cancer and Aging Research Group tool. The reason is chemotherapy is nasty. Everyone knows that. And it is about choosing the right chemo combination, right chemo drug for the right person. So this is a validated tool which uses various things. Again, functional status, medications, age, what chemo are you going to choose? Is it one drug, two drugs? What about their blood parameters? And you can put a score together and create a total score. Higher the total score, higher the risk of side effects from chemo. And more likely, we change the chemo treatment based on this score. So the CARG score is very often used in choosing chemotherapy regimes for older patients. And one thing that geriatricians are very good at, oncologists don't ask in the history, a simple history of a fall. A history of fall in the last 6 months, as you can see here, is scored very highly. And that is a sign of a frail individual and a higher risk of side effects from the chemotherapy. The second tool, I haven't used it much, is the CRASH tool, which again, similarly offers a lot of information. But the CARG tool is the one that is widely used before chemotherapy is considered in older patients to assess whether they are at a serious risk of side effects and whether any adjustments need to be made. So what does geriatric assessment add? Basically, what is the evidence? The evidence is here. This is from 2013, which showed it's a multi-center study, prospective study. Median age was 76, 40% breast cancer, 21% colorectal cancer. And the patients were screened using G8 tool. And if it was abnormal, less than 14, they had a CGA done, comprehensive geriatric assessment. And the interesting thing, geriatric defects were picked up in 51% of patients, which were often not identified before treatment. So a routine history did not reveal any of the issues with the domain I just mentioned, nutrition, fatigue, falls. So more than half the patients in that 1,800 patient study showed some defect in their geriatric assessment. What about for surgery? There is enough evidence from this study that major surgery for cancer patients, 1 in 4 developed postoperative delirium. And a simple test like timed get up and go has a strong predictive factor for post-op delirium. And if it is more than 20 seconds, as you can see, there is a 4.8 times higher risk of post-op delirium. So there is evidence from literature that even after, even in surgical patients, the assessment for geriatric assessment is quite useful. The cognitive impairment, we know cognitive impairment and impact on care. There is increased risk of worsening cognition with treatment. There is decreased tolerance to chemotherapy. As I mentioned, there is increased risk of postoperative delirium and potentially a decreased survival in patients who have cognitive impairment and are put on cancer treatments. So this is a study which looked at, does this geriatric assessment actually impact on treatment decisions? And the short answer is yes. This was a systematic review. 40% of the initial plans had to be modified following a geriatric evaluation. And in 66%, it was with less intensive treatment. Okay, but it did allow intervention in more than 70% of patients. So patients in whom no intervention would have been considered, following a geriatric evaluation, there was a group of patients were identified who would benefit from treatment. So using the tools that I just mentioned, they ran through the tools in these studies that were looked at. And you can see % modification of initial treatment plan based on a geriatric assessment. And this is the most recent data. 2020 ASCO, which is the American Society of Clinical Oncology, had at least 3 trials which showed in various tumor groups that a form of geriatric assessment, it can be a comprehensive geriatric assessment led by a geriatrician, or a geriatric assessment, as I mentioned, reduces risk of chemotoxicity. The last study is the colorectal one, which is published in the British Journal of Cancer, which shows 45% of patients completed chemo successfully without delay or dose reduction in the group that had a geriatric assessment, compared to 28% who had no geriatric assessment. I mean, if this was a drug, if geriatric assessment was a drug, pharmaceutical companies would be on it straight away, because it makes a massive impact on how you can deliver cancer care. But unfortunately, it is not a drug. It is an assessment, it is clinician-led, and there are some challenges. So a lot of studies which have shown clearly a geriatric intervention is better than no geriatric intervention in making decisions about cancer care. This is the big news that is going to come through, which is run by the French group called the PREPARE program, where they were looking at first or second line chemotherapy. After one treatment has failed, second line treatment. And they used the common tumor types. And they were doing in the over 70, after a G8 assessment, if they had a G8 assessment which showed the score was over 14, they were given standard treatment. If their score was less than 14 or equal to 14, they were given standard treatment. That is where the randomization comes to. Or they were given case managed by a geriatrician or a specialist nurse or somebody who has expertise in the field to manage that person in a very specific way. So this is going to be practice changing in the Western world, where there will be greater focus on the need for a specific geriatric orientated evaluation and preparing a treatment plan based on that evaluation. What about the Indian context? There are a few interesting. This is from the Tata Memorial Group, where they were trying, this was in 2015, they were trying to come up with their geriatric assessment tool, which is specific to the Indian population. Again, the standard domains, the usual domains, and with the cutoffs and the scores. So this was the earliest that I could find something on, was from 2015. And then comes this tool, which was more recently published in 2019, again from the AIMS group, looking at an assessment tool which is short and with psychometric validation of an Indian population specific with cancer. This is the paper that was published last year, looking at a geriatric oncology clinic in a tertiary cancer center, Tata Memorial. And in their study of 250 patients over a year and a half that they followed through, only 2% of the patients had a normal comprehensive geriatric assessment. 98% had some domain that was abnormal. And the commonly deranged abnormal domains, the comorbidities was top, fatigue was the next, nutritional status was the third. And as you can see, function and psychological status and cognition came through. 51% of the population in that study had polypharmacy, which was more than 5 drugs. And in about 23%, they were using alternative medications, Ayurveda, Siddha, and the risk of fall was in about half the patient, but actual number of falls was only in 13%. And they used the same CARG tool to assess the risk of side effects from chemo. About 70% of the patients in that study group had at least a 50% risk of having grade 3 toxicity. So in cancer, we grade toxicity as grade 0, no side effects from chemo, fantastic. Grade 1, some side effects, but still managing to do most things. Grade 2, it interferes with quality of life and daily living. And grade 3 requires hospital care. So any grade 2 or more side effect an oncologist will have, because clearly the quality of life is affected. And you can see there were at least 70% of the patients who had a 50% chance of having a grade 3 side effect. The best outcome was that none of these vulnerabilities identified were addressed before these patients were assessed in the clinic. And it was all after the initial setup of the geriatric oncology clinic that these vulnerabilities were addressed. And what about time consumption? It took them about 50 minutes to complete the geriatric assessment, life expectancy, and chemo risk. So it is a time-consuming, labor-intensive process. What they also did was a survey to see what proportion of oncologists actually care for geriatric patients. And you can see 99% of the oncologists in that group cared for geriatric patients. And in fact, 87%. Okay, thank you very much. I'll just finish off with one last slide.
Sure, sir. Thank you.
This is the role and responsibility. An oncologist does cancer diagnosis, does all the treatment, does all the follow-up, curative, palliative, leave that with the oncologist. What does the geriatrician bring in? The holistic view, assessments of comorbidity, life expectancy, the concept of frailty, geriatric assessment, together, which treatment, which dose, which supportive care, where to offer treatment. And that is what, in my opinion, is what personalized medicine is. It doesn't have to be drugs. It can be a simple geriatric evaluation run by somebody who has expertise, which will make a big difference in the outcome. Thank you very much.
Thank you very much, sir. That was an extensive talk regarding oncogeriatrics. We are running short of time, so questions can be asked later in the chat box. We would like to go to the next presentation by Dr. Ashish Goyal. Dr. Rajiv Ranjan, sir, are you there, sir?
Yeah, I am here.
Yes, sir. Rajiv Ranjan. Sir, the stage is yours, sir.
Yeah. First of all, thanks a lot to the organizers for giving this opportunity. I want to introduce Dr. Ashish Goyal. He is the head of department at B.R. Ambedkar Institute at Mohali, and he has been the so-called president of the IAG also between 2022 to 2024. He completed his MPS from Johns Hopkins, and he has more than 100 scientific publications and numerous books. So now I invite Dr. Goyal to give his lecture. Please, Dr. Goyal.
Thank you. Thank you for that introduction, and thank you for inviting me to make a presentation here. Please allow me to share my screen right away. And I'm going to talk today about the role of technology or the applications of technology in the healthcare of the elderly. So this is a WhatsApp meme which has often been circulated, where death comes to take an old man who says, "Let me take a selfie before we go away." And that is how we are accepting or embracing technology these days in healthcare per se. So for the purpose of my presentation here, we are already about 15 minutes late, and I will try to pull us back on schedule a little bit, if not all. I will talk about artificial intelligence as technology, mobile technology. I'll talk about wearable and implantable devices, and then a little bit about big data science and gamification of healthcare. To understand how this is applied to geriatric medicine or the healthcare of the elderly, I would talk under three subheads, which would be prevention and prediction of disease, then detection and diagnosis of disease, and finally, medication and management of disease. So as an introduction, I can just say that active aging is an industry in the United States of America and is working largely under these three broad subheads, which are safety and smart living, health and remote care, and wellness and fitness, and is expected to grow by next year into an industry of about 30 billion US dollars. So for artificial intelligence, there are three things which are necessary. The intelligence learns, reasons, and corrects itself, and has got three major components, which are machine learning, deep learning, and natural language processing. It's been used in healthcare, in diagnosis, in procedures, in prescriptions, and in research. Mobile health was largely limited to messaging or making phone calls, until there was the arrival of the Internet of Things. And when mobile technology was combined with the Internet of Things, what resulted practically was a revolution. So the Internet of Things started off in 1982 when it was applied to the Coke vending machine in the Carnegie Mellon Institute. But now its applications in healthcare have been in health-related advice, in providing improving compliance, prescriptions adherence, improving dietary and exercise guidance, and in improving personal and medical data organization. In fact, the Evangelical Lutheran Good Samaritan Society has partnered with the IBM Big Data team and has included data from sensors, from telehealth and emergency response team, and has been able to detect normal patterns. It is able to check the health concerns and medical conditions of individuals and ultimately predict when a fall may take place, can predict when a person would develop congestive heart failure. Now we are applying the principles of gamification, in which we measure success, share the results, and gifts and rewards to the individual. And these we are applying to different practices in geriatric medicine. And now I'll break my presentation into three parts. That's prevention and detection, prevention and prediction, detection and diagnosis, and finally managing medication. So there is a component of disease perception, prevention, and prediction, which is the first aspect of this. There are virtual applications like a walk through dementia, which will give you 3 scenarios of buying ingredients in the supermarket, when you're going home or making a cup of tea. And it gives a normal person an idea how the life of a person who's suffering with dementia and living with dementia looks like. So when he goes through this, he realizes how difficult the life may be for a person who's living with dementia. Another application like the Ayogo is used to check the and record everyday health parameters. And it has got small activities and games which reward the individual for small changes in their lifestyle and patterns. Then prediction of dementia, it has been seen that use of artificial intelligence-based algorithms are able to predict dementia at least 6 years before a diagnosis is clinically made. Moving to the second part, that's detection and diagnosis. So there is the Whiting's Wi-Fi BP monitor, which can record and sync with your mobile phone. There's a Viatom CheckMe, which sends the data directly to the doctor. Whatever records are made, they are directly shared with the doctor. And then there are the wearable and the implantable systems, which are now much thinner than Band-Aid, and things like BioStam and monitors, which can monitor your vitals, and these can be transmitted wirelessly across to digital portals. The concepts of gamification have also been applied to healthcare systems and healthcare delivery. There are brain training mobile games, which improve performance on MMSE and have shown to give slight improvements in dementia. There is the Akili Evo, in which you play the game, and again, it has been shown that it has shown some improvement in memory and in balance. However, there is also a counter argument which says that most of these games and most of these applications are merely able to improve performance on that particular game or application. And these are not yet, it has been shown with clear evidence that it translates into everyday working life. The automatic speech analysis tool, that's the Pratt Voice Kit, can also detect the cognitive impairment and can identify cognitive impairment and grade it just by analyzing your voice. Things like diabetic neuropathy and has been detected with artificial intelligence and artificial neural networks, and smartphone-based screening in primary care is even possible. Monitoring individuals is another application which is being now targeted in technology. The mobile app accelerometers can detect how much you're walking, can also detect if you have fallen down. And then there is the task fall detector. It can alarm, it can sound an alarm or tell your loved ones that you have fallen down. Similar is the Man Down app, which can send a message to your relatives or friends who have been included in this app that you have fallen down, and then aid can be on its way. Talking about medication and management, yes, the applications of technology have been in managing medications, monitoring and tracking disease, and in mobilizing to improve the function of individuals. So over 500 apps are available today on the Google Play Store, which provide health-related information, and especially in managing diabetes by recording and monitoring your blood glucose, HbA1c, and your body anthropometry. The Mango Health app, in fact, has got links with the supermarkets. And if you have achieved certain targets on your blood sugar levels, then you get rewards in cash flow and in getting your shopping assistance at the supermarkets. So that's just a screenshot of the number of applications that may be available for glucose monitoring. Disease can be monitored now remotely, and the output can be generated from self-recording. And this can be managed and transferred directly to the healthcare providers, while there is real-time monitoring, which can be done from the remote, and there can be home-based care, and hospitals can now be instituted at homes itself. Again, Glucose Buddy is another app which can help you monitor your glucose and blood sugar. The M-App has shown that there is better blood pressure control when there is monitoring by your mobile phones or digitally managed. Game Shows is another app which has shown that there is 40% improvement in memory and thinking, has been developed by the University of Cambridge, and it improves cognitive reserve. So remote monitoring as a concept evolved from gambling and casino security systems and has been applied now to fall detection monitoring and programs of that nature. So My Lively is another application where small sensors are placed on home objects such as pillboxes or shower door sensors or refrigerators, and the door access can be controlled for an individual for a certain period of time. For example, if your blood sugar is high and this is connected with the My Lively app, the refrigerator door becomes locked for you so that you can't take more food till your blood sugar levels come down. So those kind of technological advances and things have been introduced and are now being applied to manage healthcare issues. There are applications like the Timeless or the Nimble or the Iridis, which can engage individuals, especially the older persons. Things like Talking Tomcat or My Reef 3D. Let's look at a few of them. There is the Timeless app, which was started by a young girl who was worried about her grandmother not being able to recognize people. And the mobile app can help you identify and recognize people who are in your address book just when you point the phone to their face, and it allows recognition and improves memory loss. Iridis can take a picture of your home and can suggest and guide how you can make modifications in your surroundings in terms of making it more elderly friendly. WalkJoy is a device which detects peripheral neuropathy just by the way you walk, and it can help you improve the signals that are being sent from the periphery and can help recognize peripheral neuropathy early. Smart Soles by GTX Corp are interesting devices which are insoles into the shoes, which when placed inside the shoe have a GPS which is inbuilt and can guide you to get home. So people living with dementia don't need to worry about getting lost, and the shoes can guide them back home. So I will rest this presentation here and try and save off some of our time. So that's just an image which shows the series of progress that we make with the bottles in our life, how we start and how we end our life. And in the next slide, also now these bottles are increasing, and in the terminal care, the technology has kind of lost the human touch that has been so important in our lives. Now we are adding just another wire of technology into our lives with the Internet of Things. So with that, I put the rest on this presentation. So I talked about artificial intelligence. I talked about mobile technology, wearable and implantable devices, big data science, and gamification of healthcare under an approach with prevention and prediction, detection and diagnosis, medication and management. So I hope I have been able to complete this in time and have been able to save some time for the organizers. Dr. Chandrasekhar.
Thank you very much, sir. It is really wonderful talk. So I think, am I audible? Sir, I think you have taken to all the dream, because how the apps will grow, and it is for both the things, for the good and bad. So, but anyhow, for the geriatrics, its application is really amazing. Sir, any comments from Rajiv Ranjan, sir?
Yeah, thank you, Dr. Goel, for all this excellent presentation. I was just wondering that in next few years, maybe the diabetic people in our homes also it will reach that the fridges will get locked automatically once our blood sugars are high. I mean, these things, I mean, liked it so much. Yeah,
absolutely. The technology is moving so fast that with an iris scan, the fridge will be able to detect what's your blood sugar, and it can get locked automatically. So those things are just around the corner.
Thanks a lot.
Sir, thank you very much, sir. With this, we are completed the session here. Thank you very much for all the speakers and the chairpersons. So we will be moving on to the next session. So that is e-posters 1. So I am requesting judges, Dr. P. Narayana, sir. Sir, are you there? And also Dr. Prem Narasimhan, sir. Sir, please unmute yourself and.
I'm here.
Sir, Narasimhan, sir, very good, sir. Good afternoon, sir. So,
Good
Narayan,
afternoon.
sir. Narayan, sir, call Narayan, sir. Online, but he has to open. Then we will call students. Sir. Narayan, sir, Vinabadutunda, sir?
Yes, I am here.
Okay, sir. Thank you, sir, for joining.
Right.
There are 5 students, sir, for poster presentation.
Yeah.
So one by one we will call, sir. The first is
time limit is there.
Time limit 5 minutes. Poster will be staying, sir, and she will explain within the 5 minutes. And there are 2 minutes question and answers from the judges, yourself and Narasimhan, sir. Prem Narasimhan, sir. And
Let me speak with Narasimhan, Prem Narasimhan.
The Prem Narasimhan, sir.
Hello. Good evening, sir.
Yeah, good evening, sir. I'm here.
So we are both chairperson for this poster presentation.
Yes.
So they have given a mark sheet, and it is very difficult to point out. Grossly, we will put the marks.
Yeah, I think so, sir, because
grossly for visual presentation, visual impression, and scientific content and
yes, sir,
poster.
maybe, sir, we can just give overall marks if that is okay with you.
Yeah. That is enough.
Okay, so we'll do that, and so I think they can start. I think I'm okay, sir.
Okay.
Sir, don't reveal every box, sir. Later on, you give it to.
No, we won't reveal. We
will send the marks to you only.
Okay, sir.
Secretly.
Secretly, because we have to announce tomorrow. Because everyone is there, sir.
No, we will not reveal. We will not reveal.
Okay.
No problem.
Just I'm joking, sir. So shall I call the first presenter, sir?
Yes.
Dr. Niveda Srivastava.
Yes, they have to introduce themselves shortly.
Yeah.
Before presentation.
Dr. Niveda Srivastava.
Yes, sir. I'm here.
Introduce yourself and share your screen to present your poster. And You can talk for 5 minutes. Maximum time is 5 minutes. Explain about all, and then judges may ask some questions. Okay.
Okay,
Niveda.
sir.
Okay, Niveda.
Is my screen visible now?
Yeah, it is. Veda, I would prefer if you also put your video on.
1 minute.
Yeah. And I think can the timers be set according to the posters?
Yeah.
5 minutes.
Yeah. Okay.
Yes, yes.
And 1 or 2 minutes for questioning.
Yeah. So so the technical support can just let us know. So we'll sort.
Okay.
Are you listening?
Yeah, no, you can start. I can't see your slide. Yeah.
So good afternoon. I'm Niveda, Dr. Niveda from Department of Geriatrics from Amrita, Kochi. So today I'm going to present a study on the comparison of clinical presentation across selected age group elderly compared to young individuals with novel SARS-CoV-19 infection. It was a retrospective study, cohort study in a tertiary care hospital in Kerala. So coming to the introduction, it was a COVID-19 infection is a contagious disease causing severe acute respiratory syndrome. So in India, being one of the worst affected nation with this disease, and clinical presentation of this infection is varied and multifaceted. And the difference in clinical presentation between the elderly and young individual was the aim of the study. And the main aim was to study the difference in clinical presentation between the elderly and the younger age group with SARS-CoV infection. And materials and methods, it was a retrospective study. After getting clearance from the ethical committee, based on the proportion of COVID-19 infection observed in the earlier publication with a relative precision of 20% and 95% confident limit, the minimum sample size was 322. Hence, we conducted the study with 330 patients, and data of 330 patients admitted and treated with SARS-CoV-2 infections in the defined period were analyzed. And patients were grouped into two categories. Patients aged 65 years and above were categorized as elderly, and others as younger individuals. So various clinical presentations were studied among these two age groups. And to test the statistical significance of difference in proportion of selected age group, chi-square test was used. And SPSS software was used for the analyzing of the data. And results were total 330 individuals were analyzed, and 263 patients were below the age of 65, and 67 patients were elderly. And patients with elderly group presented with more clinical symptoms, and 30% had cough, 40% had breathlessness, and 20% had patients had fever. And in younger patients, 84 patients remained asymptomatic. But severity of the infections were more in elderly compared to young. And this is a pie chart representing younger age group and the elderly age group, where younger age group were predominantly asymptomatic, whereas elderly presented with more of breathlessness and cough and other symptoms. So discussion and conclusion, from my present study, it was evident that the elderly presented with more clinical symptoms and the duration of illness were longer. Younger patients were predominantly asymptomatic, and it was also evident that more severe infections were presented in elderly with underlying various comorbidity, and death was also more prevalent in elderly. So clinicians and geriatricians should emphasize on meticulous care in elderly age group with SARS-CoV infection. These were my references for the study, and I would like to thank Dr. Alex, Dr. Priya, and Dr. George for helping me with this poster presentation.
Yeah, the comparison she has made, no doubt, but she has not mentioned the comorbid conditions. Comorbid conditions she has not mentioned.
The comorbid conditions, we actually we did the evaluation, but more comorbidities were present in the elderly: diabetes,
But elderly
hypertension.
people associated with diabetes mellitus, hypertension, and all those things. You have to mention, to note down why in elderly people that is symptomatology is more, and especially it was found in my study, hypertension is the prevailing more than diabetes mellitus. So complications are more seen in hypertensive patients. So you have not mentioned the associated comorbid conditions.
So comorbidities were diabetes, hypertension, dyslipidemias, chronic liver disease, and malignancy, which were more among the elderly than in younger age group.
Okay. Yes.
But wouldn't you want to compare it with COVID as well?
Sir?
The prevalence of the comorbidity is okay, but did you also compare it with the fact that in diabetics there were so many with COVID? And
mainly my focus was on clinical presentation, so I focused on more clinical presentation than the comorbidities.
Okay, is there any, no, I mean I mean you're doing an MD in geriatrics, so you obviously will have to always focus in with comorbidities, because comorbidities are the biggest thing which differentiate a young person from an older person.
Yes, sir.
Number one. Number two, is there any reason why you did not take, why did you neglect the age of between 60 to 65 years?
Sir, 60 to 65 years are younger age group. 65 years and above I took as elderly. Below 65 years as younger age group.
No, why did you not take 60 to 65? Because as far as India is concerned, we don't, abroad everywhere it's above 65, but India we always take 60.
According to WHO, 65 years above was elderly. So we took 65 years above as elderly.
Yeah,
and
so I wanted to ask
years,
you that only, that what is the, so you have used the WHO definition. That's okay.
WHO definition.
Okay, and for the comorbidities, what index did you use?
Sir?
What index? Do you use any index to find the comorbidity burden, like Charlson's comorbidity index or anything of that sort?
No, sir. We didn't use any comorbidity indexes.
Okay, fine. Narayana sir, anything else you want to ask?
Yes. But any gender differentiation is there that she has not mentioned?
Gender differentiation. We have not seen, sir. Mostly it was more common in females.
Time is up, sir, but there is also
one question for Niveda from Dr. Uma Kalyani. How did she assess the severity of the illness?
Yeah, how did you assess the severity of illness?
Sir?
How did you assess the severity of the COVID illness?
COVID illness. Assessment of
severity more. Severity, whether the oxygen requirement and the other symptoms, breathlessness, and although
the criteria.
Cytokine estimation, IL-61, CRP, all those things are carried out or not?
CRP, everything, sir.
Biochemical parameters
CRP,
have you taken into consideration?
Yes, sir. CRP, total counts, LSTs, all the biochemical parameters were also checked.
See, the poster would have automatically become better if you would have shown us the severity thing as well.
Okay, sir.
Time is up.
Okay.
Okay, thank you, Niveda.
Right. Next.
Hello. Hello, next speaker, next presenter, Dr. Nigar David. Nigar David, are you there?
Yes, sir.
Yeah. You share your screen to present your poster and present for 5 minutes, and judges will ask the questions. Go ahead, Nigar.
Good afternoon. My name is Dr. Nigel David. I'm doing my final year post-graduation in geriatrics in Christian Medical College. I'm presenting about a retrospective observational study that was done in our Christian Medical College. It's to look at the clinical profile of older adults admitted with acute pyelonephritis in our department of geriatrics. Background of the study
Just
is
before
that,
you go ahead, I'm just telling everybody who's going to present, it would be always better if you are showing your video. If you have a connection problem, I can understand, but it's always better that you present yourself to the judges in person through showing your video. Yeah.
Yes.
Go ahead.
On your video, Nigar.
Acute pyelonephritis is one of the most common cause of a community
Loudly speak.
Community-acquired bacteremia in hospitalized elderly patients. Many comorbid conditions and decreased immune and physiologic function can make an elderly susceptible to a UTI. And UTI symptoms or signs of infection can be atypical and vague in elderly adults, even in severe infections such as acute pyelonephritis. So the objective of this study was to investigate the clinical and the microbiological data of older adults admitted with community onset acute pyelonephritis who were hospitalized in this tertiary care center. This is a observational retrospective study. This was conducted in the Department of Geriatrics, which was done between 1st of November 2018 to 31st October 2019, and patients who were admitted with acute pyelonephritis were included in this study. There were a total of 1,256 admissions during this time period, out of which 94 were admitted with acute pyelonephritis. The mean age of the study population was 75.4, with 45.7% of females and 51% males. And the average duration of the hospital stay was 9.6 days. Out of these patients who presented, for 53, that is 56.4% had ESBL producing strains, and 24, that is 25.5% of percentage of patients had bacteremia. Of this clinical presentation, 69% patients had fever and urinary symptoms, 78. The point I had to stress on here is that 15 patients did not have any fever at presentation. That is 15% did not have any fever, and 6 patients presented with just delirium. That is, they had no fever or urinary symptoms. They just presented with the delirium to the healthcare setting. So, which actually emphasizes the thing that elderly patient may not classically present with a urinary symptom with a fever to say that it's actually acute pyelonephritis. And also comorbidity wise, diabetes and hypertension were more prevalent, of which hypertension, 80 patients had hypertension and 75 had diabetes. Among the patients treated, the choice of antibiotics as an empirical one was meropenem, and followed by peptides. The existence of the ESBL being 25, out of those positive urine cultures, 53 were ESBL producing stains. So, which actually tells the emergence of a drug resistance in the community itself. Outcome wise, there were 79 alive. Death was around 12, with 13 discharged against medical advice. Among the urine culture also, E. coli being the most predominant bacteria that was grown in the culture, followed by Klebsiella. And so I conclude the study. Finally, we concluded that there was significant mortality associated with acute pyelonephritis in older adults, and the presentation of UTI in the older adults may not be typical, and they may just present with delirium and may not have a typical UTI symptom also. And the emergence of a drug-resistant bacterial stain was evident from this study. I thank Dr. Benny Paul Wilson, my guide, for being with this study.
Yeah. One important thing I want to mention you have not mentioned anything that these patients previously admitted for some maneuvers in the hospital, so they may acquire hospital-acquired infections. So that history you have not taken and not presenting. Have you understood the question?
Yes, sir. Yes, sir.
So previously, how many people were admitted for some other procedures? That is also very important because hospital-acquired infections are resistant to antibiotics, and that if you had included, that should have been better.
Okay.
Anything, Prem Nasimha?
Yes, sir. Can you tell me what new thing have you told us by the study? I already know, I mean, most people know people can have delirium. There might not be fever, drug resistance is there. So what is the new thing that you're adding to the already gained knowledge?
Delirium was due to septicemia, is it?
Yes, sir. Yes, sir. Secondary to septic encephalopathy.
What encephalopathy?
I mean, as a septic encephalopathy.
Okay, septic encephalopathy. Okay.
Actually, sir, I mean, among geriatrics, we are aware of this delirium being one of the presentation of like any infection, but that's not. I mean, this is not. People are not aware of it. Like even when we discuss with our radiologist here, like the patient is in delirium and we need a emergency ultrasound to rule out some infection. People still think that there is no fever and the counts is still low. And how can you meet an emergency for this? So I think that still, even among the medical background people, still that atypical presentation among the elderly is not well established.
Okay, you said ultrasound. What were the ultrasound findings? Did you do, because you have not mentioned anything about ultrasound?
No, sir, I haven't mentioned. But no, sir, I mean, as an example, I said, sir, like.
No. Did you do ultrasound in these patients? I'm sure you must have, no?
Yes, sir. Yes, sir. We did an ultrasound, but I haven't analyzed about the ultrasound studies in this.
Can you tell me how ultrasound will help in these conditions?
No, sir. To like a patient who presents with the delirium, we usually ask for an emergency ultrasound to rule out any intra-abdominal focus for an infection. But unless there's a pyonephrosis, any complicated UTI, there's no use of an imaging per se.
Chronic pyelonephritis, how many people are having chronic renal failure in this category?
Did you understand what sir is saying to us?
CRF, chronic renal failure was there in these people?
Yes, sir. 33 patients had CKD, sir.
CKD. Yes, so definitely, when CKD is there, the mortality will be very high, no problem. Okay.
Okay, there are a couple of questions.
There is a comment for you. Uma Kalyani madam is asking that your objectives are different from your conclusions. How it is possible?
And also there is no mortality data in your slide. So did you mean mortality or did you mean morbidity?
Mortality was 12.7% was the mortality in my studies.
No, but you didn't really sort of try to tell that in a big way. You just said mortality was more. Okay. And
okay.
Okay, Nizar, David. We'll move on to the next poster presenter. That is Dr. V. Manoj Reddy.
Yes, sir. I am there.
You are there, no?
Yes, sir.
So you share your screen with your poster and start your presenting. You have 5 minutes time.
Yes, sir.
Okay, Manoj.
So, good afternoon, sir, and good afternoon, everyone.
Can you share your poster?
So, I have shared, sir.
Yeah.
Is it visible, sir?
Yeah.
Yes, now it is visible.
Yes, sir.
Sir,
I'm Manoj Reddy, final year medical postgraduate from PES IMSL, Andhra Pradesh, Kuppam. Today I'm presenting a
Can you make it into a screen, full screen?
Full screen. You make it a full screen.
So I
On
have
the
mailed.
no, near 73%, can you see a logo?
Yes, sir.
Down. So just press that and it will become full screen. This one, this here.
Yes, this one.
Not able to do it?
No, sir.
Because it's too cluttered for us. Anyways, you continue. It's okay, continue.
Coma
Continue.
vigilant
Using time.
case report.
Yes, sir.
Okay, carry on.
Yes, sir. Today I'm presenting an interesting case of locked-in syndrome, sir. Locked-in syndrome is a devastating rare neurological condition in which there is a complete paralysis of all voluntary muscles except for the ones that control vertical movements of the eyes. Patients are conscious and cognition is unaffected. It is also referred to as de-differentiated state, pseudocoma, cerebromedulospinal disconnection, and coma vigilante. Coming to the case report, a 64-year-old man with no known comorbidities and a significant history of smoking and alcoholism was brought to ER with a history of giddiness and vomiting the day prior and sudden loss of consciousness on the day he presented to ER. He was intubated in view of low GCS, that is 4/15, and impending respiratory failure. Blood pressure was 230/120 millimeters of mercury on arrival, and injection labetalol was given. All the four limbs were flaccid and plantars were mute at the time of presentation. Hypertensive emergency with intracerebral bleed was suspected, but CT plane was normal and subsequent blood pressure readings were normal without using any antihypertensives. After about 36 hours after admission, he regained consciousness and was opening his eyes spontaneously. He was quadriplegic, had no facial movements, but only vertical eye movements and blinking were present on examination. So we subsequently had done the MRI brain, which showed infarcts in midbrain, pons, bilateral cerebellar hemispheres, and left thalamus, which are shown in the images in the slide, sir. So diagnosis of acute locked-in syndrome was made, but his family members wished to take him to home, and he was discharged against medical advice. These are the images showing infarcts in the midbrain, pons, bilateral cerebellar hemispheres, and left thalamus. Coming to the discussion, our patient had initial loss of consciousness, but once he regained consciousness, he was aware of his surroundings, but he was unable to move his limbs or facial muscles. Only vertical eye movements were present. Locked-in syndrome should be differentiated from persistent vegetative state, wherein patient may be awake without awareness. It is due to bilateral ventral pontine lesions, of which most common is partial basilar artery thrombosis. It is a clinical diagnosis. MRI brain, as we have done in this case with diffusion weighted imaging, will show acute infarcts. EEG cannot definitely identify awareness, but normal EEG in an unresponsive patient will help differentiate locked-in syndrome from persistent vegetative state. Coming to the conclusion, geriatricians should be familiar with locked-in syndrome because of high incidence of stroke and increasing post-stroke survival in elderly. Currently, there is no standard treatment of care for locked-in syndrome. It is only supportive, and medical management is as for any stroke. Eye-coded communication should be established with the patient, and early multidisciplinary rehabilitation is helpful. This concludes my poster presentation. I thank my professor, Dr. Betsy Matthew, for helping me in presenting this.
Yeah, what is the definition of locked-in state syndrome? Where you will get which condition you will get in textbook description? Locked-in state is described in which condition?
So it is seen in bilateral ventral pontine lesions, sir.
The commonest condition is bacillary artery thrombosis.
Yes, sir.
Bacillary artery thrombosis can produce the bilateral ischemia. You will be there, bacillary artery thrombosis, and if you timely you do angio and you can do some catheterization and embolectomy, if you carry out, total recovery may be present. If patient presents within 4 hours or 5 hours or 6 hours, the bacillary artery stenosis is the commonest cause for locked-in state that is described. And we are saying ischemia is there in the brain and all those things surroundings. It is suggestive of basal artery thrombosis only for me. And at least thrombolytic therapy may be helpful in this patient. Early stages, if patient comes within 3 hours, you can give thrombolysis therapy and recovery may be faster.
Yes, sir.
Our interventional embolectomy also some centers are doing for that.
Yes, sir.
So what is your comment, Dr. Prem Narasimhan?
Was a carotid Doppler done for him?
So carotid Doppler is showing a no significant stenosis, sir. It is around the 50% stenosis, sir, not more than 70, sir.
No. 50 where? Both, single?
Common carotid or internal carotid?
Internal carotid.
It is showing in the common carotid, sir.
One side or both sides?
On both sides, sir.
Both sides.
Yes, sir. He presented to us within 2 hours only, sir, but because our center is a rural tertiary center, we couldn't carry out thrombolectomy, sir.
Okay. I mean, just a very general question. How would you explain the relative that the patient is actually in a locked-in syndrome? Because they will ask.
Yes, sir. I tried to demonstrate, like, as the patient is conscious and he is able to communicate with us with the vertical movements of the eye blinking, I'll first try to explain the patient regarding that to communicate with me using those signals, like eye-coded communication. So I will explain the patient regarding that this is a type of paralysis where all the muscles are paralyzed except for but patient is aware of the surroundings. I'll show them, I'll ask them to ask the patient whether if he understands the question or if he understands the if he wants to give the answer give it by blinking of the eyes or by nodding, by moving the eyeballs.
Okay.
Okay, thank you.
Okay.
Thank you, sir.
Okay, Manoj Reddy. And we will move on to the next presenter, Dr. Bhim Rao Bose. So, Dr. Bhim Rao Bose, are you ready?
Yes, sir.
Yeah. Share your screen and present your poster.
Good afternoon, sir. I'm Dr. Bhim Rao, doing second year postgraduate in Madras Medical College, Geriatric Medicine. The topic is the evaluation of nutrition status in elderly population. A, to estimate the prevalence of malnutrition in elderly population aged 60 years and above, attending the outpatient department of Geriatric Medicine at Rajiv Gandhi Government General Hospital. Methodology, the cross-section study was conducted and data collected by simple random sampling among 100 elderly who are 60 years and above the outpatient using any nutritional assessment structured questionnaire after obtaining their consent. Patients with cognitive impairment, aphasia, and severe hearing loss were excluded. The mini nutrition assessment is an 18-item questionnaire comprising of anthropometric, which include body mass index, mid-arm circumference, calf circumference, and the weight loss effect. Combined with the questionnaire regarding the dietary intake, which includes number of meals consumed, food and fluid intake, feeding, autonomy of feeding. And the global assessment includes the lifestyle, medication, mobility, presence of any acute stress or presence of dementia, depression, and a self-assessment, which includes self-perception of health and nutrition. The mini nutritional assessment is scored as 24 to 30 points as normal nutrition, 17 to 23.5 points as at risk of malnutrition. Less than 17 points are categorized as malnourished. Results. Of the 100 participants, 76 were male and 24 were female. The mean age group was 67. From the above study, 20% of the patients are found to be malnourished, 50% are at the risk of malnutrition, and 30% are found to be of normal nutrition state. Among the age group 60 to 70 years, 58% are at the risk of malnutrition and 10% are malnourished. Among the 70 to 80 age group, 31% are at the risk of malnutrition and 54% are malnourished. Among the gender, in the male, 40% are at the risk of malnutrition, and 50% are malnourished. Female, 42% are at the risk of malnutrition, and 30%. Among considering the comorbidities, those who have having greater than 2 comorbidities, 15% are at the risk of malnutrition, and 40% are at malnourished. Those who are having less than 2 comorbidities, 56% are at risk of malnutrition, and 12% are malnourished. We take into consideration the polypharmacy. 15% are at the risk of malnutrition, and 30% are malnourished. Among the patients with no polypharmacy, 22% are at the risk of malnutrition, and none are at malnutrition. Conclusion: the mini nutritional assessment was and healthcare programs rapid and reliable evaluation of the nutrition status of the elderly to recognize those at risk of malnutrition, take appropriate steps to prevent further malnutrition or malnourishment. It also helps in identifying the malnourished persons and take immediate action, thereby preventing the further deterioration of the malnourished states. I would like to.
You're finished early. Do you want to say anything more?
No, that's all.
Okay. Narayan sir, please.
This is it is somewhat difficult to assess malnutrition in elderly people because sarcopenia and all those things will be present relatively. It is not that easy to assess nutritional status like young people. So, how you have taken the parameter to say that patient is having undernourished? Arm circumference may not be ideal. Sarcopenia will be present, isn't it?
Yes, sir, but I have taken into account the anthropometric measurement of body weight circumference of and any weight loss.
BMI you have taken, huh?
Yes,
the
yes,
BMI.
Sir. Yes, sir.
So what was the average BMI you had to take normal in elderly people? Average BMI. Less than that, you can put it as undernourished.
Less than actually
mean BMI.
Okay, I was taken into account the score, sir. Less than 19 are considered as 0, and 19 to 21 are considered as 1, and 21 to 23 are 2. More than 23 or greater are considered as 4 to 3. On the scoring basis, I came to the final conclusion.
Okay, when you considered that a patient is undernourished, basing on the BMI.
For a elderly population, only BMI can't take into account. They have taken all the parameters like dietary intake and the lifestyle and the comorbidities, and also the self-assessment of the patient also taken into consideration.
Yeah, one more thing that skin fold thickness also you can measure skin fold easy. Skin fold thickness that indicates subcutaneous fat and all those things is also another parameter you can take very easily, isn't it? Okay, but the nutritional status, it is due to lack of nutrition or patient is having comorbid conditions?
The comorbid condition plays a major role, sir, in the nutritional status of the patient. As we see, with more than 2 comorbidities, most of the patients are at risk of malnutrition or malnutrition.
What is the most common comorbid condition?
Sir, in our setting, most of the patients comes under hypertension, diabetes, and coronary artery disease. With a few of them at CKD and the CO.
Yeah. Is it a village population or a city population, urban population?
So mostly urban population.
Urban population only. Okay, comorbid condition makes a big role.
It's a big role, sir, which also plays a role in the polypharmacy.
Okay. Nutritional status, what kind of nutrition they are taking? That is also important, you know.
Yes, sir. We ask in the
vegetarian, non-vegetarian.
Yes, sir. We take into account the dietary intake, sir. We ask for the amount of protein intake and the carbohydrate intake also we ask for this, sir. Any meat, fish, poultry, like that also we take into the account, the assessment.
Okay.
And the fruits, vegetables.
Okay, sir.
So patients with cognitive impairment, aphasia, and severe hearing loss were excluded. So by cognitive impairment, what do you mean? Because there is clearly a global assessment in MNA which sees the presence of dementia.
No, sir, their reliability cannot be, we suspect their reliability because of the hearing loss and the cognitive impairment.
No, hearing loss is okay. I am asking cognitive impairment. What did you exclude? Did you exclude a particular, I mean, doing an MMSE or a mini cog, or did you not do a scale for cognitive impairment?
Yes, sir. Actually, it's we did this study under the comprehensive pediatric assessment. We also see the cognitive impairment.
Yeah, absolutely. So what scale did you use for cognition?
Mini mental scale.
MMSE scale we are used to.
Okay, fine. And you also said comorbidities and polypharmacy, right?
Yes, sir.
So polypharmacy, which were the most drugs which were culprit, because drugs play a very important role in decrease in diet intake.
We didn't take into account the type of drugs, sir. More the amount of drugs only we take into account, sir. More than 5 drugs is categorized as polypharmacy.
Okay.
Less than 5 drugs we consider as a nil form.
But don't you think that drugs also affect the nutritional status because the intake can be affected?
Yes, sir. Surely, sir. It will be. But
okay.
Now my study, I didn't take it to the.
Okay. Thank you.
Okay. Thank you.
Okay. We will move on to next participant, Dr. Bharati. So, Dr. Bharati, you are here?
Yes, sir.
Yeah. Bimra, please stop sharing your screen. Dr. Bimra.
Good evening, one and all. Hello.
Yeah, Bimra, please can you stop sharing your screen?
Okay, sir.
Dr. Bimra.
Trying, sir. Trying.
It's not
So
going.
Bimra, also stop sharing the screen, please.
Yeah, that's what I am asking. So that Bharati will start sharing. Yeah.
Okay. Now it is okay.
Dr. Bharati, please start sharing your screen and then start presenting your poster. Yeah. So we are unable to see. There is something else is coming. You have started sharing.
Yeah, you'll have to share your window.
That green button.
Yeah.
Yeah. Yes. So make
Enable
it a full
editing.
screen.
Ma'am, enable editing on the top.
Yes.
Now come down, make it full screen. Yes.
No. This one.
The next one. No problem. Yes, ma'am. So you can start.
Good evening, one and all. My e-poster topic presentation is about clinical profile of urinary retention in elderly, conducted in Christian Medical College Hospital and Vellore, Department of Geriatrics. Background. Urinary retention can be defined as acute or chronic inability to voluntarily pass an adequate amount of urine on experiencing a sensation to micturate from the bladder. It is the most common problem encountered in elderly population, especially males. The etiology may be diverse and based on multiple factors. Objectives is to describe the clinical spectrum of urinary retention in elderly population admitted in a tertiary care hospital and to describe their clinical outcomes. Coming to methods, study design, retrospective observational study, and duration was 2 years from April 2018 to April 2020. All adult patients, elderly, aged more than or equal to 60 years, who were admitted with or developed acute as well as chronic urinary retention in the ward were included. Baseline characteristics. Out of 2,175 admissions, 50 patients had urinary retention, that is 2.2, both acute as well as chronic. 62% of the patients had diabetes mellitus. And in our study, we found that males have higher risk of getting urinary retention. That is, out of 50, 36 were males and 14 were females. That equals to 72%. It comes in the risk ratio of 2.5:1. Male is to female ratio is 2.5:1. And 56% of the patients presented with painless retention compared to painful one. It's going to the clinical presentation. The most common presenting complaints were inability to pass urine. That was observed in 74% of the patients. And the next common presentation was a delirium. That is, acute change in the mental status was observed in 56%. They have neither had fever or lower abdominal pain or had urinary symptoms. They presented only with delirium alone. And 38% of the patient presented with fever, and 36%, only 36% of them had lower abdominal pain, and remaining 34 had overflow incontinence. They were complaining like passing frequent amounts of small amounts of urine. They were complaining that they are having a polyuria. Coming to the risk factors, the most common cause of urinary retention was in males is benign prostatic hypertrophy, which was observed in 52% of these patients. And other common obstructive causes which we see in males mainly are prostatic cancer, which was seen in 6% of this patient, and others like phimosis and paraphimosis, urethral stricture, were observed in 4% of these patients. We have so many comorbidities. Among these were seem to be common with the urinary retention population. And next contributing risk factor was constipation. So 22 patients out of 50 were at constipation. That contributes to 44%. And 19 patients, multiple medications were also implicated as a risk factor for urinary retention. That contributes to 38%, especially anticholinergic drugs like nebulizations, like ipratropium, tiotropium that we are using in COPD, especially in males. They will also lead to urinary retention in this population. And the next contributing risk factor was neurodegenerative disorders. Particularly, they have an inability to articulate, and they were not able to tell their complaints as well. Like in case of Parkinson's, dementia, mixed as well as Alzheimer's and vascular and other demyelinating disorders were also contributed to 34%. And next is diabetic cystopathy. They contributed to 22% of urinary retention. And in females, particularly prolapse and pelvic masses and cervix and ovarian cancer also contributed to, that was only very less percentage, less than 3% in our study. And coming to the complications, 48% of them developed urinary tract infection. Out of that, 20% had urosepsis. And hydroerythronephrosis was observed in 16% of these patients, and 30% developed a renal disease, either acute kidney injury or a chronic kidney disease. And 34% of the patients had an overflow incontinence. So diagnosis is mainly by clinical examination. Clinical examination includes perabdominal and perrectal. Perabdominal means we have to palpate as well as percuss the bladder, and perrectal examination includes to look for any fecal impaction as well as prostatic hypertrophy. And along with PVR assessment is most important, the post-void residue assessment, either with ultrasound abdomen or like a bedside bladder scanner machine like this. So this we are using in R, which also helps in aiding to find the diagnosis as early as possible and for acute bladder decompression. So in this we can see for one patient which is having 420 ml as a PVR after, so who was presented with overflow incontinence. So treatment is bladder decompression by placement of urinary catheterization, either with 16 French or 18 French. All patients after this catheterization, they actually, if they have a significant PVR, they will be catheterized. So all patients were given trial of voiding, of which 25 patients failed, and they were requiring continuous bladder drainage. So 14% of them have got again readmitted, while 6% of them died due to urosepsis. So coming to conclusion, urinary retention is more common in elderly, especially in males. So identifying the risk factors associated with this urinary retention at the earliest in order to avoid complications like urosepsis and renal failure. Thank you.
Yeah. One question I want to ask you is, what is the commonest cause of urinary retention, non-obstructive cause in your study? Non-obstructive cause of urinary retention in your study. Have you understood the question?
Yes, sir. Sir,
Non-obstructive cause of urinary retention.
First, second to obstructive causes, non-obstructive causes, medications were coming as a non-obstructive cause as well as a neurodegenerative disorders.
How you assessed that it is non-obstructive retention? Have you carried out cystometry? The volume and pressure estimation will tell you. Cystometry.
Sir, usually if we have a significant PVR of more than 200, we'll usually refer to urology for urodynamic studies. So from that, if we are suspecting a non-obstructive cause, we'll be able to find out whether we will be ruling out any other disorders or any medications other than the obstructive. We'll be able to find out the causes of urinary retention.
What is the main cause of urinary retention in females?
Females, pelvic masses, any cancers or and also prolapse, cystocele or rectocele. And these are the
Obstructive causes, mostly
yes.
obstructive causes.
Yes, obstructive causes.
Okay. Prem Narasimhan, anything?
Yeah. So was a gynecological examination done in all the female patients?
Those who are presented with urinary retention, we'll do whether they are having prolapse, and sometimes we'll find the perabdominal pelvic mass itself. We'll be able to find out for some patients, or those who are already diagnosed with cancer, they will present later with urinary retention.
How important is a gynecological examination in an older adult, female older? Do you think it should be done for all older adults, females?
Yes, sir. It's very important because we'll have like this kind of urinary retention as one of the complication in this thing, and not only those, they'll also cause back pressure changes, causing infection, sepsis, and those things. So that's why gynecological evaluation in females is very important.
Okay, Dr. Shanti has asked one question. What is the volume of urine to consider as retention?
Sir, actually, it's individualized. We can't say a particular value for this. It will differ for each one of them.
But there has to be a common value. There has to be a range. No, how can it be individual?
Yes, sir. Yes, sir. More than like 200 to 300, we'll usually refer to urology, sir. And then if the patient is having a distress or in delirium or any back pressure changes or any hydroerythronephrosis, we'll definitely catheterize even more than 200 ml. So, but with 250 or up to 200, we'll ask them for a double voiding, and we'll ask for a urology opinion also.
Okay, thank you.
Okay, Bharati, thank you.
Thank you.
And we'll call the last participant of today e-poster session, Dr. Nabil Fayaz. So I think he's already sharing his screen. So over to you, Dr. Nabil. Are you there, Nabil? But I think it is not completely showing. It is. But Nabil, this is fine, I think. Yeah.
Can you unmute yourself?
Nabil?
Yeah, sir. Yeah,
Dr. Nabil?
yes, sir. I'm here,
Okay.
sir. Yeah.
Yeah,
Okay.
and another thing, you should have just waited for the discussion to finish and then uploaded your slide.
Okay, sir. Actually, okay, sir. Okay.
And this is not, I think there's a slide in motion, so we will not be able to see it. So you have to make sure that it is not a slideshow and just fix the slide, because we have to see the entire poster.
Yes, sir. Yes.
Don't make a slide. Yeah.
You fix
Yeah,
it
just
there.
fix
Okay,
it
sir.
here.
Yeah, I fixed it, sir. I fixed it.
Okay. Go ahead.
Okay, sir. Shall I start, sir?
Yeah. Start.
A very good evening to everyone. Myself, Dr. Nabil Fayaz, a junior resident from Department of Geriatric Medicine, Madras Medical College and Rajiv Gandhi Government General Hospital, Chennai. I'm going to present a case report on a drug-induced SIDH in elderly. Introduction: severe hyponatremia is one of the rare side effects of NSAIDs. Nausea and malaise may be the initial symptoms in patients with mild hyponatremia. However, serious CNS symptoms like headache, lethargy, altered sensorium, seizures, and coma can occur if the serum sodium level fall below 110 milliequivalents per liter. So, in the above mentioned symptoms of hyponatremia, it can also be caused by drugs like NSAIDs, like indomethacin, diclofenac, ibuprofen, meloxicam, etc. Now, coming to my case, he's a 60 years old male who presented to our OPD with complaints of nausea, hiccups, and giddiness for 3 days duration and altered sensorium for 1 day duration. There is no history of fever, no history of cough or expectoration, no history of chest pain, abdomen pain, or distension, no history of vomiting, loose stools, reduced urine output, or swelling of legs, no history of trauma or head injury. His bowel and bladder habits were normal. Past history is a known diabetic for 15 years duration, and he is on tablet metformin 500 BD. He is also a known case of systemic hypertension for 1 year duration on tablet amlodipine 2.5 mg 2 OD. He is not a known case of CAD, bronchial asthma, renal disease, or seizure disorder. There is no history of previous surgeries in the past. Drug history: patient had history of frequent use of over-the-counter analgesic medication for his generalized malaise and backache with tablet ibuprofen 400 milligram daily dosing for past 3 months duration. Previously also that he was taking that tablet for 3 years duration, but occasionally 1 or 2 days in a week. But his dosing, it was increased in the past 3 months due to his increased pain intensity. Personal history: the patient is on mixed diet. He is not a known smoker or alcoholic. So on general examination, the patient is conscious, afebrile, not dyspneic or tachypneic, no pallor, no icterus, no cyanosis or clubbing, no signs of volume overload like pedal edema, raised JVP or ascites, no signs of dehydration. His vitals were stable at the time of presentation. System examination: cardiac and RS were normal. Per abdomen is soft, no distension, no organomegaly, bowel sounds were heard. CNS: he was in an altered mental state. His cranial nerves were normal. Motor, sensory, and reflexes were also normal. So on administering this CAM score, that is confusion assessment method score, so it was found as the score is out of 3 by 4, and the patient was found in acute confusional state. On examining his cerebellum, the rhombox sign was positive. Tandem walking is also impaired. So investigations, we did all the basic investigations on the first day, like CBC, renal parameters, liver profile, lipid profile, ABG, thyroid, and serum cortisol. So everything is within normal limits. His random blood sugar was 220. His fasting and postprandial the next day is 186 and 279. The urine routine, urine PCR, urine acetone, blood and urine culture, everything is negative only. Viral markers is also negative. So our serum sodium report on the first day, it came as 106. We sent the value for, we sent the sample for reconfirmation. That was 102 on the same day itself. His serum potassium is 3.9, uric acid is 1.2. So in the serum, in the calculated serum osmolality is 231 milliosmoles per kg. Next day, we started evaluation for hyponatremia. His urinary sodium is 67, urinary potassium is 7.9, urine urea is 493, creatinine is 25.9. Fractional excretion of sodium is 16%, and fractional excretion of urea is 69%. Urine osmolality is 290 milliosmoles per kg. His cardiac status, like ECG and echocardiography, it was normal. Ultrasound abdomen and pelvis, it showed normal study only. Chest X-ray, CT chest and CT abdomen is also normal only. So CT brain showed age-related cortical changes. Now coming to the discussion part. So his investigation revealed severe hyponatremia. Hence the workup initiated for the same. Patient was found to have euvolemic hyponatremia. So further additional investigations were done, and it was clinically diagnosed as a case of syndrome of inappropriate diuretic hormone. So further analgesic intake in this patient was withheld. Patient was treated with free water restriction, 3% hypertonic saline for first 3 days, then OHS, antihypertensives, and other supportive measures. Patient's clinical condition and serum sodium levels improved day by day, and the patient became symptomatically better in 5 days. So patient was discharged hemodynamically in a stable condition and advised fluid restriction to avoid over-the-counter analgesics to continue OHAs and antihypertensives with normal salt diet. So follow-up was done after 2 weeks and 4 weeks, during which the patient was clinically better with normal serum sodium levels. So this is the criteria, Schwartz diagnostic criteria for diagnosis of this SAIDs. So first is decreased measured serum osmolality, clinical euvolemia, urinary osmolality more than 100, urine sodium more than 40, normal TFT, adrenal, normal renal function. There should be no use of diuretic agents in the past, no hypokalemia or no acid-base disorders. And we have supporting diagnostic criteria also, like serum uric acid less than 4, blood urea nitrogen less than 10, fractional sodium excretion more than 1% and fractional urea excretion more than 55%. So hyponatremia is one of the most common electrolyte abnormality in elderly people. So it may be due to polypharmacy, comorbid conditions altering the fluid balance of the body, or maybe due to age-related changes in the body homeostasis. So NSAIDs are one of the rare cause of hyponatremia. We often fail to offer appropriate attention to drug-induced hyponatremia, especially due to NSAIDs, which are often used in elderly population. The mechanism by which NSAIDs cause hyponatremia is by reduction of renal prostaglandins. So prostaglandins, it inhibits the activity of antidiuretic hormone. So if NSAIDs inhibit prostaglandins, ADH levels will increase, thus causing free water retention and hyponatremia. Then ADH levels, it becomes high and relatively non-suppressible if NSAIDs are used along with other drugs which causes this SAIDs. So conclusion, the cause of SAIDs in this case is attributed to NSAID, since the criteria for SAIDs is fulfilled in this patient and other causes of SAIDs and euvolemic hyponatremia are ruled out. So even though limited literatures are available for NSAID-induced hyponatremia, this diagnosis should be kept in mind in patients presenting with euvolemic hyponatremia with history of chronic NSAIDs use. Since NSAIDs are frequently used in older population, a proper drug review is crucial during initial hospital administration, because discontinuing the medication is the first step in the management of drug-induced hyponatremia. Thank you. These are my references for my case report. I would like to thank my professor, Dr. Shanti Madam, Dr. Usha Madam, and Dr. Uma Kalyani Madam for helping me in this presentation. Thank you.
Okay, the SIADH you are attributing to analgesic therapy.
Yes, sir. Yes, sir.
What made you to think that it is related to analgesic therapy?
Actually, SAIDH, we have so many causes for SAIDH, sir. Like
so many causes are there, but you are attributing
yes,
it to analgesic therapy. What made you to think in this condition?
Yeah, because other causes of SAIDH were ruled out, sir, like malignancy, infections, everything were ruled out in this patient.
Simply in the MRI, you mentioned that atrophy of the brain is present.
Yeah, no, it is just age-related cortical changes only, sir.
Yeah. First thing that the old age, the secretion affected is ADH only.
Yes,
in old age people, when atrophy of the brain is present, age-related atrophy is present, first hormone that is affected is ADH only. That is described in textbooks.
Okay.
And
okay,
that may be relation, but the relation to analgesic therapy is controversial now.
Actually,
what do you say?
There are a few literatures available.
And the patient is also diabetic and hypertension.
Hypertension, yes, sir.
And patient is amlodipine is using.
Yes, sir.
Amlodipine also can cause vasodilatation and diuresis also.
Yes, sir. Yes, sir. Even metformin, there are literatures available where metformin also can cause SAIDs, sir. Like it will decrease the action of NaCl receptor, NaCl transporter in the distal collecting tubule,
so many causes are there, but
so many
single attribution to that analgesic nephropathy, okay, it is somewhat doubtful. What do you say, Dr. Prem Narasimhan?
Nabil, you haven't been able to answer why it is an SAID. Why do you think it is? Because it has multiple It
Yes,
has
multiple drugs,
causes,
but
no?
this NSAID it may have aggravated the other drugs. Like it might be an add-on effect to metformin and amlodipine. Because
Okay.
metformin also can cause SAIDH by increasing the urinary excretion
Yeah,
of
but your
sodium.
focus is on the NSAIDs in the description also, no?
Yes,
It's not.
but no, sir, actually the patient he was taking metformin for 15 years duration, but his this symptom of hyponatremia, it is only for 1 week after taking this analgesic, chronic analgesic intake for 3 months duration. That's why I attributed it to analgesics.
Yeah, so that's what Narayan sir was asking, you know, why do you saying that it's because of that? Okay. Okay. So what is the safest NSAID in elderly?
We can use paracetamol, sir.
Paracetamol. What is the maximum dose you can give in a day?
Maximum dose we can give up to 2 grams, sir. Maximum dose 2 grams in elderly population.
2 grams.
Yes.
Okay.
In
And which
adult
is
population we can give up to 4 grams, sir. In elderly, I think we can use up to a maximum of 2 grams.
okay. And which is the most unsafe NSAID to give in older adults?
I think it is diclofenac or.
Like, okay, what are the common side effects? Life-threatening side effects.
Common side effects of NSAID.
Life-threatening side effects of NSAID in older adults.
Life-threatening. It can cause cardiac failure, sir. Like then it can cause acute tubular injury of the renal tubules, thereby causing renal failure.
Okay. What about GI bleed?
Yes, GI bleed also it's common.
So GI bleed will be absolutely most life-threatening. No, other things will still take time. Okay.
Yes,
one of the important thing in elderly people, those if they are using RAB or angiotensin blockers, if you add analgesics, that is more dangerous.
Yes,
that point we have to keep in our mind.
Yeah,
Along with antihypertensives like ACE inhibitors, if you add analgesics like diclofenac, that is more harmful.
More harmful, yes, sir. That is the point actually I wanted to share here, sir.
Okay.
Okay. Thank you.
Right. Thank you.
Okay,
Thank you.
Thank you very much. So we have come to the end of this. We have come to the end of e-poster, sir. So now that is the end of scientific sessions today also. So all the delegates and all the faculty. So that is the end for today from Hall A. Hall B already is ended their scientific programs. See you back tomorrow early morning 9 a.m. sharp, the same venue.
Thank you.
Thank you. Thank you, Dr. Prem Narasimhan, and thank you, Dr. Chandrasekhar.
Sure, sir.
And this is a present way of seeing people like this, and young people are presenting. And we have to encourage young people to present so many posters and platform presentations. This is very, very important. We have to encourage younger people.
Tomorrow also one oral presentation session, one e-poster session is there, sir.
Yeah. Okay.
So
Okay.
we will contact you by phone, WhatsApp, and
Okay.
your results also send it by WhatsApp, sir. In the any of the group. So
Yeah.
have a
Krishna
mutual
is
talk
active.
also.
Krishna.
Like other judges also doing same. So that in the validatory function we will announce the results.
Okay, right.
And the participation certificate also we will email them to the direct candidate.
Yes.
Thank you.
Okay.
Thank you.
Okay,
Thank
Narasimhan
you.
sir, and okay,
Thank
Narayan
you,
sir,
sir. Thank you.
and all other dignitaries who are presenting all the while from morning. Thank you very much. You are patient hearing and helping in the difficult situations also. Thank you. Thank you all.
Thank
Bye-bye.
you.
Good evening.
Right.
Sir, we are closing up for today, sir.
Yeah, sir.